Cardiodiabetic Society, a confluence of minds dedicated to advancing science and practice of cardiovascular and diabetes care. I am Dr. Anushka Garg,
And I am Dr. Mudita.
Junior Residents, Department of General Medicine, and it's a privilege to serve as your host for this enlightening journey. So, without further delay, let us begin this academic journey together. Our first session of the day focuses on a topic that continues to puzzle and challenge clinicians across the globe: ketosis prone diabetes, a unique and fascinating subtype that blurs the traditional boundaries between type 1 and type 2 diabetes. We are honored to have Professor Rajneesh Joshi sir, Professor and Head, Department of Medicine at Aiims Bhopal, who will be joining us via online platform to guide us through this intriguing subject. Please also welcome the chairperson for this session, Professor Ravikant sir, Head of Department of Medicine, Aiims Rishikesh, Dr. BALA-G ma'am, Additional Professor, Department of Biochemistry, Aiims Rishikesh, and Dr. Akhilesh sir, Assistant Professor, Department of General Medicine, Aiims Rishikesh.
So I think without delay, we can straight away go to the video by Dr. Rajneesh Joshi.
To this bright Saturday morning at Rishikesh. I'm currently at Bhopal, and I apologize for not being able to be there. But I hope that next few days at Rishikesh would be really educating and enlightening as far as the Cardiodiabetic Summit is concerned. So I have a brief presentation on ketosis-prone diabetes mellitus, and I'll take it up from here to explain how this particular entity is different from typical type 1 diabetes mellitus, which is ketosis-prone, but it's has certain similarities with type 2 diabetes mellitus. So my talk is focused on definition and overview, understanding ketosis-prone diabetes as an emerging clinical syndrome. We'll look briefly at pathophysiology and classification, typically the AA-beta classification system. We'll describe clinical features and distinguishing features from type 1 diabetes mellitus, and briefly we'll move around diagnosis as well as management of this condition. So ketosis-prone diabetes mellitus is a heterogeneous syndrome. It is characterized by an initial presentation of diabetic ketoacidosis in individuals who are antibody negative, but they often achieve insulin independence after initial treatment of diabetic ketoacidosis. So also known as flat brush diabetes, it presents with unprovoked ketoacidosis in individuals who are middle-aged and obese, not a typical phenotype associated with type 1 diabetes mellitus. And we are seeing it more frequently now as we are recognizing this particular phenotype better. So let's understand the A-beta classification system. Now A stands for autoimmunity and beta stands for beta cell function or dysfunction. So individuals who are autoimmune positive, say GAD antibodies, insulin antibodies, or ZNT8 antibodies, require lifelong insulin therapy because they also have a more severe beta cell dysfunction. So A plus beta negative is a typical kind of presentation or typical type of pathophysiology which is associated with type 1 diabetes mellitus. In contrast, we have individuals who may be A negative, that is, they are antibody negative, and beta cell function is relatively preserved. So they may present as beta minus, but by the time they recover, they become beta positive. So at time of recovery, their C-peptide levels are not as low as they were there during initial presentation. So since these individuals have obesity, since these individuals are middle-aged, often there is a strong family history. These individuals often have a more severe insulin resistance. This more severe insulin resistance makes them ketosis prone. So there is an activation of ketogenesis, point number 3 here. And this activation of ketogenesis essentially is shifting of metabolism from a glucose predominant metabolism to now lipolysis metabolism, leading to excess production of ketones. So this presents them as severe hypoglycemia and ketosis as an initial presentation of unprovoked diabetic ketoacidosis. Now, beta cell function fluctuates. The beta cell function may be severely compromised initially, and this severe initial compromise is also compounded by glucotoxicity and lipotoxicity. But as the insulin based regimens for management of ketoacidosis kick in, gradually their beta cell function recovers and they often can become an independent of insulin therapy subsequently. So, 65% of these ketosis prone diabetes individuals happen to be men. Typical age is 40 to 50 years, and about 85% or more may be overweight or obese. So, initial presentation is severe hyperglycemia. Typically, glucose is in range of 500 to 700. HbA1c levels are higher. So, typical HbA1c is say 10 to 14% initially, and ketones are present in blood and urine, signifying a particular metabolism which these individuals are prone to. Now, clinical course is a unique recovery pattern. So, this unique recovery pattern would be missed if these individuals are not closely followed up, because progressively over a period of 3 to 6 months, these individuals will tend to develop slightly elevated C-peptide levels and can achieve insulin independence and can be managed with diet, physical activity, and sometimes oral hypoglycemics. Long-term outcomes usually resemble type 2 diabetes mellitus. That is, if you have an aggressive lifestyle as well as dietary measures and you can achieve a good amount of weight reduction and a sustained weight reduction, these individuals can become not only insulin free, at time only drug free, but once these initial lifestyle measures which have kicked in, once there is a relapse, these individuals tend to go back to where they were, that is requiring more insulin as they were requiring earlier. So, acute presentation of diabetic ketoacidosis, a recovery period which is characterized by improving beta cell function, has the clinical dilemma of initial treatment phase, which is DKA treatment, and then potential remission, which is often confusing as we follow them up further. So, diagnostically, initial laboratory parameters, as already discussed, are of much elevated glucose, elevated A1C levels, low very C-peptide levels. pH levels are low because of ketosis prone, and ketones would be seen in urine. And that's a typical key metabolic parameters. And there's a metabolic profile also of elevated glutamate, reduced glutathione, amino acid metabolism abnormalities, which are typical of insulin deficiency. So if you tabulate ketosis prone diabetes, which is in the first column here, and contrast them with type 1 and type 2 diabetes mellitus for a better clarity, you would find that they have an autoantibody negative profile like type 2. C-peptide levels are low or normal, which is somewhat like type 1. BMI is higher, which is like type 2. Age of onset is middle-aged, which is typically like type 2, but insulin independence is often achieved. So they may develop diabetic ketoacidosis or could even present catastrophically with diabetic ketoacidosis, but the phenotype is much different from type 1 diabetes. An individual with type 1 diabetes is young, thin, requires insulin, and often has an age of onset which is at a much younger age group. In contrast, we have individuals with type 2 diabetes mellitus who are middle-aged and who have a much higher body mass index. So BMI is a bit moderate, but still in overweight or obese range, and age of onset is late as far as this phenotype is concerned. So how would you acutely manage? So acute management will be no different from a management of type 1 diabetes mellitus. So there's a kid which is shown in the picture, but individual with ketosis prone diabetes is unlikely to be a kid. That person is more likely to be between age group of 30 to 40 years. We would use the same fluid resuscitation, same protocols for insulin therapy, and same protocols for electrolyte management as we use for type 1 diabetes mellitus initially. So acute management protocol is no different from type 1 diabetes mellitus. The key issue is long-term management strategy. So unless you follow up individuals with type 1, with individuals who had evidences of who had diabetic ketoacidosis and follow them up further, you would realize that some of them are not actually thin-built individuals who are obese, middle-aged, and once your aggressive lifestyle measures kick in And if you have measured their C-peptide levels on follow-up, you would realize that some of them now have a recovering beta cell function. When they have recovering beta cell function, which is usually recognized between third and 6 months and even later, there may be a transition possible from insulin to oral therapy. So every individual who has had or hasn't had diabetic ketoacidosis but is overweight or obese should undergo a lifestyle modification program and a regular monitoring process so that you can have follow-up visits, you can assess their A1C levels and assess their beta cell function also on follow-up. So recovery patterns, there is some degree of heterogeneity. Most individuals can be insulin dependent. A few individuals can be insulin dependent, but most of them become independent and could be controlled on oral medication alone. So again, the genetic, metabolic profile and prevention strategies of these individuals quite mirror type 2 diabetes mellitus. The genetic predisposition, family history of type 2 diabetes mellitus increases risk significantly. So there could be a strong family history, and there could be individuals in the family with similar profiling of a type 2 diabetes mellitus. So metabolic factors such as central obesity and insulin resistance play their part, and metabolic syndrome components accelerate the disease progression. Sedentary lifestyle and poor dietary habits also increase the risk. Prevention strategies are important because, especially in individuals who are family members of individuals with type 2 diabetes mellitus, they may be younger, but they may be having a significant degree of adiposity and hence insulin resistance. And aggressive lifestyle measures from the very beginning can actually prevent this type of ketosis prone diabetes mellitus. So what are clinical pearls and what are key considerations for this? So firstly, this is a unique diabetic phenotype requiring individualized management approach, and recognition is important because it can prevent misclassification and can have an impact on their long-term insulin dependency, so that we could know that it's possible for us to make them insulin independent. Diagnostic challenges are that initial presentation is like type 1 diabetes mellitus, require autoantibody testing to differentiate accurately. C-peptide levels may be very low initially, but on follow-up we find that their C-peptide levels have recovered. Management considerations are important because it requires a real close follow-up to understand that their beta cell functions are now improving, so that we can avoid a premature acute phase. And patient education is crucial because once aggressive lifestyle measures and oral drug therapy at times as well as weight reduction kicks in, it's possible to have a gradual weaning based on metabolic stability. Globally, since we are recognizing this ketosis prone diabetes mellitus, this is a unique phenotype we can keep in mind, and it helps us think beyond the typical phenotypes of type 1 and type 2 diabetes mellitus, that now we could also think of that individuals who have survived diabetic ketoacidosis by our aggressive fluid insulin management, some of them could now also become insulin independent over a period of 3, 6 or even 12 months period. It offers us research opportunities and it offers us educational opportunities as well as far as patient management is concerned. So I'll end my brief presentation here. I wish all the best and happy networking to all speakers as well as participants at Aiims Rishikesh, and I hope Cardiodiabetic Society continues to progress and continues to disseminate knowledge as it has been doing over the years. So I'll end here. Thanks a lot, and thanks for giving me this opportunity to shed some light on this upcoming topic. Thank you.
So I think session is concluded, so we can go ahead with the felicitation program.
May I request Dr. Namrata Gaur ma'am to felicitate Professor Dr. Ravi Kansal. May I also request Dr. Mukesh Bhairava sir to felicitate Dr. Bela Goel ma'am. And also may I request Dr. Mukesh Bhairava sir to felicitate Dr. Akhilesh sir. Now, we move on to our next session, Cardiorenal Syndrome, Clinician's Perspective for Management. To shed light on evidence-based management of cardiorenal syndrome from a practical clinician's point of view, we have Dr. Bala-Murugesan sir, Additional Professor at Department of Medicine, JIPMER, who would be joining us in online platform to guide us through this intriguing subject. Let us also welcome our chairpersons for this session. Dr. Namrata Gaur ma'am, Additional Professor, Department of City VS, Aiims Rishikesh, and Dr. Sharon Kandari ma'am, Associate Professor, Department of Nephrology, Aiims Rishikesh.
Good morning, sir. Is my voice audible to you?
Yes, yes, please.
Is the screen visible, sir?
Yeah, screen visible. My voice is audible or not?
Yes, sir. Your voice is audible.
Okay, thank you. Then proceed.
You can start the presentation, sir. We'll change the slides for you as soon as you instruct us.
Okay, okay. Can I start?
Yes, sir.
Yeah. Good morning, one and all. It is my great pleasure and happiness to be part of the program, 6th edition of the Cardiodiabetic Society. I thank Almighty and Dr. Ravikant ji for giving me the opportunity. I would have loved to come there personally, but however, due to some personal reasons, I am unable to come and I will try to cap up. Anyway, Dr. Ravikant ji has given an important topic. In a day-to-day clinical practice, we see acute kidney injury. This is one of the important problem which we see in the day-to-day clinical practice whenever we see any rise in elevated serum creatinine, and we are able to recognize the problem cardiorenal syndrome. And in acute kidney injury, nowadays they call it the pox of acute kidney disease. There are many diseases which involve cause acute kidney injury. But when we recognize the problem of acute kidney injury, by the time the serum creatinine rises, it is a very late stage. So better understanding of the physiological mechanism, what is being implicated, and what is the treatment modalities which are available, and latest advancement, and what is the mechanism, because we start recognizing the cardiorenal better because of various investigations, various molecules, that is a biomarker, all those things are available. So in the next 10 to 15 minutes, I will be talking about cardiorenal syndrome, what different type of cardiorenal syndromes are available. Before 20-25 years, we are giving that the patient is having a acute kidney injury, and if the urine output is there is an indication for dialysis, we will go for dialysis. But nowadays, because of the better understanding of the pathophysiological mechanism implicated in the cardiorenal syndrome, and we are able to provide some treatment because there is a complex interplay between the kidney and the failing heart. There is a one organ dysfunction can cause other organ dysfunction, either acutely or chronically. So we are having a 5 type of cardiorenal syndrome. One type 1, type 2 is the cardiorenal syndrome. Type 1, type 2, type 3, and type 4 is the renocardiac syndrome, and type 5 other causes. So before going into the cardiorenal syndrome per se, we will see briefly about the what are all the prevalence of AKI, because that will be a set induction for the audience, so that they will be able to know what is the magnitude of the problem of acute kidney injury. In the acute kidney injury, what are the rare causes and what are the cardiorenal syndrome, all those things we will see. So in a data, in our Indian data, which is done by Prasad and Narayan et al. From 1990 to 2008, the prevalence of community-acquired AKI is 4.4 per thousand admissions. These are hospital data only. We don't have data from the public. The mortality rate for community-acquired AKI is ranging from 11%. However, the studies report the incidence of AKI in hospitalized patients in South Asia to be approximately 24%. That is the more important thing. So, the hospitalized patient who seek medical advice because of decreased urine output or breathlessness or fluid overcharges, a significant mortality. That is our target, because our India is becoming a diabetic capital, and there is also an alarming increase in the chance of hypertension. So we have to control both these non-communicable disease menaces and educate the public about the serious implications of the problem, and we have to reduce the occurrence of these complications, because the heart failure with reduced ejection fraction is one of the important things which will cause the serious complications. Yes, next slide. Next.
Sir,
Next.
am I
can
audible,
take
sir?
myself or, so next slide, please.
Yes.
Yeah. Epidemiology continuation. The outcome mortality rate of patients with AKI is between 20 to 30%. The most common comorbidities, I already told that hypertension and diabetes are the most common comorbidities. So we have to tackle these both non-communicable diseases effectively to prevent the occurrence of the complication. So, however, AKI not only occurring because of these problems, and that is due to medical, surgical, obstetrical settings. In the range of, you can see the medical setting only 87%, followed by 7.3%. Surgical problem, sepsis and other compartment syndrome, abdominal compartment syndrome, all those things can cause. It is only contributing for 7.3%, and in obstetric setting it is only 6.6%. The most common cause of acute kidney injury in our medical setting is sepsis, followed by tropical fever. The tropical fever conditions like leptospira, dengue, and other acute fever illness can lead to acute kidney injury, either because of disease per se or because of the drugs. Next, please. So, first we should know what do you mean by acute kidney injury, and because by knowing this only, sometimes I already told that the biomarkers, particularly the biomarker which we are using, serum creatinine takes much longer time. So we have other marker also. So basically it is absolute decrease in the renal function over hours today, resulting in tension of the nitrogenous waste product, dysregulation of the extracellular fluid volume and electrolytes. It encompasses the entire spectrum of syndrome from minor changes in the markers of renal dysfunction to the requirement of renal replacement therapy. So sometimes patient may come with only creatinine elevation of 1.3, 1.4, and they don't require any renal replacement therapy. Addressing the causes may eliminate the problem. Sometimes they come with anuria, fluid overload, and they may require various renal replacement therapies like peritoneal dialysis or hemodialysis like that. Next, please. So again, how we will divide by define the acute kidney injury by value of serum creatinine. From the baseline, serum creatinine increase in the serum creatinine value more than 0.3 milligram or 26.3 millimole within 48 hours, or increase in serum creatinine to more than 1.5 times baseline. So you have to remember that previous baseline creatinine was 5 milligram. If it is increased to 1.5 times baseline, it is known or presumed to have occurred within the prior 7 days. And urine output, there is a reduction in the urine output which is less than 0.1. We know that 1 ml per kg per hour is the normal urine output. When the urine output reduces to less than 0.5 ml per kg per hour, and it is called acute kidney injury. So it does not mean that all the patients with acute kidney injury will have will need renal replacement therapy. You know that the staging of acute kidney injury, 1.5 to 1.9 baseline is stage 1, 2 to 2.9 times from the baseline is stage 2, more than 3 times from the baseline, or increasing serum creatinine to more than 4 milligram per deciliter, or initiation of renal replacement therapy. So most of the time in our hospital setting, because of severe sepsis or any tropical illness, we get the patient like this. So the main point is to prevent these complications and to give relief for the patient. able to prevent the progression to stage 3. If they come at stage 3, we have to address the basic problem. Next one. Next slide. Next, please. Thank you. Next one. Next. Yeah. Next. No, no, no. Previous one. Previous. Yeah. So we can see in this Venn diagram, there is a AKD and CKD, acute kidney disease and chronic kidney disease. The acute kidney injury, previously with acute kidney injury, that is a part of. So there may be an acute kidney injury, majority will contribute for acute kidney disease. Sometimes the patient may be having a chronic kidney disease, but however, they can have an acute worsening of the renal function. So it can be present in the patient with chronic kidney disease also. So AKI is the terminology which will present both as AKD as well as AKD. Next. You can see, basically, you see that the stages defined by creatinine and urine output are surrogate markers, because by the time we get an elevation of serum creatinine, and it is a very late stage. So we have other markers such as neutrophil gelatinous glycocaline, kidney injury molecule 1, interleukin 8, and fatty acid binding protein, and cystatin. There are various other markers of that. But what is the problem with the marker is, we are not able to use the markers routine in a routine clinical practice. That is pragmatism. Pragmatically, we are not able to use these markers in our day-to-day clinical practice. So, patient ultimately lands up with a rise in urine serum creatinine and anuria or fluid overload or serum creatinine more than 4 milligram. They reached already stage 3 kidney disease. Next one. So this is the time level at which these markers start rising. Serum creatinine takes around 48 hours to rise after an insult to the kidney. Kidney injury molecule is a non-specific marker and takes 24 to 48 hours to rise. And plasma or urine neutrophil gelatinase lipocaline, which also is another marker, which is a promising marker, but the cause is the most important problem. Interleukin 8 and the fatty acid, liver fatty acid binding protein, first to rise within 6 hours. Again, the problem is cause, and we are not done the research in the large scale. So, over a period of time, these markers may be play a significant role in earlier identification of acute kidney injury. Next one. So basically, what are the complications? Why we need to address acute kidney injury? Whenever there is acute kidney injury, there is a rise in serum creatinine, fluid overload, and cell debris release disturbed homeostasis. There is this alteration in the homeostasis, cell homeostasis, result in various complications affecting the various vital organs of the body. Namely, because when the urea level rises, it can cause uremic toxicity, can cause uremic encephalopathy, and because of the inflammatory mediator, the patient will be cleared land up in the altered sensorium. Because of the fluid overload, and it can cause arrhythmia and hyperkalemia. And in the lungs, again, cause fluid overload and breathlessness, and liver dysfunction can also occur. You know that it can lead to liver enzyme elevation, and chronic kidney disease patient will have a bone marrow suppression and immune system side of cytopenia and systemic inflammation. So it affects multiple organs. We think that whenever a patient comes, we always think that because of the kidney dysfunction, patient develops breathlessness, fluid overload. It is not that. It causes uremic encephalopathy, it causes liver dysfunction, it causes fluid overload in the lungs also. Next slide. So before going into the cardiorenal syndrome per se, many times we get some of the rare things. What is pseudo AKI? AKI? What is atypical AKI? When can we use diuretic? Very important thing, because diuretic means that sometimes in a prerenal AKI, diuretics are more worsening the kidney function. Lab errors. Sometimes different patient sample has gone, or sometimes that the reagent is having a problem. So different lab values, different lab errors. Daily variation in serum creatinine due to difference in the diet and activity may be as great as 10%. Finally, apart from these lab errors, endogenous chromosomes like bilirubin, ascorbic acid, and uric acid, and exogenous chromosomes and drugs, cephalosporin, trimethoprim, cimetidine may interfere with the creatinine assay. So when we are getting irrational or fallaciously elevated creatinine values, we should think all this. Next. What is atypical AKI? So, for example, patient coming with the trauma, we are giving, or any sepsis, we give large IV fluids to lower the creatinine level, or sometimes following a massive blood transfusion will result in the serum creatinine more closely mimicking the donor blood rather than the original patient. Next. So this is a brief overview for acute kidney injury. Because it is a topic, we wanted to see there is a sudden and severe reduction in the blood pressure. That is one of the important mechanisms of the cardiorenal syndrome. Blood loss, dehydration, heart failure, and intrinsic renal causes like drugs and toxin, and post-renal causes like benign hypertrophy, cervical cancer, metastatic, meatal stenosis or retroperitoneal fibrosis, all those things. So our concern is cardiorenal syndrome. We will go into the cardiorenal syndrome section. These are the very rare causes like BALA-G nephropathy, warfarin-induced nephropathy, acute oxalate nephropathy, drugs abuse like cocaine, ecstasy, opioid, and drug-associated crystalluria and acyclovir because they give patients with Bell's palsy, these are all the rare, and abdominal compartment syndrome. And following a fracture, we also get acute kidney injury for atherosclerotic renal disease. Following. Yes, next. So what is cardiorenal syndrome? Coming to the cardiorenal syndrome per se, basically it encompasses disorders that acute or chronic dysfunction in one organ. That means cardiac failure can cause renal function, renal failure can cause. So we have a cardiorenal syndrome and we know cardiac syndrome. It can induce acute dysfunction. No. So it represents the confluence of heart and kidney interaction, including hemodynamic crosstalk. So basically, even though cardiorenal syndrome is currently gaining popularity, way back in 1836 by Robert Bright, who outlined the significant cardiac structural changes seen in patients with advanced kidney disease. Next, please. Basically, there is a complex interplay between one organ dysfunction can lead to other organ dysfunction. There is a hemodynamic alteration between because of this problem and other inflammatory markers and neurohumoral markers like renin activation of the renin angiotensin aldosterone axis, sympathetic system activity, and various. Based on this, different type of types of the cardiorenal syndrome, what we are going to see. So even in a cardiac failure, we know that inflammatory pathology is there, activation of sympathetic overactivity, and RAS activation. All those mechanisms are a main mechanism which causes worsening of heart failure. Because of reduction in the cardiac output, patient can develop a reduction in the plasma flow and subsequently they can develop a kidney injury. Similarly, when they have acute kidney injury, they can also develop fluid overload and cardiac. That is called renal cardiac syndrome. Next, please. So, the cardiorenal dysregulation leads to CRF, in which therapy to relieve symptoms of heart failure is limited by further decline in function. That is a very important part. When we start using the diuretic to relieve congestive symptoms, it may further aggravate renal dysfunction. So we have to judiciously use the diuretic rather than improve the underlying of kidney abnormality. So by targeting the therapy, we will. So most of the patients will be having diabetes and hypertension. Some of the drugs we cannot give at the point of when the creatinine elevation is there. So cardiorenal syndrome is divided into two major groups: cardiorenal and renocardiac. In cardiorenal also, cardiorenal 1 and 2, renocardiac 1 and 2. Type is the next we will see also things. Next. So these are all subtypes of cardiorenal syndrome. Type 1 cardiorenal syndrome, that is called acute cardiorenal syndrome, heart failure resulting in AKI. Okay, patients primarily having a heart failure, reduced ejection fraction, ACS resulting in cardiogenic shock, and AKI. Acute heart failure, decombined heart failure resulting in AKI. So type 1 is patient presents with acute coronary syndrome, patient develops acute kidney injury. Acute decombined heart failure patient developing acute kidney injury. This is a classical example of type 1 CRS. Okay, type 2 CRS is patient who is already having a chronic heart failure. Their ejection fraction is 25, 30 like that. Those patients develop kidney injury. It may be because of reduction in the cardiac output leading into renal plasma flow, or other drugs which we are using to treat the cardiac failure also may be the cause. Then these are two important things. And type 3 is acute renal cardiac syndrome. Acute renal cardiac syndrome is AKI patients develop cardiac failure. Heart failure is setting of AKI from volume overload, inflammatory stress. That is because of inflammatory stress and metabolic disturbance in the uremia. These are the important things. So basically, this is renal cardiac syndrome. We get majority of patients like renal cardiac, but proper recognition of the renal cardiac syndrome is very, very vital in preventing the deterioration of the cardiac function. Type 4 CRS is chronic kidney, because this is very important. Nowadays, we start recognizing this chronic kidney patient developing chronic heart failure. Particularly, there is the understanding of the CKD patient, they develop a pulmonary hypertension. That is the most important thing. Apart from left hypertrophy and heart failure from CKD, cardiomyopathy is also there. Because they will have a long-standing hypertension. Because of the uncontrolled hypertension, they develop a cardiac failure. So it is easy to remember. Type 1 is heart failure, that is a type 1 acute CRS. Type 2 is chronic heart failure leading to CKD. Type 3 and type 4 is renal cardiac syndrome. Acute kidney injury leading to heart failure. Type 4 is chronic heart failure leading to CKD. So, CRS1, CRS2. CRS3 is renocardiac, acute renocardiac and chronic renocardiac. Type 5, that is very important because many times we are not Systemic process like amyloidosis, sepsis, or cirrhosis, those patients they develop, and patients cirrhosis they develop a kidney disease. There is separate entities that is called hepatorenal syndrome, but that we are not going to discuss because again in that hepatorenal syndrome it is a diagnosis of exclusion. Again, it is called functional kidney disease. Patient is having a chronic liver disease and they develop the disease. They now got a type of cardiovascular syndrome. Next one.
Sorry to interrupt, sir. Sir, 2 more minutes in the session, sir.
Okay, I will
Yes,
finish.
thank you, sir.
Okay.
Thank you.
There is a hemodynamic pathophysiology, there is a failing gut and reduced forward flow, renal hypoperfusion, activation of the RAS system, elevated central venous pressure, renal venous congestion, increasing in the intrarenal resistance. All those things contribute for the type 1 CRS. Next, please. This is the most important slide, type 1 CRS. We know that ischemia, cardiomyopathy, arrhythmia, because of reduction in the cardiac output, reduction in the renal perfusion, increasing renal venous pressure, and there is the activation of the arginine vasopressin, sympathetic nervous activation, RAS activation. Apart from there is the inflammatory markers and renal hypoperfusion, tubular atrophy, decreased VFR, decreased oxygen delivery, diuretic resistance. All those things contribute for the acute kidney injury in the type 1 CRS and setting up acute kidney failure. Next one. In the renal cardiac syndrome, there is the reduced VFR is there. There is the sodium and water retention, loss of nephron, albuminuria, and fibrosis, inflammation. All those things lead to reduced cardiac output, increased central venous pressure, loss of vasoregulation, maldistribution of blood flow, resulting in the encephalopathy, liver dysfunction, GI dysfunction, and fluid over the lungs. This is renal cardiac syndrome. I told type 3 and type 4. Next one. So basically, inflammation, activation of system, a same mechanism will be playing in the report. Next one. Treatment strategy. So as all you always know, there is a fluid overload. We will use diuretic and neurohumoral modulation like a tolvaptan. That is the more important thing. Selective V2 receptor antagonist, process which is aquaphoresis without loss of sodium, only water, and dopamine when there is hypotension. Levethamidine is a calcium synthesizing phosphodiesterase inhibitor, potassium modulator, and omecaptive metoprolol, that is cardiac myosin activator. All those drugs are available. However, we are using levethamidine, but this omecaptive metoprolol, all those drugs we are not able to use. RAS inhibition in chronic CR, that is a chronic cardiovascular syndrome. We can use depending upon the creatine value, and we have to monitor the potassium. And nephrolyzing renin, this is very important. Sacubitril valsartan is being used, and none of antagonists like aldosterone antagonist, phenolactone, and eplerenone, beta blockers. Depending upon the staging of the heart failure, we should use very judiciously. We should use these drugs. Next one. So, what are the level of evidence? We are having various therapies. You know that cardiac recirculation therapy, implantable cardiovascular therapy, and sorbitrate, digoxin, ivabradine, beta blocker, mineralocorticoid antagonist, ARNI, that is angiotensin receptor neprilysin inhibitor, AC inhibitor, diuretic. So you can see there is a strong evidence and weak evidence based on the clinical setting. Appropriate patient individually we have to choose the therapy. Next one. This is the next one. This is a very important one because diabetic patients, many of the diabetic patients, they develop hypertension and heart failure. So what are the drugs which are very safe? There are various trials have been conducted based on, there is a very safe drug is executing that, but GFR below 30, we are not supposed to 30 or 20. There are trials based on empagliflozin, canagliflozin. They are all the sodium glucose
Thank you so much, sir, for such an insightful session. May I call upon Dr. Sahil Kumar, sir, to felicitate our chairpersons. Ma'am, the session is open for discussion also.
Any? We were able to learn about the pathophysiology of the cardiorenal, the various phenotypes. Students were able to learn that from this session. The phenotypes of cardiorenal, the pathophysiology, as well as some medication optimization that has to be done. Any questions from students? Would you like? We will end the session. Thank you.
Thank you so much, ma'am. I would like to request Dr. Sahil Kumar, sir, to felicitate our chairpersons. Dr. Namrata Gaur, ma'am. Dr. Sharon, ma'am. We now move on to our next session, which addresses one of the most challenging emergencies encountered in clinical practices, undifferentiated shock in diabetic patient, an approach to management. To guide us through this crucial topic, we have with us Dr. Seema Mahant Ma'am, Professor, Department of Medicine, Aims Bhopal, to share insights on this complex topic. Please also welcome our chairpersons for this session, Dr. Ankit Agarwal Sir, Professor, Department of Anesthesia, Aims Rishikesh, Dr. Prakash Sir, Assistant Professor, Department of General Medicine, Aims Rishikesh, Dr. Dharab Singh Sir, Assistant Professor, Department of General Medicine, Aims Rishikesh.
I need hand mic. And how I change the slides? This one, na? Okay, okay. Okay.
Ma'am to share her talk.
Thank you. Good morning, everyone. Is it working? Is it working? Good morning, everyone. First, I would like to thanks organizing committee and special thanks to Professor Dr. Ravikant sir, who invited me and gave me opportunity to speak on such an important and interesting topic, that is undifferentiated shock in diabetic patient and approach to management. Then why our focus is on diabetic patient? Because they have very high stake outcome. Mortality rate is very high in shock associated with diabetic patient as compared to non-diabetic population. Study shows that diabetic patient with septic shock have mortality rate up to 40 to 60% as compared to 20 to 30% in non-diabetic patient. So early recognition and tailored management can significantly improve outcome, and prompt intervention, especially within first hour of shock recognition, that is known as the golden hour, can reduce mortality up to 50%. Diabetic patients also have increased risk profile because they have increased risk of developing shock through multiple pathways. They are more susceptible to severe infection because they have compromised immune system, that leading to septic shock. Additionally, they have higher rate of cardiovascular disease such as coronary artery disease and heart failure. They can precipitate cardiogenic shock. They also have metabolic disturbances like diabetic ketoacidosis, hyperosmolar hyperglycemic state that can lead to circulatory collapse. diabetic patient also have atypical presentation, and I think it is the most challenging aspect while managing shock in diabetic patient. They have diabetic neuropathy. Because of the diabetic neuropathy, they mask these pain symptoms and making it difficult to diagnose underlying etiology, underlying infection or ischemia. Silent myocardial infarction are more common and that delay the recognition of cardiogenic shock. On the other hand, chronic hyperglycemia that blunt the typical inflammatory response, limit the sign of sepsis and making it difficult to diagnose clinically. There are some additional risk factors that make shock in diabetic patient more complex. First and most important is the fluid challenging issues. As we know, the diabetic patients, they have multiple comorbid conditions like chronic kidney disease or the diabetic nephropathy that make even a small amount of the fluid excess can lead to the pulmonary edema. And that too when they have the compromised cardiac function. Diabetic patients have multiple metabolic derangements like hyperglycemia, hypoglycemia, diabetic ketoacidosis, HHS. So all these conditions make the treatment part more complex. Diabetic neuropathy, they mask the symptom of shock. Microvascular dysfunction, cardiovascular disease burden, and high risk of infection are other additional risk factors. Now, what is the undifferentiated shock? As we know, the shock is acute circulatory failure causing tissue hypoxia and organ dysfunction. In undifferentiated shock, the patient have clinically and hemodynamically shock, but underlying etiology is not clear, or the patient may have mixed pattern. Commonly, there are 4 types of shock: distributive shock, more commonly septic shock characterized by vasodilation, increased vascular permeability, and distributive circulatory failure, and it accounts 60 to 70% of shock in diabetic patient. Then the cardiogenic shock, it is due to the primary cardiac dysfunction, often due to myocardial infarction or exacerbation of the heart failure or arrhythmias, and it is more common in diabetic because of increased atherosclerosis. Hypovolemic shock, as the name suggests, it is due to the intravascular volume depletion from hemorrhage, severe dehydration, or shifting of fluid into the third space, and it can precipitate or exacerbate by osmotic diuresis in hyperglycemic state. Obstructive shock, it is due to the mechanical obstruction of circulation, such as pulmonary embolism, tension pneumothorax, or cardiac tamponade. Though it is less common, but it is rapidly life-threatening if remain unrecognized. So diabetic patients have multifactorial shock like sepsis with cardiogenic, or obstructive, hypovolemic, or cardiogenic, or may have any combination. Now, recognizing shock in diabetic patient is need very high clinical vigilance because the classical sign of shock can be masked due to the diabetic complications. So first we have to look the general appearance and mental status of the patient. They are usually acutely ill. They have altered mental status. This altered mental status may be due to hyperglycemia, hypoglycemia, or making it crucial to consider shock as an underlying condition. We also look for restlessness, anxiety, or inappropriate calmness. Then move to hemodynamic parameter. Tachycardia, the heart rate more than 100 beats per minute. It is earliest and most essential sign of shock, but it can be blunted due to use of beta blocker or autonomic neuropathy. Patient have hypotension, systolic BP less than 90, or MAP less than 65. Though normotensive patient also have shock, particularly in previously hypertensive diabetic patient. Then move to respiratory and renal manifestation. Patient usually have tachypnea, respiratory rate more than 20 beats per minute. It may be due to the hyperventilation that compensated metabolic acidosis, or it is due to the underlying pulmonary disease. Patient usually come with oliguria, urine output less than 0.5 ml per kg per hour. Then look skin and perfusion changes, assess skin temperature, color, and capillary refilling time. If the skin is cool and mottled, it is suggestive of decreased perfusion. If the skin is warm, it indicates distributive shock. Then look for sign of specific shock like urticaria or angioedema in anaphylactic shock, jugular venous distension in cardiogenic or obstructive shock, or surgical scar that indicate underlying complication. Then go for lab marker of hypoperfusion, elevated serum lactate more than 4 millimole, or significant base deficit less than -4 milliequivalent per liter. They indicate hypoperfusion and metabolic acidosis. These lab markers are very important in diabetic patient because they have blunted clinical presentation of shock. Next. Now, as soon as the patient come, we immediately start initial assessment through ABCD primary survey. And this ABCD primary survey provide systematic framework to identify life-threatening complications in shocked diabetic patient. So A stand for airway management, assess airway patency and then consider early endotracheal intubation. If Glasgow coma scale less than 8, or the patient have significant respiratory distress or inability to protect airway. Diabetic gastroparesis increased risk of aspiration, so early intubation indicated. B stand for breathing assessment, evaluate oxygenation and ventilation adequacy to maintain SpO2 more than 94%. Then look for sign of pulmonary edema in cardiogenic shock, pneumonia if we are suspecting septic shock, or small respiration if the patient have diabetic ketoacidosis. We should provide proper ventilation by the use of non-invasive or mechanical ventilation. Then C stand for circulation evaluation. We should rapidly assess pulse quality, blood pressure, and establish large bore IV line or central line. We should avoid delay in vascular access, and we consider intraosseous access if IV attempts fail within 2 minutes. So we can use upper part of tibia or lower part of femur for intraosseous line. Obtain immediate blood sample and send for lab analysis. D for disability assessment. So we should do the neurological evaluation through Glasgow coma scale and assess for focal neurological deficit. Altered mental status in the diabetic patient may be due to hypoglycemia, hyperglycemia, electrolyte abnormalities, or neurogenic, or may be due to the shock. Perform rapid blood glucose check and consider thiamine administration before dextrose. Look for sign of increased intracranial pressure or stroke. Then E for exposure or environment. So fully expose the patient, but keep normal body temperature and try to find out the source of shock. Pay particular attention to diabetic specific complication like abscess, cellulitis, diabetic foot ulcer, Fourner's gangrene, or necrotizing fasciitis. Then after initial assessment, we should start immediate resuscitation. Immediate resuscitation is very important because any delay in the resuscitation will cause permanent injury in the diabetic patient. So our focus should be on proper perfusion. Proper organ perfusion should be our focus. So start with the fluid resuscitation protocol, and we give fluid challenge of 300 to 500 ml of isotonic saline administered within 20 to 30 minutes. Reassess frequently, monitor blood pressure, heart rate, urine output, and clinical sign of perfusion after each bolus. We should limit the IV fluid up to 250 ml if we are suspecting cardiogenic shock and assess JVP, basal crepitation, and S3 gallop frequently. Then vasopressor therapy. So initiate vasopressor therapy if MAP is less than 65 in spite of adequate fluid resuscitation, and choice of drug is norepinephrine. So we start 0.05 to 1 microgram per kg per minute and titrate to achieve MAP more than 65. We can give maximum up to 0.5 to 1 microgram per kg per minute before starting second agent. Then second agent is the vasopressin, 0.1 to 0.04, 0.01 to 0.04 unit per minute. Then inotropic support. So give inotropic support with dobutamine, 2.5 to 10 microgram per kg per minute when we are suspecting cardiogenic shock. Or we can give combination therapy with norepinephrine plus dobutamine in mixed shock state, septic shock with cardiac dysfunction. This combination is very common in the diabetic patient because they have multiple comorbid conditions. Then diagnostic workup, and so we should give the proper diagnostic workup to find out the common cause of the shock as well as diabetic specific complications. So we start with ABZ with lactate, and that give the acid-base status, oxygenation and perfusion idea. And our focus should be on ketone and lactic acidosis, DKA. So we focus on particular that area. Then complete metabolic panel. So we advise blood sugar, electrolyte, abnormal serum electrolyte level, or the ketones level. So by this we can find out the, our focus would be on the potassium level, diabetic ketoacidosis, ketone, and anion gap. Then complete blood count. So by this we can find out the infection and anemia that may contribute this shock. And if the patient have thrombocytopenia, then we consider it, then it also suggestive of shock or disseminated intravascular coagulation. Then move to cardiac evaluation. Troponin level are very important because they have high prevalence of coronary artery disease. So increased troponin give idea about the underlying silent myocardial infarction, or the patient may have the stress cardiomyopathy. BNP and pro-BNP level, again very important in shocked diabetic patient because it gives idea to differentiate whether the shock is cardiogenic or the cause is the other. If the VNP level is more than 500, it is likely cardiogenic. If it is less than 100, the cardiogenic unlikely. Then 12-lead ECG, look for acute STT changes, arrhythmias, and conduction abnormalities. Then infection screening. So we should do blood culture, at least 2 sets of blood culture from 2 different sites before administering antibiotic. Then urine analysis and urine culture, because the diabetic patient, they have high incidence, they are very prone for UTI and urosepsis. Then chest imaging, X-ray chest to find out pulmonary edema, consolidation, or pneumothorax. We go for CT chest if we are suspecting pulmonary embolism. Then this is very important, point of care ultrasound focus. So we follow the rush examination. This is the rapid ultrasound in shock and hypotension, and we should follow systematic approach. First we evaluate cardiac, then volume status, then other causes. So in cardiac views, we look for regional wall motion abnormality, left ventricular ejection fraction, RV strain, and cardiac tamponade or pericardial effusion. Then we move to inferior vena cava. By this we can find out the volume status and the calibration or the size of the IVC can help the fluid replacement. Then lung ultrasound, it is very important and it is very sensitive as compared to the X-ray chest for the diagnosis of the pulmonary edema, consolidation, and pneumothorax. And additional diagnostic test, HbA1c, serum and urine ketones, and procalcitonin. As we know, the diabetic shock, they have multiple etiology. So our treatment should be very much targeted. If the patient have septic shock, then start antibiotic within 1 hour, and we should use broad spectrum antibiotic coverage, piperacillin, tazobactam or carbapenem plus vancomycin. We have to find out the source and control it. Then aggressive fluid resuscitation with 30 ml normal saline in first 3 hours. We should also consider atypical organisms like mucormycosis. Then if the patient have DKA or HHS related shock, then aggressive fluid management, 1 to 2 liter normal saline in first hour, and start IV insulin 0.1 unit per kg per hour after initial fluid resuscitation. Monitor electrolyte level, frequent potassium, phosphorus and magnesium replacement according to need. If the patient have cardiogenic shock, then immediate cardiology consultation for PTCA. Optimize preload by the use of diuretics. Give inotropic support with dovitamin if the patient have low cardiac output. We should provide mechanical support in the form of intra-aortic balloon pumping or ECMO for refractory cases. If the patient have hypovolemic shock, then give rapid volume replacement with normal saline. And if the underlying cause is hemorrhage or bleeding, then give right blood product and find out the underlying cause and treat accordingly. So diabetic patient, they have the multiple pattern of the shock. So we tailored the treatment, we give a specific treatment according to the multiple etiology. Then yes, adjunctive therapy in the form of corticosteroid. So we give corticosteroid 100 milligram IV every 8 hourly if the patient have refractory shock that need high dose of vasopressin more than 0.5 microgram per kg per minute norepinephrine for more than 24 hours. All the patient have history of steroid use because there is risk of adrenal insufficiency, or the patient have septic shock with inadequate response to initial resuscitation. Then focus on glucose management. During acute stage, avoid aggressive glucose control, and blood sugar level should be between 150 to 200 milligram per deciliter. Avoid sliding scale insulin in acutely ill patient. Then focus on acid-base management. Give soda bicarbonate. Soda bicarbonate is generally not recommended unless the patient have severe acidosis with pH less than 7. Or the patient have hyperkalemia with ECG changes, or the patient have history of tricyclic antidepressant overdose. Renal protection, again important. Avoid all nephrotoxic medication. Monitor urine output and serum creatinine level, and consider early renal replacement if the patient have severe AKI. Then again, this is very important. While managing shock in diabetic patient, we usually follow minute bundle because this 30-minute plan of management is especially for the undifferentiated shock. So aim for maintain ABC within minute. Then IN for infuse and investigation. So infuse fluid and vasopressor and send blood sample for investigation within few minutes. Then U for ultrasound. So do ultrasound to find out the underlying shock. And in ultrasound, first we do the cardiac assessment, then IVC for volume, then the ultrasound of the chest and other part. And this ultrasound should be within 10 minutes. Then TE, treat etiology. So within 20 minutes, we have to find out underlying etiology and treat accordingly. Then as for stabilize, so within 30 minutes, stabilize the organ perfusion. This one is the last one. So this is the take-home points. Rapid recognition is very important in diabetic shock. We should follow structured approach, ABCDE survey and minute bundle. Target common diabetic complications, and time is tissue. So time is very important. Timely intervention should be needed. dynamic reassessment, multidisciplinary approach, they all are important while we managing shock in diabetic patient. Thank you very much.
Thank you, madam. Very nice talk by madam. And we find that shock is common in the diabetes patients. So various causes like the infection, hypovolemics,
Yes.
cardiac causes, and renal causes. Cause is the in case cardiac cause because of the diabetes leading to cardiac autoimmune neuropathy. In these cases, should we advise the pregabalin or not? What is the role?
Advice?
Cardiac autonomic neuropathy
Yes, yes.
because of the diabetes.
Right. So,
So what is the role of the pregabalin in this case?
parabalin,
Pregabalin.
pregabalin. Actually, pregabalin gives symptomatic support in diabetic neuropathy. I think there is no effect in the autonomic cardiac complication.
So
I think.
it should be given in these cases.
Can be given, but there is no much benefit in cardiac complication.
If we not given, then
We give it, though it is very beneficial in the neurogenic complication or the diabetic neuropathy, but in cardiac autonomic neuropathy, the importance is not clear, the role is not clear.
thank you, madam. Any question from the audience?
I think this lecture is only for the PG resident, because the PG resident, your wisdom, your attentiveness, that can change the future of the diabetic patient, because you are the first person to attend all the emergencies. So your wisdom, your attentiveness definitely give change. Thank you.
Thank you so much, ma'am, for that excellent and practical presentation. I would like to request our chairpersons to felicitate our speaker, Dr. Seema Mahant, ma'am. To felicitate our chairpersons, I request Dr. Prasann Kumar Panda sir to felicitate Dr. Ankit Agrawal sir, Dr. Dharab Singh sir, and Dr. Prakash sir. We now move on to a very interesting and thought-provoking session, a debate on role of prophylactic antifungals in invasive fungal infection in critically ill diabetic patients. To discuss both sides of the issue, we have two eminent speakers with us today. Dr. Ritu ma'am, Assistant Professor, Department of General Medicine, Aiims Jammu, who will be speaking for the use of prophylactic antifungals, and Dr. Jitesh sir, Consultant Physician, Critical Care at EMS Hospital, who will be presenting against the perspective. Also, let us welcome the chairpersons for this session, Dr. Seema Mahant ma'am, Professor, Department of Medicine, Aiims, and Dr. Prasann Kumar Panda sir, Additional Professor, Department of Medicine, Aiims Rishikesh. Let us begin by inviting Dr. Ritu ma'am to present for prophylactic antifungal use.
Good morning, everyone. First of all, I would like to thank you, the organizing committee, especially Professor Dr. Ravikant sir, for inviting me and giving me the opportunity for speaking on the dais. So my topic is role of prophylactic antifungals in invasive fungal infection in critically ill diabetic patients. So why this topic is important? In 2022 October, the WHO issued a warning that fungal pathogens are the major threat to public health as they are becoming increasingly common and resistant to the treatment. And most of the fungal pathogens lack rapid and sensitive diagnostic. During the COVID-19 pandemic also, we have seen many cases of mucormycosis and invasive fungal infections. The reported incidence of invasive fungal infections increased significantly among the hospitalized patients despite the growing concern, and the fungal infection receives very little attention in the resources. Now, the background of this is that invasive fungal infection are life-threatening infection with high mortality, and globally 300 million people suffer from the fungal infection and 2.5 million people die every year. And invasive candidiasis is among the most common of the invasive fungal infection and accounts for the 70% of these infections, followed by the aspergillosis and mucormycosis. Now, what about the India? 4.1% of the Indian population suffers from the serious fungal disease, and 30 days all-cause mortality is 43.4%. Now, this is a systematic review showing the prevalence of this invasive fungal infection to be of 5%, with the Candida followed by the Aspergillus prevalence more. Now, why it is important in diabetes? Because there is the deterioration of neutrophil activity, there is depression of the antioxidant system, compromised innate immunity. Now, what are the overall risk factors for this invasive fungal infections are? First is the poor glycemic control, broad spectrum antimicrobial therapy, indwelling central vascular and unit tract catheters, as happen in most of the ICU patients, prolonged mechanical ventilation, prolonged duration of the ICU stay, total parenteral nutrition and renal replacement therapies, and chronic kidney disease patients, chronic liver disease patients. Now, what are the initiation strategies for the antifungal? So, we can start as prophylactic, we can start as preemptive, empirical and targeted. Now, in prophylactic is given at high-risk patients. Preemptive is given to the high-risk patient with the positive biomarkers and the radiological signs. Empirical is on the clinical suspicion without the confirmed microbiological evidence, and definitive is not the confirmation of the microbiological evidence. Now, what is the rationale for using the antifungals for this prophylactically is the substantial morbidity and mortality of the invasive fungal diseases, the difficulty in obtaining a timely diagnosis due to limitation of the available diagnostic test, the suboptimal response of the best available treatments. The substantial additional resources used in patients, in these patients, diagnostic approaches and therapeutic monitoring through slow resolution of the infection and prolonged suppressive therapy. Now, I will be discussing three guidelines. First is the surviving sepsis guidelines, international guidelines 2021, where there is the weak recommendation with low quality of evidence for the adults with sepsis or septic shock at high risk of fungal infection, where we suggest using empirically antifungal over no antifungal therapy. Then there is national guidelines in April 2024, where the antifungal prophylaxis for candidiasis should be given to that subgroups of the patients where they have an increased risk and they have using the particular scores. These scores are like Candida score, Nebraska medical cancer score. Then indications for empirical antifungal therapy in aspergillosis is that whenever there are high-risk patients with prolonged neutropenia who remain persistently febrile despite broad-spectrum antibiotic therapy, and use of BAL fungal biomarkers are very specific for this invasive aspergilloma, like galactomannan, and to guide the antifungal therapy in asymptomatic or febrile high-risk patient can reduce the unnecessary antifungal therapy. Now, this was about the national guidelines. Then 2016 update by the IDSA, where there is strong recommendation that empirical antifungal therapy should be considered in critically ill patients with the risk factors for invasive candidiasis and no other known cause of fever, and should be based on the clinical assessment of the risk factors, surrogate markers for invasive candidiasis or culture data from the non-sterile sites, and should be started as soon as possible in patients who have the above risk factors and who have the clinical signs of the septic shock. Now, what are the common pathogens? This is the WHO fungal priority pathogen list. So, in the critical groups, it is the Cryptococcus neoformis, Candida auris, Aspergillus fumigatus, and Candida albicans. Now, about the invasive candidiasis, it accounts for 6.5% of the per 1000 ICU admissions, and risk factors are catheterizations, again mechanical ventilation, TP and peritoneal dialysis. Then come the invasive aspergillosis, most frequent in critically ill, liver failure and cirrhotic patients, 10.1% cases, 10.1 cases per 1000 ICU admissions, and the most important risk factor for this is lack of the high particulate efficiency or HEPA facilities in the ICU. Then invasive mucormycosis, as in prevalence is 14 cases per 1 lakh individuals, and it is 70 times higher than the global data. Now, how we diagnose these fungal infections? The gold standard for fungal infections is culture of the blood and fluid from the sterile sites or tissues. All biopsy specimens should be tested for both histopathology and microbiological culture. Malditoff technique should be performed for the species identification. Beta-D glucone should be used to stop the empirical antifungal therapy, and BAL-galactomannan is more sensitive than serum galactomannan in diagnosing the Aspergillus infections. Now, this is about the diagnosis of candidiasis. We have the culture as the gold standard, then non-culture we like PCR, beta-D glucone detection assays, then antigen and antibody detection. Then aspergillosis, I already told you, is the galactomannan in the BAL. Then diagnosis of mucormycosis is by biopsy and KOH mount. Now, what are the antifungals? As you already know, what type of antifungals we can use. Some inhibits the cell wall synthesis like echinocardin, some inhibits the cell membrane pores like amphotericin B, and ergostol synthesis inhibitors are our azoles. Now, for prophylaxis, antifungal regimens used for candidiasis is fluconazole, 800 mg loading dose followed by 400 mg, 6 mg per kg daily. And when we have to stop these antifungals in invasive candidiasis when giving as prophylaxis is in patients who improve in 2 weeks, same as for the treatment for documented candidiasis, and for the patients who have no clinical response to empirical fungal therapy at 4 to 5 days and who do not have subsequent evidence of invasive candidiasis after the start of empirical therapy, or have a negative non-culture based diagnostic assays with high negative predictive value. So, consideration should be given to stop this antifungal therapy in that patients. So, this is a flow chart for treatment of the invasive this candidiasis. Now, prophylaxis for aspergillosis is choice of the agent depends upon the immune status, organ dysfunction, prior azole exposure, and likelihood of the resistance. So, initial therapy should be voriconazole or isavuconazole for the primary drugs of choice. If intolerance, then prazoconazole and liposomal amphotericin B can be used. So, this is a table showing the treatment of invasive aspergillosis. Then duration of therapy till the resolution of all the signs and symptoms, individualized based on the site of infection, response to the therapy, immunosuppression, and underlying disease. Monitoring is by imaging and galactomannan measurements also help in termination of the therapy. Then mucormycosis is liposomal amphotericin B, 5 mg per kg per day, 10 mg per kg per day if the CNS is involved. Now, the key points from this talk is that delay in the diagnosis and initiation of the antifungals is associated with high mortality. Using prophylactic antifungal therapy in high-risk population with the prevalence of fungal infections more than 10%. Biomarkers and radiological signs in high-risk patients help in early initiation of the antifungal therapy. Clinical signs, risk factors for invasive fungal infection, and use of various scoring systems like Candida score help in identifying the patient for empirical therapy. Thank you. you, sir.
And I think from this presentation, you have some idea ki we should start empirically or preemptively or prophylactically antifungal therapy for the critical ill patients who are admitted in our all ICUs. And she correctly described all the guidelines who are there favoring actually, and also already there in the guidelines ki when we should give. But there are always gray areas because it is not like guidelines are being coming to our individual case-to-case basis, and it's not exact what guidelines says because each case has its own different type of you can tell presentation. But in that presentation, when not to give also, we'll see our next speaker will focus on actually the against what is the demerit, or you can tell actually when we should not give that. And after the end of this, definitely you can have a take-home message exactly ki at this point we should give the antifungal therapy and this point we should not give. Now, we'll just come to Dr. Ritu again. But before that, let's learn from our another pillar from our institute, Dr. Jitesh.
Thank you, ma'am, for your presentation. Now, to present the counter view, I invite Dr. Jitesh sir to share his perspective against the use of prophylactic antifungals in critically ill diabetic patients.
Good morning, everyone. So, thank you, Devigan sir, and thank you, Mukesh sir, for inviting me back to the place where I learned critical care. So, today I will be speaking against the motion of role of prophylactic antifungal in invasive fungal infection in critically ill diabetic patients. So, my first slide, as the ma'am has already explained, what is prophylaxis? Prophylaxis means giving a drug to prevent occurrence of a particular disease before there are any signs, any symptoms, even the markers are not been positive. So, if you are using a particular drug at this particular point, you should have a highest scientific evidence. So, this is the first thing that I want to say. Now, my second slide is this thing. Is there any specific data that pertains that support prophylactic use of antifungal? See, I'm not talking about empirical use. I'm talking purely about the prophylactic use. So far, there is no randomized control trial. There is no meta-analysis. So now, next. So what I'm doing right now is I'm using some trials and meta-analysis that has been published on a non-neutropenic population. See, all the trials which support the use of antifungals are basically that has been done on immunocompromised population. So this slide covers maybe around 4 meta-analysis that covers nearly 27 RCTs and that covers around 4,000 populations. So what they found out in all these RCTs? There is decrease in the infection that is not statistically significant. There is no mortality benefit except one Playford study. What they found out, that may be beneficial in very high-risk patient who has undergone abdominal surgery. Again, this abdominal surgery population become the high-risk category. So that is the only state. So what these 4 meta-analysis say, prophylaxis is of no use. Then this is another meta-analysis that got published in the 2017 in Critical Care Journal. So this in this study, they had covered around 19 studies, and they have categorized the use of antifungals in different headings like preemptive, anti-inflammatory, prophylactic, as well as empiric. In all of them, again, the diamond stands in where the values of no use. Again, the 2017 meta-analysis also say prophylaxis is of no use. So this is another randomized control trial which uses caspofungin prophylaxis. One good thing about it is they say that if you use caspofungin prophylaxis, that there is not much side effect. Decrease of infection, again, no benefit. Then this is another Cochrane review. Again, in this one, what they did was like they had taken almost fluconazole, ketoconazole, caspofungin, mecafungin, amphotericin B, nystatin, and everything. Again, the diamond again stands in there is of no significance of prophylactic use. So like all-cause mortality, no reduction. Invasive fungal infection, reduced infections are there, less colonization is there, no difference in side effect. So basically, if we give prophylaxis, we will get less fungus in cultures, nothing else. So the other point, like if you start giving the prophylaxis, what are we going to encounter? The main thing, what we are worried, is emergence of resistance. So we all know diabetic population will have some sort of fungal infection. They will have candida. You give antifungal prophylaxis, it gets changed to Glebrata, cruzi or Ores. Emergence of MDR drugs, you may be able to, earlier if you may be able to treat with fluconazole, now you will have to step up to Caspo or Anadula. Then it is basically against the antimicrobial stewardship. Then, see this, in this slide if you see, there is an increased incidence of occurrence of Candida auris in diabetic population. Again, diabetes is a risk factor. That is why I told you, if you are trying to give prophylaxis in a diabetic population, whoever comes to ICU, you are making a lot of population exposed to unwanted antifungal, and again it will lead to emergence of lot of resistance. So this is again increasing resistance of Candida gablerata against echinocandins. So then next one, see we are giving drug to an absolutely, see the patient is coming to ICU due to some other reason, and you are giving a drug. If the drug don't have much side effects, still it is okay. This drugs itself has lot of side effects, like see fluconazole can affect, lead to hepatotoxicity, QT prolongation. Itraconazole can have impact on the heart. Then fosaconazole have hepatotoxicity, prolongation of QT. Amphotericin B is nephrotoxic, nephrotoxic hypokalemia is there, and all those things. Again, you are unwantedly, unnecessarily exposing this population. Then drug interaction. So all the antifungals that good, they are notorious to have multiple drug interaction. See, they are metabolized in CYP3A or CYP29C. So, and what they will do, they, if you are giving any other drugs like tacrolimus, cyclosporine, again, nephrotoxicity and neurotoxicity will be high. So you may say you don't use much of these drugs in ICU. It's fine. But what about midazolam and fentanyl? Very commonly used drugs. Again, their level get potentiated. QT prolongation happens. Almost all the drugs that we use in ICU have a QT prolongation risk. Dyselectrolytemia is there. Again, QT prolongation happen. Warfarin, which we use, again it get potentiated. Then see, drug interactions, a lot of drug interactions are there for almost all antifungal. If we are using it for treatment, I still agree that we are ready to, we should face the side effect, that's okay. But here we are using it as a prophylaxis and without much evidence. So that's something not good. Then again, cost. So the cost is like the fluconazole is one of the cheapest drug, and remaining all the drugs comes like, see, once it comes to the critical care stay, in a corporate ICU, it's cost nearly around 40,000 per day. So in my ICU, it's like a corporate ICU where the stay is like the stay one day cost like around 8,000 rupees, which is almost equal to the price of caspofungin. So if you are using it as a treatment, it's okay. Again, prophylaxis, no. Only person who is going to get benefit out of it, it's the pharma companies, if you use it as prophylaxis. So now let's go to the guidelines. What does guidelines recommend? So first one is our surviving sepsis guideline. Surviving sepsis guideline very specifically remains silent about the prophylaxis. It only use specifically empirical use in patient with sepsis with septic shock. And actually, even if you see that also, the quality of evidence is low. It purposefully remains silent about the prophylactic use. Next one, IDSA. IDSA again support the use of antifungal in septic shock, but prophylactic part, they say give it to the high risk population. So now, do diabetes come in high risk population? No. Then, what does our Indian Society of Critical Care say? Indian Society of Critical Care is also clear. Give it to the high risk population. They are like transplant candidate, abdominal surgery, pancreatitis population. These patients you can give, but not to the diabetics. Now, so basically what I am trying to tell is diabetes doesn't become an automatic indications to start prophylactic antifungal. So ma'am has rightly told in diabetes there is decreased neutrophil function. So what we can do better? We can go for a better glycemic control. That will prevent it better than giving a prophylaxis. So the other thing, if we start to give prophylaxis, the consultant will have a false sense of comfort that antifungal will work and fungal infection won't happen. So that's it. So literally what will happen, we will suspect less, there is a high risk that the patient get worsened. And we have a lot of diagnostic tools are available like 1,3 beta D glucon, PCR panel, Candida testing, and lot of scores are available. So rather than going for prophylactic, we can go either empirical or preemptive. So now, like about the scores, like this Candida score is there, ostrich sickness score is there, IFIRS score is there. See, if you have seen the components, none of them has included diabetes. So it's very clear, diabetes may be an immunocompromised state, but it is not that immunocompromised state that can have a high risk fungal infection where a prophylaxis will get benefit. So last, what will I suggest? What we can do to prevent this thing? Simple, have a strict glycemic control, strict antibiotic protocol, early removal of lines, use of scoring system, use of fungal biomarkers, and culture-based therapy. I do support use of empirical use of antifungal, maybe up to preemptive, but even if you go to the empirical use, empiricus trialists and all are still against it. That is why their level of evidence is still low. So that's it. So the summary is like no direct data, resistance is high, side effects are there, drug interaction is there, cost is there, and guidelines don't support it. We have other better alternative. So my final closing statement, you can use antifungal as a treatment or up to empirical level. If you are using it as an empirical stage, start it, send the test. Once the test turn negative, stop it. That's it. Thank you.
Thank you so much, sir. I now request our chairpersons to kindly share their concluding remarks.
Thank you, Dr. Jitesh, for such a kind and nice presentation. And my question is that, suppose a patient admit in ICU with multiple comorbid condition, and we send the fungal culture, and it take near about 3 to 4 days, and sometime more than that. So what should be our stand between these duration, 1 to 5 day, when the culture report will come?
Ma'am, see, if you are peculiarly seeing if the patient is in sepsis with septic shock, we have, if the sepsis with septic shock is there, our guidelines support it.
Yes.
Empirical use is fine.
Okay.
If you are just the patient come to ICU and you send cultures, don't need an antifungal. My take is simple. The concept is very simple. If the patient needs it, like sepsis, septic shock is there, start it. You can use the scores, you can take help of score, Candida score is there, other scores are there. And if the patient is a high risk patient, you can directly go for it. And wait for that, you can either go for the beta D glucan and all those things, you can take help of it. And wait for the cultures to come, and if cultures come negative, stop it. If it is positive, continue.
Continue it.
So you want to say if point of care test is positive, then point of care test like all the galactomannan or beta-1,3 glucan, we should go for that. And if it is positive, then don't hesitate, because that will be a part of preemptive or actually
Sir, like rather than even before going for beta D glucan, we have imaging also with us. Like even if the radiological evidence say that it looks like a fungal infection, go for it, go treat it, because see, still we have some backup.
and that will be therapeutic rather than prophylactic.
Yeah, see, that will be
Therapeutic, not prophylactic.
But one point actually, because you are telling diabetes is not in the evidences, but diabetes doesn't mean itself all form of diabetes. Like I will tell, if a uncontrolled diabetes is there, HbA1c actually 14 is there, is a patient. In that point, what will be the decision point?
Sir, that is the thing. See, that area is still grey.
Yeah.
See, no trials are there. I can't say something without evidence, right?
Yeah.
See, diabetes, we know it is an immunocompromised state, so that's fine. But if none of the scores they have included it, and they have included abdominal perforation, hematological malignancy, so they feel these are particularly risk factors, and they have not considered diabetes in that state yet.
Yeah.
Maybe they may change the points later on.
Thank you both of you. Any question from the audience?
Yeah, I agree with Jitesh in this, because being a cardiac surgeon in our cardiac ICU, in Aiims Rishikesh, we manage our patients ourselves. Most of the time, the critical care and anesthesia team doesn't manage the post-op care.
Bedside, yeah.
Now, if your patient is clinically looks febrile, or maybe had one spike of 99, and because the patient had transfusions in OT or ICU, so that doesn't still recommend starting an antifungal unless you have a culture positive or you think your report has gone for 3-4 days. The patient usually post-operatively is on 2 antibiotics for first 3 days till the monitoring lines are there. What protocol we follow is universal precautions. We try to de-line the patient as fast as possible. when the anatopes are tapered and we don't need many monitoring lines. And those prophylactic antibiotics also, if the patient is febrile, we stop by 3 days.
Yes.
And very stringent control of sugar. And we keep monitoring the patient clinically. So that is the better way. I personally agree with Jitesh. Instead of what I have seen is in general, there is a very big perception all over, especially in private hospitals. I have worked in corporate also, where they'll say, let's add antifungal also. So they feel it's something very, everything is added. And you don't realize that ultimately it is the body that has to assimilate. And you are increasing the load on that patient of that resistance. So
When other system they are compromised, renal
Compromised
function
because of that.
compromised, yeah, they can toxic.
Thank you both of you. Over to organic team.
Thank you to both our debaters. I would now request our chairpersons to felicitate our speaker, Dr. Ritu ma'am. Dr. Jitesh sir. I would like to request Dr. Darab Singh sir to felicitate our chairpersons, Dr. Seema Mahant ma'am. Dr. Prasann Kumar Panda sir. We now move on to our next session on a topic that continues to generate discussion in intensive care units across the world, use of steroids in critically ill patients. To guide us through this important subject, we have with us Dr. Nidhi Kele ma'am, Additional Professor and Head, Department of Emergency Medicine, Aiims Rishikesh. Please join me in welcoming ma'am to share her expert insights. Also, let's welcome our chairpersons for this session, Dr. Anirudh Mukherjee sir, Associate Professor at Department of Medicine, Aiims Raebareli. Dr. Mahendra Meena sir, Assistant Professor at Department of Medicine, Aiims Raebareli. Dr. Akhilesh sir, Assistant Professor, Department of Medicine, Aiims Rishikesh.
Ma'am actually doesn't need an introduction. She is my alumni senior also. And I don't think I'm deserving enough to chair her session at the least. And I know that she's the best in whatever she does. Ma'am, please go ahead, ma'am.
Thank you so much, chairpersons, for the kind introduction. And I take this opportunity to thank Professor Ravikant sir to give me this opportunity to share my topic with you. And without further delay, let me start with the topic. Today's topic I'm going to talk on is steroids in critically ill patients. So glucocorticoids are potent anti-inflammatory medications that are frequently used in the treatment of critically ill patients. Systemic glucocorticoids, prednisolone, methylprednisolone, and hydrocortisone mimic the action of naturally occurring glucocorticoids by binding intracellular glucocorticoid receptors in the cytoplasm. Glucocorticoids promote the activity of anti-inflammatory cytokines and inhibit fibroblast production. They are the key mediators of the stress response, as we all know. They increase the cardiac output, increase the responsiveness of vascular adrenergic receptors, and decrease the vascular permeability. They also have a significant effect on metabolism by increasing the gluconeogenesis and altered metabolism of fat, bone, and protein. Under physiological conditions, the adrenal glands in adults secrete approximately 5 to 11 milligrams of cortisol per day, that is equivalent to 20 to 30 milligrams of hydrocortisone and 50 to 200 micrograms of aldosterone per day. Now, this was the introduction we all know about glucocorticoids per se. Now, where all do we use glucocorticoids in a critically ill patient and in emergency setting? So we enumerate, for enumeration, before you, we use glucocorticoids in patients with sepsis and septic shock, in severe CAP, in severe ARDS, in moderate to severe ARDS patients, and then we have transverse myelitis, we have severe spinal cord syndromes where we can use glucocorticoids, and then we can also use glucocorticoids as anti-edema measures in emergency department and critically ill settings. So coming to the sepsis, according to the survival sepsis 3 guidelines, and this is a latest review on published in 2023, an update in on sepsis and septic shock in adult patients, management and emergency department, they have advocated the use of hydrocortisone at a dose of 200 mg per day, which has been suggested in septic shock patients not reaching target VAP despite vasopressor administration. Now, this is a very important line in sepsis 3 guidelines, that they have they advocated the use of low dose hydrocortisone in patients who are already on noradrenaline for at least or more than 4 hours, and they have advocated the use of 50 mg of hydrocortisone maybe 6 times a day, or QID, 200 milligrams of a total dose. However, as opposed to this, in 2016, a guideline was published wherein they decided that, they did not they did not support the use of hydrocortisone, and they said that they were able to restore hemodynamic stability and increase neuromuscular weakness without a clear effect on short and long-term mortality. So in 2016, the use of hydrocortisone was not advocated. In 2018, 2 landmark trials were published, in fact 3. The most important, the 2 were adrenal trial and approaches trial. Adrenal trial was adjunctive corticosteroid treatment in critically ill patients with septic shock. The eligible patients were those who were on vasopressor support or inotrope for more than equal to 4 hours to maintain a MAP of more than 60 millimeters of mercury, and at the time of randomization. So this trial advocated the use of hydrocortisone. Then came the approaches trial. The approaches trial again advocated, that was the activated protein C and corticosteroids for human septic shock trial. There they use hydrocortisone plus fludrocortisone in patients with septic shock, and this trial also supported the use of hydrocortisone in patients with septic shock. Another landmark trial was the VANISH trial, which advocated the use of corticosteroids. So all the 3 trials, they actually proved that the early use of corticosteroids in these patients with septic shock who were already on as inotropes for more than 4 hours or 6 hours, they had then additional benefit of shorter duration of ICU stay, enhanced oxygenation in patients undergoing mechanical ventilation, reduced mechanical ventilation and duration, increased ventilator-free days for at least 28 days, reversal of septic shock, and reduced mortality. Thus, the patients with ongoing requirement as a dose of norepinephrine or epinephrine for more than equal to 0.25 micrograms per kg per minute for at least 4 hours after initiation to maintain the target MAP was found to have benefit with the use of corticosteroids. Thus, the guidelines have advocated in these patients the use of hydrocortisone up to a dose of 200 milligrams per day. Now, just if you see the corticosteroids in septic shock, these are all the landmark trials. The last 2 trials were the main authors were Venkatesh, that is basically the adrenal trial, and Anane trial, that is 2018, the approaches trial, where they have advocated the use of hydrocortisone, and in case of approaches trial, they have also used along with hydrocortisone, fludrocortisone 50 micrograms was used, and they found that there was improved mortality at 90 day, at 180 day, vasopressor free days were achieved, and organ failure free days to approximately 28 days were achieved with the use of hydrocortisone and fludrocortisone in these patients. Thus, there was a clear benefit. Next importance, so now we know that in patients with septic shock, hydrocortisone should be used in patients with emergency, in emergency as well as in critical care settings. Next important thing is use of corticosteroids in severe pneumonia. Now, pneumonia, as we know, is classified into community-acquired pneumonia, hospital-acquired pneumonia, which includes ventilator-associated pneumonia and healthcare-associated pneumonia. And then we have an entity called as aspiration pneumonia, which can be categorized under any of these settings. Now, the evidence supporting and recommending the use of corticosteroids in patients with severe CAP comes from these three important trials. One was the ESCAPE trial, then the landmark Cape Cod trial came, and then the REMAP, it came in 2025. The ESCAPE trial found no significant difference in 60-day mortality with the use of hydrocortisone or steroids in patients with severe CAP. Whereas Cape Cod trial demonstrated a significant reduction in 28-day mortality in patients with severe CAP. REMAP again was published and evaluated the use of hydrocortisone 200 milligrams daily with a fixed duration of 7 days in patients with CAP, and again did not demonstrate a significant reduction in 90-day mortality. So are we giving hydrocortisone or are we giving glucocorticoids in patients with severe CAP is an important question. Now, before that, we have to know what is the definition of severe CAP. When do we define a patient with severe community-acquired pneumonia? Now, a patient with more than one major criteria, that is septic shock with the need of vasopressor, respiratory failure requiring mechanical ventilation, that is more than one major criteria, more than 3 minor criteria, that is respiratory rate more than 30, PF ratio less than 250, multilobar infarcts, confusion dementia, 1 more than 20, leukopenia or leukocytosis, thrombocytopenia less than 1 lakh, hypothermia, and hypotension. Now, this is defined as by the ATS, as per the ATS criteria, the definition of severe CAP. Now, as per the latest guideline, we are following the Cape Cod trial. In patients with bacterial pneumonia, all the RCTs and the meta-analysis have supported the evidence of use of corticosteroids in patients with bacterial pneumonia presenting with severe CAP features, and low-dose corticosteroids or dexamethasone up to 6 milligram, 5 to 6 milligram is recommended in patients with bacterial pneumonia. The evidence of utilization of glucocorticoids or use of glucocorticoids in patients with influenza is still lacking. In patients with the fungal pneumonia also, the evidence of use of corticosteroids is lacking. In patients with severe CAP, complicated with severe ARDS, the use of high-dose glucocorticoids is robust, as I will be discussing in the subsequent slides. So you have to categorize your CAP patients and you have to define whether it is a bacterial pneumonia or a fungal pneumonia or a viral pneumonia. The evidence of glucocorticoids in other than COVID-19, in patients with other than COVID-19 is lacking, is not much robust. That is what is recommended by the guidelines. So clearly we are, as per all the ISCCM guidelines of critical care, we are following currently the Cape Cod trial. We are using glucocorticoids in patients with severe CAP as defined by ATS. So this is a summary of the ESCAPE, Cape Cod, and REMAP Cod trial, where they've advocated the use of glucocorticoids. Okay. Next important topic is corticosteroid use in patients with septic shock and ARDS in CAP. So most of the trials, and the two most important, that is the adrenal and approaches trial, have advocated the use of glucocorticoids in patients with septic shock in the presence of severe CAP and complicated ARDS. So the two large RCTs for septic shock, that is adrenal and approaches, were published in 2018, with the former showing no significant improvement in 90-day mortality, and later approaches trial was published which demonstrated a significant reduction in 90-day mortality with the use of hydrocortisone plus fludrocortisone in patients with septic shock with ARDS and severe CAP. So approaches trial had shown significant mortality benefit, 90-day mortality benefit, with the use of hydrocortisone and fludrocortisone. So this is these are the trials which have been done for the use of corticosteroids in severe pneumonia patients. Another important topic is whether to use corticosteroids in ARDS patients as an adjunctive medication, as adjunctive therapy. See, in patients with ARDS, mechanical ventilation plays a very important role. However, lot of trials have advocated the use and also pressed upon one important aspect in the treatment of ARDS, and that is the role of corticosteroids. Not only this, they have also said that we are talking about the role of mechanical ventilation so much that we have actually downpressed the role of pharmacotherapy in patients with ARDS, and then they highlighted the role of corticosteroids in patients with ARDS. So ARDS, we all know that it is acute respiratory distress syndrome, and it is an inflammatory process in the lungs that induces non-hydrostatic protein-rich pulmonary edema. So again, in the definition, we are only talking about the role of mechanical ventilation. Again, downpressing the role of pharmacotherapy. So lot of important trials, and the latest is the DEXA ARDS trial, where they have advocated the role and demonstrated a significant survival benefit with the use of dexamethasone. High dose dexamethasone they've utilized for 5 days, 20 milligram OD for 5 days, followed by 10 milligram OD, and subsequent tapering of dexamethasone has been advocated, and with a tapering regimen, and they have found to have survival benefit in these patients, and including ventilator-free days. So DEXA ARDS has advocated the use of high-dose dexamethasone in patients with ARDS, and then it was supported. This was published at around 2024-25. And Sarki guidelines, that is also, it is published in 2024, again, including several sub-analyses they suggest that the role of high-dose dexamethasone should be there in patients with severe ARDS. So this is a summary. These are the summary of all the guidelines, that is ATS guideline and Sarki guidelines, where they have actually highlighted the role of dexamethasone, that is 20 milligram OD for 5 days, followed by 10 milligram OD for 5 days up till extubation, or methylprednisolone can also be used, that is 1 milligram per kg for 14 days, followed by tapering over 20 days. They have not only utilized glucocorticoids in a critically, not for shorter duration. In fact, they have highlighted the tapering of a lot of times we are confused whether to taper glucocorticoids or not, but this time they have given clear-cut guidelines that how to taper glucocorticoids in a critically ill patients. So 1 milligram per kg of methylprednisolone can be given for 14 days, followed by it can be tapered 2.5 milligram per kg per day. And again, high dose methylprednisolone 2 milligram per kg has also been advocated, and which can be given for 7 days and tapered over 32 days. So this is a summary of all the trials for the use of glucocorticoids in ARDS patients. So if you talk about the 3 important indications of use of glucocorticoids in critically ill patients, one is septic shock, the other is ARDS, and third is severe CAP. Septic shock, we have already discussed the use of hydrocortisone in patients with septic shock, the patients who are already on vasopressor at a dose of 0.25 microgram per kg per minute for at least 4 hours. And ARDS, again, they have said, then a patient with moderate to severe ARDS, role of high-dose dexamethasone is there, 20 milligram OD for 5 years, as per DEXA ARDS trial. And severe community-acquired bacterial pneumonia, there is role of hydrocortisone as per Cape Cod trial. So there is strong recommendation for administration of corticosteroids in adult patients hospitalized with severe bacterial community-acquired pneumonia. Corticosteroids in COVID-19, so we all know the recovery trial which was published in 2021, which has advocated the use of dexamethasone 6 milligram daily for up to 10 days. So this we all have used, and we are all aware of this recovery trial. So another important indication of use of glucocorticoids in emergency and in critical care setting is the HIV-associated pneumocystis jirovecii pneumonia infection. So in this pneumocystis pneumonia, moderate to severe PJP patients without HIV, there is role of use of glucocorticoids in these patients. Tablet prednisolone can be initiated, especially if the partial pressure of oxygen is less than 70 millimeters of mercury and alveolar arterial oxygen gradient is more than equal to 35. There is hypoxemia on pulse oximetry, that is SpO2 is less than 92%. And patients who...
Ma'am, sorry to interfere. Ma'am, your time is up.
Okay, I'll just take 5 more minutes.
Ma'am, try to reduce it.
Yes. Patients who worsen clinically and meet criteria for glucocorticoids while receiving anti-pneumocystis therapy. Okay, so we all know that there is role of glucocorticoids in acute exacerbation COPD patients, wherein both methylprednisolone, dexamethasone can be used along with short duration hydrocortisone can be used. Another important indication of use of glucocorticoids in critically ill patient is adrenal crisis, where you can give bolus of 100 milligrams of hydrocortisone followed by 50 milligrams of hydrocortisone. And alternately, you can also use IV infusion of hydrocortisone 200 milligrams over 24 hours, and specific mineralocorticoids is not required because your mineralocorticoid demand is fulfilled by hydrocortisone which is being given. Another utilization of steroid in the critically ill patient is anti-edema measure, wherein we can use for brain metastasis and any space occupying lesion, we can use dexamethasone 6 mg TDS or 8 milligram TDS 8th hourly can be utilized in patients with to reduce your brain edema. Another important indication of use of corticosteroids in emergency setting and in critical care setting is tuberculous meningitis, that is TBM. Patients with grade 2 or grade 3 BMRC disease, IV treatment for 4 weeks is given, 0.4 mg per kg for 1 week, followed by 0.3 mg per kg per day for week 2, and tapering dose of dexamethasone can be given, followed by 4 weeks of oral therapy of prednisolone can be initiated. Another important indication of use of corticosteroid is hypercalcemia of malignancy and new treatment option. Therein, we can use 200 to 400 milligrams of hydrocortisone. And then transverse myelitis is another important indication. It is an acute emergency where we use IV methylprednisolone 30 mg per kg up to 1000 milligrams daily. We have a lot of rheumatological emergencies where we can use methylprednisolone as a pulse therapy along with other immunotherapeutic agents. Then inflammatory bowel disease. In patients with in severe, moderate to severe inflammatory bowel disease, we can use either oral prednisolone or methylprednisolone 60 mg per day according to the severity of the patient coming with. And autoimmune hemolytic anemia. And last but not the least is angioedema, where there is a role of hydrocortisone, clear-cut role of hydrocortisone in critically ill patients. So there are n number of uses of corticosteroids in critically ill patient, but using the right dose of hydrocortisone and understanding Whether it is required as a short duration of dose or a low dose is required or a higher dose is required should be actually based on the guidelines and on the extensive evidence given in and supported by the RCTs and meta-analysis. We cannot just randomly start steroids in any patients because use of steroids is basically a double-edged sword in a critically ill patient. It can increase the mortality if given in a tubercular patient. It leads to hyperglycemia and increase incidences of hyperglycemia in patients who are critically ill can itself have an impact on increased mortality on these patients. Thus, understanding your patient and knowing the correct diagnosis and then treating these patients is absolutely need of the hour. Thank you so much.
Thank you.
Thank you, ma'am, for such enlightening topics. I am always interested to listen from you from my UG times. हमेशा के लिए मेरे जब भी आपको सुनता हूँ तो मुझे लगता है और जिस हिसाब से आपने बताया वेरी सिंप्लीफाइड वे दैट इज़ द वेरी करंट इशू कि कहाँ स्टेरॉइड का यूज़ करना है कहाँ पर नहीं चाहे सीवियर सेप्सिस हो ARDS हो कोविड जहाँ पर देखा जाए तो देयर इज़ द लॉट ऑफ तो बस एक लास्ट क्वेश्चन है मैम आपसे कि हाउ वी कैन राइट बैलेंस because there are the chances of secondary infection, there are the chances of secondary, so how we can right balance the steroids use, ma'am? Only last question.
So I'll tell you from my latest experience that my postgraduates, after reading this Cape Cod trial and then the DEXA ARDS trial came, madam, all of them were starting patients on DEXA 20 milligram OD. And irrespective of the fact that they were not differentiating these patients as having severe CAP versus ARDS or bacterial pneumonia versus influenza. So having the correct history and correct categorization of the patient and understanding whether your patient requires low dose corticosteroids or high dose corticosteroids and how much where the tapering is required. In acute exacerbated COPD patient, maybe tapering is not required, as we all know, whereas the other patient tapering would be required. In severe ARDS, you are starting with high dose dexamethasone in these patients. And again, if the patient is having stress hyperglycemia, correcting the treatment of that hyperglycemia, starting your insulin infusion would be beneficial in these patients. So correct dose, correct diagnosis, and for what is the indication of starting the steroids is just not starting the steroid blindly is absolutely is the need of the hour.
Thank you, ma'am. House is open for questions, and if any.
So a wonderful talk, Dr. Nidhi. So my take on this issue is, I think let us be more practical and more scientific. So if we can have the facility, that is point of care facility, to immediately go for the serum cortisol in any septic patient. And if it comes down to be lesser than what is expected out of that patient, maybe apparent adrenal insufficiency. So for example, the absolute serum cortisol is less than 12 microgram per deciliter. I think they are the right candidate to be started with steroids. And
yes, sir. So only in patients with maybe the patient who are presenting already in severe ARDS, we don't have much time, or septic shock already on noradrenaline and the patient is not improving, maybe we don't have that much time to get the cortisol values.
So I think apart from this very sick patients, others where we need to take this is a pinch of salt. I think this adds value to the.
And we can also do ACTS stimulation test.
Exactly.
Lot of chronic liver disease patients have been found.
So this remains a gray area till the time we came to a conclusion that even the COVID response to dexamethasone, many more deaths they have already taken place. So I thank you very much for your question.
Thank you so much, ma'am, for that wonderful session. Now I request our chairperson to felicitate our speaker, Dr. Nidhi Kelly, ma'am. Now, to felicitate our chairperson, I request Dr. Namrata Gaur ma'am to felicitate Dr. Anirudh Mukherjee sir and Dr. Mahendra Meena sir. Moving on to our next talk, immune prophylaxis in sepsis, rationality and reality in clinical practice. To enlighten on this topic, we have with us Dr. Anirudh Mukherjee sir, Associate Professor at Department of Medicine, Aiims Rishikesh. Let's welcome our chairpersons for this session, Dr. Dharab Singh sir, Assistant Professor, Department of Medicine, Aiims Rishikesh, and Dr. Sahil sir, Consultant Physician and Expert in Critical Care. Let us welcome sir to share his valuable insights.
Very good morning to everybody. So what I have in front of me is a very interesting topic. When it was allotted to me by sir, so I don't even doubt whatever he suggests for even 1 second, because I know that this is the future. And he always insists on talking on the future, so whatever I could manage a little bit of research, and I compiled it together and I bring forward towards you in a very concise manner. A very good morning to all. So the topic is immunomodulation in sepsis. So I briefly start with the introduction, epidemiology, sepsis, and what are the immunotherapeutic agents, and the conclusion. These 4 pillars is going to be my agenda of the day. So sepsis, everybody knows that it's a dysregulated host response to infections, and septic shock is when there is a compromise in the organ perfusion. So as far as epidemiology is concerned, India, as you can see, has the highest load of mortality, around 36% overall. So what is our problem statement? The problem statement is sepsis has persistently posed a new critical challenge to the healthcare system throughout the history. This is nothing new. We know this for a long time. Early recognition and timely management improve the critical care in a place, and we are actually improving in it day by day by the modalities of multiple research and improving our clinical approach. We are actually improving. Every other cause of death in a tertiary care center is sepsis. There is still a lot of scope of improvement left in this regard. Still, in a tertiary care center, I mean, the highest load of mortality is always sepsis related, no matter wherever you go. So what do we understand by immunomodulation? So we know that sepsis is a dysregulated immune response. So whenever we think about immunomodulation, it actually becomes extremely lucrative to say at the least, yes, this might be the answer. This is actually the answer, and this is how we can change and revolutionize the way we approach a patient of sepsis. So what are the immunomodulators till date, what we know? So we have got glucocorticoids, we have got blood purification techniques, we have got immunoglobulins, GM-CSF therapy, and specific immunotherapy targeted to specific interleukins and PD-1s. And there are many more. Due to paucity of time, I won't be able to get in all of this. So is it actually the answer? What does the research say till now? So right, as far as glucocorticoids are concerned, I won't put a lot of stress because already Dr. Nidhi Kile has put in a lot of stress on this topic. So yes, large centered trials like the adrenal trial and the surviving sepsis campaign, they do actually recommend the use of glucocorticoids in moderated dose after adequate fluid and vasopressor resuscitation. Right. So what blood purification techniques do we know? So blood purification techniques mainly depend on the broad clearance of the toxin load. So basically there are 4 modalities in this, like high volume hemofiltration, coupled plasma filtration adsorption or CPFA, extracorporeal cytokine hemoabsorption, and end-toxin hemoabsorption. So what are the basics? There are basically 2 mechanisms by which the blood purification technique is followed through. So one is hemofiltration and one is hemoadsorption. Now if we go back to our school, what do we understand by filtration? Filtration is mainly done through the convection technique, right? And hemoadsorption is from the adsorption technique. So what is convection? Convection is based on the removal on the molecular size. And what is absorption? Adsorption is binding of that molecule to a specified cartridge. So which is going to have more selectivity? Obviously adsorption. Which is going to have more protein loss because you are attracting the solvent. More protein loss is with hemofiltration. Which one will have more fluid loss? Obviously one which attracts the solvent, which is hemofiltration. And which is more relevant to sepsis? More or less both of them are relevant to sepsis. And now we'll look at the trials which have gone through. So there are basically 2 kinds of modalities in this. One is an intermittent and the other one is continuous. So the intermittent is one which we have seen during our medical college days, or we are seeing right now also, that is therapeutic plasma exchange. And this is an intermittent method. And then we have a continuous method which has 4 pillars in it, or 4 aspects of it, like high volume hemofiltration, ultra high volume hemofiltration, pulsed high volume hemofiltration, and coupled plasma filtration and adsorption. Right. So what do you understand by high volume hemofiltration? High volume hemofiltration is nothing but a glorified name for CRT, what we are already doing in our patients. So ideally the exchange rate is kept between 50 and 70 ml per kg per hour. What does the trial say? So a large multicentric trial by the name of Aiims trial was done, and after the meta-analysis, we came to know that this technique is actually having no benefit on the patients, whether it's coming on survival rate, whether it's coming on prevention, or whether it's on restoration of the renal function or incidence of adverse effects. Coupled plasma filtration absorption, this is actually an hybrid technique which incorporates both filtration and separation. So a large trial by the name of compact trial was conducted, and after compact trial, I mean the results were again that CPFA neither improved the mortality or the morbidity or clinical outcomes in these patients. When trials related to extracorporeal cytokine hemoabsorption were done, again the results were not very encouraging. I mean, it was being able to decrease the interleukin-6 levels, but it did not have any significant effect on the mortality and morbidity, let alone the PaO to FiO2 ratio. So now, if we take some antibiotics into consideration for immunomodulation, like polymyxin B hemoperfusion has been used in lot of cases, and multiple trials have been done by the name of UFAS trial, Abdomix trial, and Euphrates trial. At the end of the day, I mean, it was actually bringing down the endotoxin activity levels, but when compared together, the end result was again the same, that there was no statistically significant improvement in these patients in all these 3 trials. So one trial had 64 patients, the other one has 240 patients, and at the end, Euphrates trial was done with around 450 patients in 55 tertiary care hospitals across United States of America, but still the results were not statistically significant. So therefore, the Surviving Sepsis campaign in 2021, they recommended, they recommended against the routine use of polymax in B infusions, though there's a weak recommendation in these trials. So next we have immunoglobulin therapy. So a big trial by the name of Sibit's trial was conducted. It was a very high quality RCT with induction of polyclonal IVIG, but at the end of the day, but at the end of the day, based on the results, again the SSC guidelines have advised against the routine use of IG preparations, with only weak recommendations from these studies. We have been also using GM-CSF nowadays in sepsis patients. Though GM-CSF is, again, it sounds extremely lucrative. I mean, it does improve immune paralysis, it does improve lymphopenia, it does improve the low monocyte HLA-DR expression. But then again, at the end of the day, when the patients groups were compared, the individual improvement was there in certain aspects, but overall the morbidity and mortality of the patients did not have any statistical difference. So what are the other immunotherapeutic agents which are in the pipeline for now? So one molecule by the name of nivolumab is being developed, and it works by blocking the PD-1 receptors, the PD-1 pathway. So though the results initially are very promising, but since this molecule is in the phase 1, as of now, giving a concrete comment in this is very difficult. So how do we conclude? Our current understanding of immunomodulator use in sepsis remains at a very early and evolving stage. Still a lot of research is required. Although the modalities such as polymaxin B hemoperfusion are not routinely recommended, ongoing studies continue to evaluate their role in PLEX, cytosorb, and other extracorporeal therapies. Further research is obviously required in this field, and it is actually lucrative, but let's see what happens 10 years down the line. Thank you. Thanks a lot.
A wonderful talk by the Dr. Anirudh, immune prophylaxis in sepsis patients. So, you have explained which immune prophylaxis should be given. Suppose a case of the COVID-19 patient comes to our OPD, or whether patient is admitted. So on which day immune prophylaxis should be started? How we decide?
By the meaning of immune prophylaxis, are you stressing on the use of steroids? Or
yes, steroid.
So ideally in COVID-19, at times we got a little overcautious, right? We got a little overcautious, and some people actually gave in to the invitation, the lucrative invitation of initiating a steroid early on in the therapy. But what has been seen that it does have its adverse effects. So ideally, as soon as the immune response, you are having the body's immune response against your dead viral load, that is the right time to initiate steroids around, I think, day 4 or day 5, whatever I have read.
Means steroids should be started on the grading
day 4 or day 5 after the patient becomes afebrile. So it is ideally around day 4 or day 5, before the actual immune surge begins and your cytokine storm is there.
Okay, thank you. Any question from the audience?
Dr. Anirudh, there are many patients they admit with pancytopenia.
Yes, ma'am.
Right, so what are the indication for the granulocyte stimulating factor in such patient?
Right, ma'am. So, ma'am, depends on the etiology. So like routinely use of GM-CSF is not recommended. Routine use of GM-CSF is not recommended. I think, ma'am, if the etiology does not lie in the marrow, we can actually go ahead for GM-CSF therapy.
Because it takes times to find out the etiology of that pancytopenia. Lot of investigation required, it takes time. So What?
So what I do in my geriatric patients, ma'am, I do follow the neutropenic measures in them, and at times I do try to initiate them on GM-CSF therapy. But then at the end of the day, it becomes very difficult for me to understand that whether he is improving because of GM-CSF or he is improving routinely with the other modalities. So I don't have a very concrete answer to this question.
Okay. So if the neutrophil count less than 500, then we can give.
We can go ahead, ma'am. We can go ahead. We can.
Sir, one question. The use of cytosope therapy, like endotoxin binding therapy, in sepsis, severe sepsis patients, sir. What is the exact time? I know it is not in the guidelines and not recommended yet, but what should be the exact time to start it?
See, since there are no strong recommendations, as I showed that the trials did not give any strong recommendations, so I could not come across any such literature in the public database as of now. I did try to look for it, but there was no such literature present.
Right, sir.
Because there is no recommendation as of now.
Yes, sir.
Maybe 10 years from now, as I said.
Yes, sir.
Yeah.
Thank you, sir.
Thank you. Thank you.
Thank you so much, sir, for that informative session. I would request our chairpersons to felicitate our speaker. To felicitate our chairperson, I would request Dr. Seema Mahat ma'am to felicitate our chairperson, Dr. Sahil sir. Now, we will be commencing on the official inauguration ceremony of the Cardiodiabetic Society Conference. Hello.
Hello, 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 hello. Cheek test, cheek, 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 cheek test, cheek, 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 cheek.
We'll continue our scientific session program after the inauguration program. Good afternoon, everyone. I, Dr. Anushka,
And I, Dr. Mudita,
junior residents in the Department of General Medicine, Aiims Rishikesh, welcome you all to the official inauguration of the 6th Annual Conference of the Cardiodiabetic Society. It's an honor to have amongst us distinguished researchers, healthcare professionals, and leaders who have come together to discuss and advance our understanding of medical sciences. We are glad to have among us our chief guest, Professor Ashutosh Vishwas Sir, Director, Aims Bhubaneswar. I would like to request our Director, Professor Meenu Singh Ma'am, to welcome him with a floral bouquet. I would like to request Professor Ashutosh Vishwas Sir to come on the dais. Please be seated, sir. Please be seated. I request Dr. Jaya Chaturvedi ma'am, Dean Academics, Dr. Ravikant sir, Dr. Mukesh Berwa sir, and Dr. Anirudh sir to come on the dais. We are glad to have among us our guest of honor, Professor Meenu Singh Ma'am, Director and CEO, Aiims Rishikesh. I would like to request our organizing chairperson, Professor Ravikant Sir, to welcome Ma'am with a floral bouquet. I welcome our special invitee, Professor Jaya Chaturvedi Ma'am, Dean Academics, Aiims Rishikesh. I would like to request our organizing co-chairperson, Dr. Mukesh Berwa Sir, Additional Professor, Department of Medicine, Aiims Rishikesh, to welcome Ma'am. I welcome our organizing chairperson, Professor Ravikant Sir, Professor and Head, Department of Medicine, Aiims Rishikesh. I request Dr. Anirudh Mukherjee Sir to welcome Sir with a floral bouquet. I welcome our organizing co-chairperson, Dr. Mukesh Berwa Sir, Additional Professor, Department of Medicine, Aiims Rishikesh. I request Dr. Dharam Singh Sir to welcome Sir with a floral bouquet. I welcome our organizing secretary, Dr. Anirudh Mukherjee sir, Associate Professor, Department of Medicine, Aims Rishikesh. I request Dr. Akhilesh sir to welcome him with a floral bouquet. We'll now begin the event by invoking God's blessing. I would like to invite Professor Ashutosh Vishwas sir, Professor Meenu Singh ma'am, Professor Jaya Chaturvedi ma'am, Professor Ravikant sir, Dr. Mukesh Verwa sir, Dr. Anirudh Mukherjee sir, and all our respected faculty members to kindly come forward for the lamp lighting ceremony symbolizing the light of knowledge and wisdom. Thank you so much, everyone. I now take the privilege of inviting our organizing chairperson, Professor Ravikant sir, to deliver the welcome address.
Thank you so much for inviting me. Very good afternoon to all distinguished guests. I am indeed privileged to deliver the welcome address of the 6th Cardiodiabetic Society Conference at Aiims Rishikesh. At the very outset, I am thankful to the Executive Director and CEO Aiims Rishikesh for creating an academic milieu of high standard that keep us inspiring all the time for bringing value addition to every other event that we host at Aiims Rishikesh. We welcome you, Madam, to the 6th CDS conference as a guest of honor and really an inspiration for our more and more activities. Your unwavering guidance and support is the key to CDS. I had the honor to welcome Dean Academics, Professor Jaya Chaturvedi ma'am, for being with us, who is an unparalleled support for the activities of not only CDS but in general in the institute as such, right from small CMEs to the annual conference that we host at Aiims Rishikesh. We welcome you, ma'am, to the CDS 6th conference. We have our chief guest for the event, Professor Ashutosh Vishwas sir, Executive Director and CEO of Aiims Bhubaneswar. Professor Ashutosh Vishwas sir needs no introduction. Sir has been instrumental in devising national and international guidelines for established infectious disease and emerging diseases as well. We have so many guidelines in place by him. Sir, the Aiims Rishikesh and CDS welcome you here for the 6th conference of the society. We welcome faculty members from Professor Rajneesh Joshi, Professor Seema Mahant from Aiims Bhopal, Professor Jyoti Prakash from Aiims Patna, Dr. Anirudh Mukherjee, Dr. Mahendra Meena from Aiims Raebareli, Dr. Prabhat Raina, Aiims Bhatinda, Dr. Kapil Sharma from Aiims Bilaspur, many other faculty members from state medical colleges, from within the institute and from other institutes from country across. for the valuable inputs and the addition that you have done to CDS. We welcome delegates from across the country and taking out a very active participation in the same. So last day we had a complete PG program. I think it was a wonderful, successful program by the delegates who have come across to us. We welcome the media and both offline and online for the event. I welcome the support staff from the institute, the residents, the pharma companies, and the office bearers for the CDS, and those who have not been named, they are most welcome to the 3-day event of CDS. With this, I thank you all very much for your gracious presence to this occasion. Thank you.
Thank you so much, sir. Next, I request our Dynamic Dean Academics, Professor Jaya Chaturvedi ma'am, to kindly address the gathering.
Good morning, everyone present here. Respected dignitaries on dais, our chief guest, Vishwas sir, director ma'am, all other members sitting on the dais and off the dais, dear delegates. I'm really, really very happy to see you all here gathering in this recurring Cardiodiabetic Society conference. This is the 6th conference in the row, and I really congratulate our team headed by Dr. Ravikant to organize such event every time with full enthusiasm. And I congratulate you all to participate in this cardio-diabetic, because this needs awareness, this needs education, this needs lot of interventions, everything which you have to learn and you have to disseminate in the society. So all the best, and thank you for inviting me here.
Thank you so much, ma'am. It is my honor to invite Professor Meenu Singh ma'am, Director and CEO, Aiims Rishikesh, to kindly address the gathering and share her words of wisdom.
Thank you very much. Honorable Chief Guest for this morning, Professor Ashutosh Vishwas, Executive Director and CEO, Aiims Bhubaneswar. Organizing Chairman, our Dean Academic, Professor Jaya Chaturvedi. Organizing Chairman, Professor Ravikant. Organizing Co-Chairman, Dr. Mukesh Bairwa. Organizing Secretary, Dr. Anirudh Mukherjee. All the faculties who've come from different Aiims, senior faculty members, our own faculty from Aiims Rishikesh, participants who've come to learn about cardiodiabetic conditions. Actually, this is the 6th conference of Cardiodiabetic Society, and it's kind of become a trademark of Professor Ravikant, because he is such a protagonist in this particular field in about teaching about diabetes, which is not only to doctors, but also to nurses and allied health professionals. And I can see many nursing professionals who are participating in today's proceedings, which is actually meant for the holistic development of this particular field. And as we know that diabetes is an epidemic which is growing by leaps and bounds, and India is becoming the diabetes capital of the world. And we really need to take preventive measures, and even the government came out with a program for prevention of non-communicable diseases, mainly focusing on exercise, weight reduction, food, the kind of foods that we eat, and maybe there are many other toxic substances that we are consuming, which is actually leading to this particular problem. As we know, diabetes is actually one of the cardiovascular diseases. It is classified as a cardiovascular disease, and because it has very important effect on the cardiac as well as vascular system. And most of the times we know that diabetics suffer silent heart attacks, and sometimes a person who has a diabetes or which is relatively uncontrolled would be prescribed medicines for like grade 1 heart disease. So these are some of the things which one has to be careful about. So one is about preventing the disease, secondly about treating it effectively so that they don't land up in complications. And we know that diabetes, as we know, is also considered to be a silent killer because it can involve the heart, kidneys, eyes, and you say every organ of the body. So every specialist actually has to participate in this. It is not just cardiologists or diabetologists. It is also the nephrologists and the ophthalmologists, and I think even the neurologists, which have to be working in on this particular disease. And all this can be done with prevention and effective management of this particular condition. So we have our experts today with us, and we have Professor Ashutosh Biswas, who is himself a professor of medicine and who's been in All India Institute of Medical Sciences, New Delhi for a long time. And his work is mainly focused on infectious disease, but I'm sure he will be leading you with and giving you a lot of knowledge about this particular disease. Thank you very much for inviting me. Jai Hind, Jai Bharat.
Thank you so much, ma'am, for your inspiring words. We are privileged to have with us Professor Ashutosh Biswas, sir, Director, Aims Bhubaneswar. I would like to request sir to address the gathering and share his insights with us.
Good afternoon, everyone. Professor Dr. Meenu Singh, Dr. Jaya Chaturvedi, Dean Academic, and Dr. Professor Ravi Kant, Organizing Secretary, Dr. Mukesh and Dr. Anirudh, and other faculty members and participants for this 6th Cardiodiabetic Conference in Aiims Rishikesh. It's really a great pleasure and honor to be here today in this August gathering. A very important area, very challenging and very difficult also to manage these combined complications, diabetic and cardiovascular diseases together. And I'm extremely happy that this team, the group of people, they came together and formulated a society that cardiodiabetic. Cardiac society is there, diabetic society is there, but cardiodiabetic, is I think first time that somebody thought probably there is some importance, a gap to fulfill, and there are points I think to address for these combined complications, combined phenomena, cardiac involvement in diabetic. I don't think is a unknown to everyone in India India is the diabetic capital of the world. So at least what a huge burden the population of diabetic population, which is playing important role for morbidity and mortality in cardiac diseases. It is also observed that more than 60%, 60 years after 60 years, 2/3 of deaths are occurring due to diabetic. So the morbidity and mortality as such is very high, and if you go higher and higher. And across India, the prevalence of the diabetic, somehow 10 to 15%, if you go higher, above 40, maybe 20%, above 50, 30, above 60, maybe 40% of the people are suffering from diabetic. So these cardiac complications, cardiovascular diseases, heart diseases, among the diabetic populations, number is huge. And a cardiologist may not have much idea about the endocrinological knowledge about diabetes, how the glycemic control and what. So they're focusing on the heart. And endocrine people, probably those who are dealing with the diabetes, may not have much about the management and complication of the heart disease. I think this group, they are going to discuss about the combined knowledge of cardiology and then diabetes. How this cardiovascular manifestation complications are associated with the diabetic and how we are going to prevent. There are many things I think to know, understand the preventive strategy to be developed. If anyone is suffering from diabetic, is not going to be cured for, is not for 5 years or 10 years, is going to be lifelong for you. But how to control this glycemic control, tight control, and then prevention of diabetic cardiovascular complication. Diabetic is not only it affects heart, everybody knows. It affects the other system as well, the eye, brain, kidney, and vasculopathy is a very important through which that it affects many organs, and therefore it causes the coronary vessels, the vessels, and then your muscles, cardiac muscles, and then nerves. So cardiac neuropathy, cardiomyopathy, and cardiac vasculopathy are the three important component, very major component that a patient of diabetic suffering through a very slow process. And sometimes it is very important that a diabetic patient will have heart attack without any symptoms, may not have a classical symptom of non-diabetic patient having cardiac attack. So that is a very important message to go into the community, and this should not be into the society only, this should come into the community, and community awareness is very important when you have this kind of diabetic having complications of the heart disease, cardiovascular disease, how you are going to be suffered, and then vasculopathy, likely to have a stroke is a very serious issue in our society now, stroke. And this all through this diabetic complication, metabolics, and metabolic milieu is a very important challenge for this. And so there are many ways now to look into this branch, this field. And the pathogenesis is a very important phenomenon, and still we need to know much about the diabetic and then involvement of the cardiovascular, cardiac vessels and the nerves, cardiac nerves, the cardiac neuropathy. Having autonomic neuropathy of the heart is very important phenomena, where we go for the electrical disturbances to see through the ECGs much before it is full blown that you are going to have. And also without vascular occlusions, the coronary occlusions, you may have a cardiac dysfunction, cardiac muscles dysfunction leading to cardiac failure. Then you may not know, and you are thinking probably all coronary is fine, but may develop gradually that cardiac muscles is becoming weak, and then only cardiomyopathy is going to, and cardiac failure, muscles failure is going to have in future. So how to know early diagnosis, early indicators, then molecular markers, and some markers, other markers, what are they, how we are going to predict, and prevention. That is a very important, the early diagnosis is a very important. And if somebody is having diabetic, now how frequently he is going to be, you are going to send this patient to cardiologist. You always, okay, go for ECG, there is nothing, okay, you are fine from the heart. Is not. Cardiac electrical disturbances may not be at the earliest stage to diagnose, but there are, as I say, that the muscular dysfunction, you need to so many other investigations to know. The echo you have to know. So are you going to refer this diabetic patient to cardiologist when he is not having any cardiac symptoms? Is it a routine phenomena that after 3 years, 4 years, we know that diabetic, if it is onset, then after how many years you are going to develop cardiac, diabetic neuropathy, diabetic retinopathy, and vasculopathy. is a time bound sometimes. As the time progresses and the incidence and the prevalence of this involvement of the various organ also increases. But we have seen also, first time the patient is coming with the diabetic with the complications. Patient, they don't know. And about 15-20% of the patient may have this of the diabetic patient. First time they realized with these complications. And renal involvement, sometimes vasculopathy, neuropathy is also involved, the patient is coming. And then organ involvement, the heart is a very important organ that we already know, and how to prevent as is a very serious risk factor, diabetes for the heart. Now it's a, and this is the only I think risk factor other than, as we know, the weight, dyslipidemia, your cholesterol and the eating habit, your weight and your exercise, diet, lifestyle modification, all we know that yes, this is going to keep your health fit. But do we have any exclusive channel that is diabetic and then cardiovascular assessment and assessment of the risk factor, that I am not going to have a coronary occlusion another maybe 3 years or 4 years down the line. That is the research area. This is the group, or they are going to have, yes, if you have, you do have any tools to say, to predict, okay, after 7 years you are going to have heart attack. Do you have any prediction model to have? The researchers are going to develop this because we have now artificial intelligence. Exactly we can know the arterial thickness, arterial contour, arterial elasticity, arterial calcium score, arterial all, everything that is going to project that if you are going to have progression of this kind of pathogenesis and pathological abnormality is occurring in patients of diabetic, it will take 7 years, 5 months to occlude and to cause your coronary vascular disease. So that is a prediction, and we have a precision medicine. We are going to have composing everything, all the factors, your weight, your lifestyle, and your fat compositions of your body, your content, daily content of the fat, protein and carbohydrate, how you are going to, you are consuming the daily, putting this everything, and then we are going to predict your lifestyle in future and disease progression and disease prediction, appearing a new disease. That is a precision medicine. Exactly we are going to have that kind of model in future to practice medicine. So we need to go further, many ways to understand the heart always is beating without taking rest, maybe contraction and relaxation time only is the rest, and that is also active, we are not sure, electrical activity all the time going on, and diabetic is directly also affecting the nerves, the neuropathy. We have the peripheral neuropathy directly, but how many people are working on the cardiac autonomic neuropathy, cardiac neuropathy? How long it takes to develop it? And without any other vascular disease, you are going to have electrical disturbances, arrhythmias, and your SA node, AV node, cardiac standstill, sudden cardiac death. So there are many things to predict. There are many cases now coming up in this. So diabetic is a huge, I think, huge area. The burden in our medical, it is a challenge in our medical science that we need to focus on. Is the best combination, the cardio-diabetic society. I think there are many challenges and we need to work on. There are potential research area also to work in. There are many people are working on it. They're combining how it is, So there are many areas to understand about the pathogenesis. Still we do not know much about how the vessels, how these metabolites, the ROS and your other lipoproteins and the fat, your contents of the body and different other, so many unknown factors are, I think, hiddenly playing important role for progression of the disease. And gradually, as we know, the diabetics, lot of other complications too, is not a diabetic cardiac involvement. At the same time, this diabetic patient suffering from multiple diseases. Hypertension is also another, is adding fuel to this fire. The diabetic and then hypertension adding much of complication, how to control that and how to manage that, and then your obesity and different other issues. Mental stress is a very important factor nowadays. And so we need to consider many things to keep your heart fit, and there are many, I think, areas to work, focus on, and this group is going to come out to think and to make a channel. Referral system is going to be established. That is a very good thing. Those who are working, the cardiology people, at least they will know how to manage this patient, diabetic patient, tight glycemic control, and how then to regulate many other ways. Otherwise now cardiac, you are having diabetes, refer to diabetologist. But by referral, it is not going to, and diabetic also, they should understand about the cardiac abnormalities, and sometimes you need a medical intervention and also surgical intervention. So at what point of time that a medical person, a physician, that he has to diagnose that this is a time for the surgical intervention or cardiac intervention to improve the cardiovascular conditions. So that indication is a very important. Early diagnosis, important area. So I think this society is going to bring out a change in the management of cardiovascular diseases among the people suffering from diabetic. And there are many things. I hope the research areas is going to open up. So hope the society is, and I am happy to know that also many Aims also joining this conference, and also many other medical colleges other than Aims, INI, and expecting this society is going to be a very large, strong society to address a very, very important challenges area to improve the cardiac health, cardiac diseases in diabetes, and also at the same time the public awareness is a very important. So that should also, a component of the society should have outreach to the community to create awareness about the cardiac involvement, cardiac complications, and how silent am I, and what are the other things, precaution, prevention strategies, what lifestyle, what is the food habit. Those things also is important to educate the community to have a very holistic approach. And Dr. Meenu Singh also told this is a holistic approach, it is not a one. We have to have many components into it, many multidisciplinary approach is not a one. So thank you very much for inviting me. Thank you once again. Okay, thank you.
Thank you so much, sir, for your inspiring words. We would now like to felicitate our esteemed dignitaries whose gracious presence has truly elevated today's events. I would like to request Professor Meenu Singh ma'am to kindly felicitate Professor Ashutosh Biswas sir. Thank you so much, ma'am. I request Professor Ravikant sir to felicitate Professor Meenu Singh ma'am. Thank you so much, sir. I would like to request Dr. Anirudh Mukherjee sir to kindly felicitate Professor Jaya Chaturvedi ma'am. Thank you so much, ma'am. I request Dr. Mukesh Berwa sir to kindly felicitate Professor Ravikant sir. I request Dr. Akhilesh sir to kindly felicitate Dr. Mukesh Berwa sir. Thank you so much, sir. I request Dr. Prakash sir to kindly felicitate Dr. Anirudh Mukherjee sir. Thank you so much, sir. With that, I would now like to request Dr. Anirudh Mukherjee, sir, Organizing Secretary, Cardiodiabetic Society, to kindly deliver the vote of thanks and formally conclude the inaugural session.
I thank you all for being here with us in Rishiyogi Nagari, where we can smell the essence of divinity in the air. And Cardiodiabetic Society has been successfully channelizing this divine energy, coupling it with scientific knowledge in the form of multiple CMEs, conferences at different aims. Also, we are covering programs for diabetic caregivers, insulin administration, and CGM are being offered as a whole. The future plans hold multiple fellowships and scholarships, and also journals which will have an impact factor in the scientific world. I, with all my heart, I thank our chief guest, Professor Ashutosh Bishwas, ED Aims Bhubaneswar, for his presence. Sir, you truly are an inspiration for young physicians like us. I truly thank our guest of honor, Director Aiims Rishikesh, Dr. Meenu Singh, under whose visionary leadership this institute is striving forward day by day, which is quite evident by the recent NIRF rankings. A round of applause. I thank the special invitee, Dean Academics, Professor Jaya Chaturvedi. I also thank Professor Satyashri, though she is not present right now, the MS of the institute. I thank the organizing committee as a whole. A special mention for Professor Ravikant, who is the unparalleled constant source of energy for all of us. Dr. Mukesh Bharwa, who always has a keen insight on everything we miss. I thank Dr. V.S. Pai, Dr. P.K. Panda, Dr. Dharab, Dr. Prakash, Dr. Akhilesh, who are an integral part of the Department of General Medicine at Aiims Rishikesh. I thank all our speakers, all our faculty members, resident students for their contribution. I thank our speakers, Dr. Rohit, Dr. Sahil, Dr. Ritu, Dr. Nidhi Kile, Dr. Mahendra Meena for their contributions. I thank all the media people who are present here to support our event and giving the details about the event to the public database. I thank the support staff, the IT team. I also thank the caterers who have prepared a delicious meal for you. I thank all the pharma companies for their contribution to the event. Please enjoy this academic feast and the wide buffet we have to offer. Jai Hind, Jai Bharat.
Thank you so much, sir. With this, we formally conclude this inaugural session. Thank you so much, everyone. All of you, please stand up for the national anthem. Jan Gan Man Adhinayak Jai Bharat Punjab Sindh Gujarat Maratha Dravid Utkal Ganga Vindhya Himachal Yamuna Ganga Uchchal Jaladi Taranga Tab Shubh Naame Jage Tab Shubh आशीष मांगे Thank you so much, everyone. We'll now continue with the scientific session program.
So we have varied vaccine serotypes, vulnerable population, awareness campaigns. So there are a lot of hesitancy in the clinician's mind as well as the general public. So history, this is 1977 to 2021 when we have PCV20. So I am going to talk more about PCV20 as to how this is different from other vaccinations and the burden of additional serotypes that we have, added in the last few years. 7 new serotypes have been added to already pre-existing PCV13. So it becomes PCV20. That is the rationality of calling it PCV20. So let us have a look into serotype coverage by pneumococcal vaccines in India. We have 8% added benefit when we compare with PCV13, and non-invasive 14% more coverage when we compare with PCV13. So this is a non-invasive community-acquired pneumonia. In those who are pneumococcal vaccines, you can see that as the age advances, more and more serotypes are involved. And to be very frank, these 7 serotypes which have been added to existing 13, they are very virulent. They carry a high fatality rate, and also the common causes of meningitis. It is associated with outbreaks. Propensity for antimicrobial resistance are very, very high, especially with 11A and 22F. Very high AMR. So antibiotics anyway are not going to do justice to these patients who are affected by pneumococcal infections, acute decomposition. So let us talk something about the overview of PCV20 vaccine. What is this? So how it works, it basically is a bacterial recognition, which is polysaccharide coating that immune system needs to recognize. Vaccine design, it is linked to a protein carrier. It activates the T cell and thereby produces the immunoglobulins. This is how it works. So what is it and how it works? Basically, you need to have 20 serotypes in the PCV20, and single intramuscular injection of 0.5 ml is to be given once only. That's it. That is the beauty of PCV20, along with other benefits which are there with the vaccine. So this is the clinical relevance and efficacy of PCV20 against PPSV. So this is a purified polysaccharide from 23 pneumococcal serotypes. If we talk about PPSV23, if we talk about PCV20, this contains polysaccharide from 13, 20 serotypes conjugated to carrier protein. Immune response is remarkable. It is long-lasting. No dose repetition is required, and there is no hyporesponsiveness if you require any further dose. I will tell you as to when you require a further dosage. So the special point to mention here is it covers non-invasive pneumonia, which is 85% of the total burden of the disease, whereas PPSV has no coverage of non-invasive pneumonia. So this is an added point. So you can even prevent these superficial infections. So clinical studies of PCV20 are many from across the globe, and if you look at the head-to-head trial with PCV20 against 13, PCV20 against PPSV23, PCV20 in those who have received earlier PPSV or PCV13 are rarely a game changer in current scenario. All PCV20 recipients are, at a step ahead of the other vaccinations if we consider the head-to-head trial. This has a comparable reactogenicity and lower adverse rates across PCV13 and PPSV23. So I mean here that PCV20 carries much more weight so far as immunogenicity is concerned, so our protection from the recurrent pneumonia is concerned. PCV20 induced robust immune response. How do we know? We have OPA GMT. Oh, what is OPA? This is opsonophagocytic activity, which is basically in vitro activity measured for the vaccine. And at the same time, we have geometric mean titer of the vaccine. So this is how we get to know what is the protection by these vaccines. So OPA GMT is really very high across serogroups of the pneumococcal vaccine, that is PCV20. These 7 additional are very well covered by the PCV20. OPA geometric mean ratios, that is GMR, in participants in more than 60 years are really promising. And PCV20 induced robust immune response to all 20 serotypes in adults more than 60 years as well as less than 60 years. So it is equally effective in 19 to 49 and more than 50 years and equally effective in more than 60 years. So I mean to say that you can give this vaccine right up more than 18 years till more than 70, 75 years and whatever. I'll come to the indications as to how you have to titrate the. It has a proven safety comparable to that of PCV13 and PPSV23 in more than 18 years. I mean, the safety and immunogenicity of 20-valent pneumococcal conjugate vaccine co-administered with quadrivalent. What happens if you give quadrivalent influenza vaccine with pneumococcal vaccine? Is it possible or not? Till today, we thought that it should not be given together. One is bacterial, one is viral. So, I mean, but the robust data says that yes, there is a possibility of co-administering them. We had 3 randomized double-blind trial, 3 arms when we gave both vaccine together, whereas in one arm we gave only one vaccine and we had a comparator as placebo. So it has fared very well, and key outcomes of the study on PCV20 co-administration was, it was non-inferior immune response, robust immunogenicity, no serious safety concerns, and supports simultaneous vaccination. It cuts down the visit of the patient also to the hospital or healthcare. So co-administration of pneumococcal vaccine, PCV20 and quadrivalent influenza vaccine is a possibility as of now with PCV20. Safety and immunogenicity of PCV20 vaccine in pneumococcal vaccine, naive, more than 18 years patient in India. We have data to support that patients who are more than 18 years of age having one comorbidity must be immunized. Say, for example, the patient is having a CKD or CLD or congenital heart failure or maybe some other comorbidity. If he has, say, for example, young onset diabetes, type 1 diabetes, they are the comorbid conditions. They must be immunized if they are more than 18 years of age. So the local reactions are really very low and systemics are almost non-existent. So OPA GMT before vaccination to 1 month after vaccination, as the age is increasing, it is promising. And so the study summary of the results are exposure, all 400 patients were given the PCV21 single dose. Most local reactions, systemic reactions, events were mild. Immunogenicity results are robust immune response to all 20 vaccine serotypes of type 1 after 1 month of PCV20 across the ages. So it was observed to be well tolerated with an acceptable safety profile in India, more than 18 years of age. What is a schedule of vaccination by age? That is a practical tip which all of we need to remember. The practical tip is if the person is more than 50 years of age, if he is a pneumococcal vaccine naive or unknown, it is indicated. If one person has received PCV13 more than 1 year back, you have to immunize. If PCV13 at any age and PPSV less than 65 years, but the total duration has more than 5 years, you have to immunize. And supposedly, a patient is 19 to 49 years, you have to look at the underlying risk factor, you have to immunize. 19 to 49 years, you have to immunize. And 19 to 49 and 50 is the age where you need to reconsider the PCV again. Once 18 year or 20 years or 25 year gentleman becomes more than 50 years, you have to take a call again, whether you need to give it or need not to give it. So the hyper-responsiveness with PCV20 is not existent, almost non-existent, so you have to repeat it. And there is a shared clinical decision more than 50 years to those who have been vaccinated before. I think data is ever evolving. Target population for PCV20 is more than 50 years, adult more than 19 years with risk factor, who have not previously been vaccinated and whose vaccination history is unknown. So they all are candidates. Key message from my talk is PCV20, which is a 20-valent pneumococcal conjugate vaccine, extends protection by including 7 additional serotypes beyond the 13-valent pneumococcal conjugate vaccine. ACIP recommends a single dose of pneumococcal 20-valent conjugate vaccine for adults aged 50 years and above who have not previously received the pneumococcal vaccine. PCV20 provides broader coverage with long-lasting immunity compared to the other vaccines, as well as well-tolerated and immunogenic in previously vaccinated adults more than 65 years of age and more than 18 years of age. PCV20 may be administered concomitantly with seasonal influenza vaccine at one go. This is the beauty of the vaccine. So with this, I thank you all very much for your patient listening and attention. Thank you.
Thank you so much, Professor Ravikant sir. I think it was well articulated talk on pneumococcal diseases in chronic diseases, and also about the vaccination. I was just looking out for the guidelines. Like there are a few guidelines which are available, and you said that there is deficiency in policy making.
Yeah.
So do we have some data on like global policies on this vaccination among chronic diseases, or some Indian data also?
The PCV20 has already been endorsed by FDA. So far, India is concerned, being a populated country. If you start vaccinating more than 50 years of people, it's going to be a huge financial burden on the government. So government is reluctant, but the topic is a hot selling cake as of now in every scientific fora, be it API, be it Diabetes Academia, be it any other forum. So now what we have done, we have formulated a dedicated society for adult immunization. So we are heavily putting in our efforts and just trying to convince the policy making or makers to endorse this vaccination. So if you go, what is the right time to vaccinate a patient? That is the question that we need to answer. The right time is when the patient is admitted in the hospital. Please pass on the benefit at the time of discharge, give him a schedule, which we are doing anyway in the Department of Medicine. All these patients are being vaccinated. And we are seeing that there are a lot of reduction in the hospitalization rate of these patients. So ACIP is one such body which has already endorsed, but the Government of India is still to recognize that this is important, and even the aging population is valuable to us. So currently what is happening, because World Health Organization is recognizing infant mortality rate and mortality rate less than 5 years. That is the reason why the immunization has so picked up heavily across the globe. They have not considered the mortality less than 50 years or 60 years as an independent marker of quality of life to any nation. That probably is the reason why we are not picking up. So anyway, the WHO takes into consideration the mortality less than 5 years of children as a very important and sensitive marker for healthcare provisions. So probably maybe 5 years, 10 years down the line. But the policy makings are different. We have to take our own, on call, and we need to be on board with the patient and benefit these patients. Mind it is really helpful and useful. Thank you.
Sir.
Any questions from the audience?
Sir, one question from my side. Sir, we see so many, because TB is very high burden, TB is very burden in our country. There are so many young patients who came with the post-TB sequelae.
Yeah.
So there are the indications for
the COPD. So this is a very important question. Any structural damage to the lung is an indication. Any structural damage, because they are the nidus for recurrent infections. It is there. Thank you.
Thank you so much, sir. Thank you.
Thank you, sir, for that engaging and informative session on the evolving trends in pneumococcal disease and vaccination strategies. I would like to request our chairpersons to felicitate Professor Dr. Ravikant, sir. May I request Dr. Seema Mahant ma'am to felicitate our chairpersons, Dr. Ajit Bhadoria sir, Dr. Anirudh Mukherjee sir, and Dr. Mahendra Meena sir. With that, we have concluded the pre-lunch session. We'll take a short break for lunch and we'll be continuing with our scientific session sharply at 1:45. Thank you. source formatting. Okay, sir. Yes, sir. ये mic को इसको
This only audio working with it has been source fetched away. Audio from the mic will be help for you.
एक try करते हैं हो सका
सोर्स नहीं किया ना सोर्स कहाँ पे है वो तुम्हारी वो वाली स्लाइड कहाँ है ये आपको सी स्लाइड्स में
सुने कैसे कि सिर्फ अभी चल रहा है ना?
Yes, sir. चल रहा है, sir.
देखते हैं if not then I'll avoid that slide but it's a good slide.
Cardiomyocytes seem their shape and structure growing thicker and stiffer. The heart tissue also develops fiber.
उस समय करना पड़ेगा. You have to do it.
So मैं adjust करेंगे.
So I'll do it. Remember, I'll just go.
Welcome back, everyone. Let's now continue with our scientific session featuring the next set of informative and engaging talks. We have highly anticipated session on a topic that lies at the very core of modern cardiology: heart failure with markedly reduced ejection fraction, role of newer heart failure medication. To discuss the current evidences and practical use of these novel therapies, we have with us Dr. Tanuj Bhatia sir, Professor and Head, Department of Cardiology, Sri Guru Ram Rai Institute of Medical and Health Sciences. Let's welcome our chairpersons for this session. Dr. Mukesh sir, Additional Professor, Department of Medicine, Aiims Rishikesh. Dr. Satish sir, Assistant Professor, Department of Cardiology, Aiims Rishikesh, and Dr. Rohit Raina sir, Assistant Professor, Department of General Medicine, Aiims Bhatinda. Let us all welcome sir to share his expert insights.
You can start, sir.
Slides, sir.
Slides.
Yes, sir.
This is not this. This is not this. slides are not moving. Good afternoon, everyone. So I would be discussing with an overview of the paradigm drift in heart failure with reduced EF syndrome management. And in the past 4 decades, actually, we've seen a lot of improvements in the medical as well as interventional therapy. And back in 1980s, it was considered to be a very hopeless diagnosis with very, very poor chances of recovery. But the latest 2021 recommendations actually show an entire different picture. We have a wealth of clinical data that suggests that HFrEF is both preventable as well as treatable in this modern era. And in 2021, we do expect a marked improvement in the improvement in the mortality as well as morbidity of such patients. We divide the entire experience into 3 groups: the first 15 years, the next 15 years, and the last 5 to 10 years. The first 15 years, starting from 1985 to 2005, we saw the advent of neurohormonal modification. We saw the advent of neurohormonal modification in management of heart failure with reduced EF. We got drugs like ACE inhibitors, isosorbide dinitrate, MRAs, beta blockers, and lenoxin as a head-to-head comparison or as new drugs in the improvement of heart failure. The next 15 years, we saw the advent of ARBs replacing ACE inhibitors to improve the side effect profile. Some other additional drugs started coming into the play, like ivabradine. These are the wealth of the various clinical trials done in this era till 2015. And then subsequently, the last 5 years, actually, we've witnessed how to combine these drugs for a best outcome for our patients. It's not that we have not had disappointments. The biggest disappointments was the ACE-NEP combination that the name was, it was the elder sibling of ARNI, which we have right now, omapatrilat, but it failed tremendously because the simultaneous inhibition of 3 enzymes, aminopeptidase, P inhibitor, ACE, and NEP inhibitor, heightened the risk of angioedema. But this mistake led to a learning, led to the design of this beautiful combination, the name paradigm HF trial, that led to a paradigm shift in the management of heart failure that left the ACE and APP intact for bradykinin metabolism and a receptor level of blockade of angiotensin combined with neprilysin inhibition. And this led to the latest revolution in the past 5 to 10 years, where we had an incremental 20% mortality benefit in our patient. And then the journey just continued, and we are now towards microRNA techniques. So this is the latest microRNA 132 inhibitor, the CD132 ligand, a very novel drug that has the potential to modify the treatment of heart failure. Currently, the recommendations are the 5 pillars: the ACE inhibitors or ARB in combination with neprilysin inhibitor, beta blockade, MRAs, SGLT2 inhibitors. Talking about the combination of sacubitril valsartan to start with, it leads to beneficial effects by natriuresis and reducing vasoconstriction by this dual mechanism of neprilysin inhibition and receptor level blockade of angiotensin receptor. We have a wealth of data, but we have to understand that heart failure is not just getting outside the hospital and letting the patient go on to his routine NYHA status. We have to go beyond that. We have to understand that hospitalization for heart failure, we've learned that that is another entity that leads to a dramatic improvement in the mortality and not just morbidity. All said and done, 25% of heart failure hospitalization patients come back within 1 month, 50% come back within 2 months, and the mortality after a hospitalization is as high as 10% in the first 1 month. And henceforth, the latest recommendation 2021 by ESC and 2022 by ACC recommend that we may even substitute it for a patient who's on chronic ACE inhibitor therapy to reduce the risk of heart failure, hospitalization, and death. So this is the most important recommendation change that we witnessed in the 5 years. And the data comes from starting from the Paradigm HF trial that enrolled NYHA 2 to 4 class heart failure, elevated BNP levels, EF of less than 35%. And this led to a 20% reduction in the overall primary endpoint of MACE along with heart failure hospitalization. And this was associated with similar reduction in biomarkers associated with heart failure. It fared well in patients even with a low blood pressure across the glycemic status, and the transition study actually taught us how to convert our patients from chronic, those who are not ACE naive or ARB naive, how to convert them from chronic therapy to this combination therapy. The changes of NT-proBNP mimic the improvement in the NYHA functional status, heart failure hospitalization. And this study also gives us a confidence that 50% of our patients can be stabilized with even high dose of 200 mg BD therapy within 1.5 to 2 months of initiation of the therapy. But all these trials did not address acute hospitalization, and hence came the Pioneer heart failure study that started it in hospital, started the RD combination in the hospital once the patient was stabilized, and this led to 46% reduction in the serious composite clinical endpoint, mirroring with the reduction in NT-proBNP. We have to be cautious about using this drug in patients with history of angioedema, renal artery stenosis, and EGFR of less than 30. And we have to give a washout period of at least 1.5 days if the patient is taking ACE inhibitor. So we've seen this in all spectrums: stable patients in Paradigm HF, hospitalization patients with transition, and patients with worsening heart failure in Pioneer HF study. We've also explored its use in Paradise MI trial. We were also part of this study, but it did not give a very significant improvement in acute high-risk myocardial infarction patients. And henceforth, there is an exploratory analysis for assessing the reverse cardiac remodeling associated with this drug. And overall, we've seen improvements in LVF, reduction in end systolic volume index, reduction in end diastolic volume index, and even improvements in the LAVI scores, although that was not significant. And this approach continues with this novel drug that I just discussed. It is yet in its phase 2 study. We are enrolling it at our site also, but it's a beautiful new drug, new mechanism of action on the level of microRNA. I'll show a small video related to it. It's a novel first-in-class, a unique method of action. So I guess the audio is not working. So what it does, it has a unique method of modifying the anti-fibrotic techniques by improvement at a cellular gene therapy level. It's one step ahead of the small insertional RNA. It is a microRNA technique that may change the whole paradigm of management in heart failure. Coming back, so I'll be discussing only a few drugs for the paucity of time. The recent advances in the past 5 years to 5 to 10 years, the latest addition on the block. So another is the SGLT2 inhibitors. And ARNI and SGLT2 inhibitors, these are two drug classes that incrementally improve the outcomes, and they can have a synergistic action because their AE profiles, adverse event profiles, are pretty complementary, and they may enhance tolerability to each other. The advent of SGLT2 inhibitors started from diabetes to improvement of cardiovascular outcomes in diabetes patients, and now irrespective of the diabetes, we give it as a class 1 indication to our HIF-ref patients. And this drug did not stop here. It is even got a better level of recommendation than all other drugs in patients with heart failure with mildly reduced EF as well as preserved EF. The data came initially from the CANVAS program, EMPA-REG outcome, DAPA-HF, and the numerous mechanism starts from improvement in the renal indices like reduction of EGFR, reduction of the glomerular pressure, preservation of EGFR over the long term, improvement in inflammation and fibrosis reduction, improved tubular oxygenation, as well as other forms of diuresis beyond that we were exploring with the conventional diuretics. So these are the various cardiovascular outcome trials from which it started. But in the HEF-REF category, this was the trial that gave us the maximum confidence. This is the EMPEROR-reduced trial that showed the dramatic reduction in hazards ratio of 0.70 for hospitalization of heart failure and overall MACE outcomes with a hazard ratio of 0.75. The relative risk reduction was as high as 50%, and this drug has found its place as a class 1 indication. Practically, we do have our hesitation of increased UTIs. Hypoglycemia is literally non-existent, but we have to be cautious about euglycemic decay. And there is a slight increase of lower extremity amputations, which is pretty kind of anecdotal rather than in a trial. And the ease is pretty good. For all other drugs, we need to up-titrate the dose, but this is a one-step, one-thought initiation of this drug. We can start it right at the maximum dose at the very first level. And now comes the beautiful combination which we've learned in the past 5 years, this quadruple therapy, and it has been seen that if we give the 4 foundational drug classes, it leads to dramatic improvement of health status, and it may add as much as 6 years or 8 years of life to such patients. How to combine? We have either conventional sequencing, where we start with A, B, then mineralocorticoid receptor antagonist, then ARNI, then SGLT2 inhibitor. But there is another proposed new sequencing where we start beta blocker and SGLT2 inhibitor at the first go, add ARNI subsequently, and add MRA. But the target should be that we should be achieving at least all the 4 drugs in the next 6 to 8 weeks of initiation of the therapy. Which is the best approach? It varies from patient to patient. We may start with very low doses of all the foundational medications at the same time, or we may try to increase the dose of one. This depends on the clinician, on the patient status, and there is no one hard and fast rule. One practical approach is to begin with ARNI, add beta blocker with ARNI, or shortly after ARNI, add MRI and SGLT2 inhibitor shortly after one another, either together or after one another very soon. But the treatment goal is within 6 to 8 weeks, we should have all the 4 pillars of heart failure therapy and initiate, optimize, and reassess whether the patient needs any additional therapy. What additional therapy? It may be vericiguat or ivabradine in certain patients, especially vericiguat in patients with worsening heart failure. Because even if the patients are on all these drugs, point number 1 is that only 28% patients actually receive GDMT. And there are times when we can't give a specific drug like ARNI or beta blocker because of peculiar contraindications. And we should try to introduce this novel drug that is vericiguat, that has a potential and that has a tendency to 4-fold reduction in 1-year mortality risk as compared to chronic heart failure. It has got a unique action in contrast to all other class of drugs which are blockers. It is a stimulator of soluble guanylyl cyclase, and it leads to reduced inflammation, reduced fibrosis, and overall vasodilatory action as well. The data from the Victoria trial and subsequent other trials also show that it has got a very, very favorable safety profile, and the cardiovascular mortality and NT-proBNP values are almost similarly improving as with SGLT2 inhibitors. There is very, very minimal reductions in the systolic blood pressure, and even the renal function is preserved over the long time. It is quite metabolically neutral with no or minimal effects on the sodium and potassium levels as well. So this is a summary slide, just summarizing. Besides that, we have evidence from ferric carboxymaltose, hydralazine nitrate, especially in renal failure patients, then definitely interventional treatments like CRT, mitral edge-to-edge repair, and other drugs are in vogue right now, like omecamtiv mecarbil as well. So we have to be classifying our patient on the basis of phenotypes. Certain patients, those who have AF, may also benefit from AF ablation or NOAC therapy. Those with tachycardia with heart rate of more than 70, despite optimal beta blocker dose, you can add ivabradine. And this is an era of domain management. So it's not just medical treatment. We have to also screen for frailty, falls for the patient. We have to be cautious about hypotensive episodes in such frail and elderly patients. So to conclude, the key takeaways are that guideline-directed medical therapy is the foundation of HF care. We have to prioritize this approach with the expectation of benefit for those patients, those who may benefit from it most. We don't have to make them out of our list, especially if they have baseline mild renal dysfunction. We should achieve target doses which are associated with best outcomes. Just starting it is not important. Optimizing is equally important. We should start immediately, titrate immediately, and in each encounter of HF visit, we should try to identify what are the barriers of giving GDMT. So this is very important. We should stop our pain, think why we are not increasing the dose of beta blocker, why we are not increasing the dose of ARNI. And any AE leads to a reduction of continuation of this care. So we have to be very diligent of optimal volume management of such patients. And the tolerability and side effect actually in part depends on how we as physicians, it does not depend on the patient's clinical status, it depends on us, how we are optimizing that GDMT. Like a scenario of worsening renal function, we can use lesser dose of target dose. We can discontinue mineralocorticoid receptor antagonist, and SGLT2 inhibitors are recommended to be continued even if the patient has developed a UTI. After the patient's symptoms improve, we can always reinitiate it. We don't have to be hesitant in that level. Symptomatic hypotension, these are elderly patients. Some are taking alpha blockers from maybe PPH, and we have to reduce those drugs rather than just reducing the dose of ARNI or just stopping ARNI overall. In conclusion, it's a team-based care which is critical to optimizing GDMT, and it may require frequent follow-up visits, telehealth visits, remote monitoring, and it's not just practice professionals, it is also the clinical nurses, pharmacists, social workers that need to be trained in this regard. Thank you very much.
शुरू में ही हुआ था उधर से नवा बोला गाड़ी आगे बढ़ाए ना बढ़ाइए गाड़ी चलते गाड़ी
So thank you so much, sir. In timely finish your talk. So, sir, regarding the GDMT, it's difficult to monitoring the effect of the drugs. Actually, most of drug diuretics, we have the similar effect that patients may have symptoms of immediate relief of symptoms in the diabetes. But in the SGLT2 inhibitors or ARNIs, the monitoring, how you monitor that patients having the additive effect of these drugs.
So, means very rightly, out of these 4 drugs, 2 are pretty metabolically neutral. But the 2 which have metabolic effects, like the angiotensin receptor antagonist in combination with neprilysin inhibition and MRAs, we should be a bit cautious about potassium. We have to be a bit cautious about the blood pressure. And I think so it's just the structure of our clinic that dictates it. Mostly we are very fast in deprescribing these drugs to our patients because of a minor adverse event. But symptomatic, if the hypotension is not symptomatic, even continuing these drugs at a BP, borderline BP of 100 by 70 or 100 by 60 is fair enough. And gradually the patient starts tolerating them. So there is an effect when this hypotension also gets over after around 6 to 8 weeks. So I think so that's...
And sometimes the patient's having multiple drugs.
Yeah.
And the doses will be with some optimals.
Yeah. So that's what it is. Polypharmacy is a problem, but giving suboptimal doses, it's not very good in the long term, but we have to individualize the therapy according to our patient.
So I think with the chair permission of the chair, I would like to ask a question to Dr. Arun.
Yeah.
So anyway,
वो उसका नाम है, वो गड़िया उठाने वाला उसका है, किरणवा का है।
गाड़ी सवाने में
चलते रहिए ना, चलते रहिए, चलते में बिजी होगा, नहीं लेकिन फिर कहाँ जाएगा? यह बात है कि सारा फिर एयरपोर्ट ये हटाने बोल रहा है। तो उसको बात तो रोक के वो हटाने को जो बोल सारी भाई एयरपोर्ट में मिसाल ठीक है जगह बोल रहा था, जियो का था आगे भाई गाड़ी जगह वाला है, गाड़ी आगे
era which is scientifically driven. I think we need to revise some prescribing SOPs also.
Yeah.
So for example, one very easy answer is what is the net excretion of sodium to initiate a particular dose of diuretic, because same drug is going to affect different to different patient population. We have no answer to that. Probably the SOP so far as the drug prescription is concerned is the need of the hour. Thank you.
Very rightly said, sir. Even like hypotension, which is a very, very common scenario in our clinics, and we just tend to deprescribe ARNI. That is a very, very bad strategy. We are not concerned about the volume status of the patient. Sometimes we are actually over-prescribing diuretic to a patient who lives in a warm environment, who's sweating, and we doesn't need so much of a diuretic. So over the long period, deprescribing or under-prescribing diuretic, a high ceiling diuretic is more important, and these foundational therapies need to be pushed as much as possible.
Sir, you said while starting the medications, it can be in any order. In a patient who is admitted with an ADHF, while we going to start GDMT, so do you believe in that wet drug and dry drug concept?
Yeah, so that is a very good question, and in fact that is our experience in Paradise MI. The reason why Paradise MI failed as compared to all other trials, that we were very, very fast in starting these drugs to a wet patient. So we have to at least optimize the volume status and then start these therapies, and maybe starting with MRA and SGLT2 inhibitor to start with, and then ARNI before. So even in the Paradise MI, it was a very beautiful exclusion criteria that if the patient was on any IV diuretic or IV vasopressor in the past 48 hours, don't start this drug. So we are learning in that regard, but yes, we have to change our approach for dry and wet patients, as you said.
Thank you so much, sir.
Thank you so much, sir, for such an insightful session. Now I would like to request our chairpersons to felicitate our speaker, Dr. Tanuj Bhatia, sir. I would like to request Dr. Darab Singh, sir, to felicitate our chairpersons, Dr. Satish, sir, and Dr. Rohit Raina, sir. Thank you so much, sir. We now come to a topic that holds immense relevance in today's diabetes care scenario: the use of co-formulation insulin as a rational treatment approach for Indian diabetics. Let us welcome Professor Dr. Jyoti Prakash, sir, Head of Department of Medicine, Aims Patna, who will be joining us via online platform to guide us through this intriguing topic. Am I audible, sir?
Yes, you are audible.
Okay, sir, you can...
Am I audible?
Yes, sir, you are audible, sir.
You can operate my slides from there.
Yes, sir.
Please change the slide.
I would
Should I start?
Yes, sir. Sir, 2 minutes, sir. We'll invite the chairperson.
Yes,
Sir.
chairperson.
Yes, sir. I'd like to welcome our chairpersons for this session. Dr. Prashant Kumar, sir, Professor, Department of Physiology, Aims Rishikesh. Dr. Pragya Gupta, ma'am, Assistant Professor, Department of Endocrinology, Aims Rishikesh. And Dr. Prakash, sir, Assistant Professor, Department of Medicine, Aims Rishikesh. Yes, yes, sir, you can start the presentation, sir.
Yes, warm good afternoon to all. I am thankful to the organizing team of Aims Rishikesh, especially Professor Ravikant, who has invited me. Unfortunately, I could not be physically present. I'll be arriving today in the evening. That's the meantime I am connecting you online. So, respected chairpersons, the topic of discussion is newer co-formulation insulins. How is it working and how is the story of this? So, please change the slide.
Yes, sir.
Slide.
Yes, sir, we are sharing the screen, sir.
Any problem?
Yes, sir, we are just sharing the screen, sir, for the slides. Yes, sir, you may start, sir.
But I'm not seeing my slides.
Okay, sir.
Yes, yes.
Sir, are the slides visible, sir?
Yes, visible.
Okay, sir, you
Can
may...
I make it power, enlarge this? Okay, so just enlarge it. Full screen. PPT mode.
Yes, sir, it is in the PPT mode and it is in full screen, sir.
Okay, so let us start the session because we are running late. Yes. And I will try to finish within 10 to 15 minutes. So in this session, we will be having a brief introduction of diabetes, the various insulin formulation available till date, a strategy for administration, and the newer co-formulations of insulins and its advantages and limitations. Next, please. So you all must be knowing diabetes is not a single disease. It is a syndrome of metabolic disorders characterized by hyperglycemia. It results from various complex interplay of genetic and environmental factors, and prevalence of DM has risen significantly, more than 10 or 11%. So it has profound implication on the health of the public and also the financial status of the society. Next, please. So the principal causes of hyperglycemia is only three. Either it is reduced insulin secretion, or it is due to increased glucose production in the liver, or due to decreased glucose utilization in the peripheral tissues such as muscle. And this diabetes, just please, diabetes has effect on various systems, causing end-stage renal disease, non-traumatic amputations, and blindness, and CBD risk factors. Next. Next. Next.
Next slide, please.
Please change.
Yes, sir, we are trying, sir.
Please change.
Sir, you may continue speaking from your own laptop, sir.
No. Okay. Once. So, sorry for disturbance. So, the etiology of diabetes mellitus is principally we have type 1 diabetes mellitus, type 2 diabetes mellitus. I'm audible?
Yes, sir, you are audible, sir.
And various genetic types of diabetes and gestational diabetes mellitus. Now, briefly, the WHO criteria of this normal glucose tolerance and that of pre-diabetes and diabetes: A1C less than 5.7%, fasting plasma glucose less than 100 milligram, and 2-hour plasma glucose less than 140 milligram is a normal glucose tolerance. Above this range, A1C between 5.7 to 6.4, fasting between 100 to 125, and PP between 140 to 199 is impaired fasting or impaired glucose tolerance test, that is pre-diabetic state. And above that, that is symptoms of diabetes with RBS more than equal to 200 milligram per dl, or A1C more than equal to 6.5%, or fasting blood glucose more than 126, or PP more than equal to 200 milligram per dl. Any of the four criteria suffices the definition of the diabetes mellitus. So this is the structure of the human insulin connected by 3 disulfide bond. Everybody must be knowing. I have nothing to do with this simple physiological structure. Now the development of insulin timeline, we are thankful to the scientist Banting, who first discovered insulin in 1921 and the first use in 1922. But with the advancement began later on. In 1940 we have NPH, in 1980s we have human insulin, and in year 2000 we have long-acting glargine, and subsequently ultra long-acting degludec, and this Lispro also, and once weekly icodec in recently 2024. We have also the inhaled insulin in market, but that efficacy is not so much. So what is the basic of insulin? The three basics: replicate the physiological function of the pancreas, so reduces the complication of the diabetes, and that's controls the complication of diabetes, and it made using recombinant DNA technology, standard formulation EU100, but also available in EU200, 300 or 500. Stored at 2 to 8 degrees centigrade, but when the vial is open, the temperature required is between 25 to 30 degrees centigrade. So this is the basic classification of the various insulin formulations. Firstly, rapid acting, which provides immediate glucose control, which is ideal for mealtime coverage. Short acting, again offers better control, longer than rapid acting, and suitable for this mealtime and correction dose. Then we have intermediate acting, which balances duration and control, often used for basal coverage, and long acting, which provides basal coverage, and a very long, that is ultra long acting, that controls basal for more than 24 hours. So what I told you, in rapid acting, we have 3 compounds: Lispro, Aspart, Glulisine. In ultra rapid acting, we have fast acting Aspart, ultra rapid Lispro. And in short acting, we have human regular insulin. In intermediate acting, we have NPH, which is given once or twice daily. Long acting, we have Glargine U100 and Detamir, which is given once or sometimes twice. In ultra long acting, we have 3: Degludec once daily, Glargine U300 once daily, and Icodec, which has very long acting duration, approximately 1 week. So given 1 week every week. So we have also Icodec in the market, which is weekly insulin. The common strategy for insulin administration is we have basal only, or either basal plus bolus strategy, or premixed or combination. Basal only provides, you can combine with oral antidiabetic on night may basal, and basal bolus means rapid acting insulin at bedtime, long acting at the bedtime for basal coverage, and rapid acting insulin covering each meal, which mimics physiological secretion. Premixed or combination is the fixed ratio, offers convenience, allows but don't allow separate titration. Not ideal for type 1 DM. This is the pictorial diagram of the basal bolus regimen. You can see the curve, long acting basal coverage and meal coverage with shorter acting. This is twice daily premixed. Now come to the co-formulation insulins. What are the co-formulation? The topic is co-formulation. A stable combination of the 2 insulin analogs with distinct pharmacokinetic and pharmacodynamic profile that maintain individual activity without molecular interface. That's why basal component covers more than 24-hour steady glucose control, whereas prandial component is covered by the post-meal glucose spikes and administered once or twice daily, usually with the main meal. When to consider initiating co-formulation insulin? Uncontrolled T2DM, on OADs, on basal insulin but still significant postprandial spikes, switch over to this regimen. On premixed insulin with nocturnal hypoglycemia or rigid dosing schedule, irregular meal timing or variable diet pattern requiring more flexibility, you switch over to this regimen, co-formulation. In Indian context, where Indians are very fond of taking high carb diet, frequent or large meal, better coverage with this co-formulation insulin. There we have the market 3 combinations: ultra long acting, this Degludec with Aspart, which is available in India too, but insulin Degludec with liraglutide, Idec lira, and insulin Glargine with lixisenatide, GLP-1 is still not available in India under trial. Idec Aspart, rapid onset, is 70% Degludec, 30% Aspart. Dosing schedule is once or twice with meals, no shoulder effect, suitable for elderlies, and there is meal time flexibility and simplified therapy. Idec lira, again the combination of Idec and liraglutide, and this is unfortunately not available in this in our country, but benefit is it has GLP-1 RA benefit, which enhances insulin secretion and also aids in weight management. That is a special advantage of this combination. Iglarlixi is another compound with glargine and this lixisenatide, once daily injection, and glycemic control is better, safety issues, of course reduces hypoglycemia, but this Iglarlixi and this Idec Aspart, they are not yet approved for pregnancy. So in pregnancy we are limited for this compound. So how are they different from the pre-mixed formulations? In pre-mixed we have two separate two components mixed, but here the two components are not mixed. They maintain their distinct identity, and both maintain their distinct pharmacokinetic and pharmacodynamic profiles, whereas in pre-mixed the components merge. So the scope of co-formulation is larger, and that's why preferred. These are the trials which prove superiority or at least non-inferiority of this co-formulation insulin over basal bolus or basal. They are BOOST trial and dual trial. These two trials have showed that this combination is suitable for covering nocturnal hypoglycemia and better glycemic coverage and less variability, glycemic variability. So advantages of this insulin is simplified therapy, multi-system benefit is there, better weight management, reduced hypoglycemic excursion, and fewer injection. That is also the injection is once only, and enhanced glycemic control. Rationale is in India is a big capital of this diabetes, big capital. So we must consider this. Physicians also are reluctant in starting newer insulins. I think there should be also given adequate training to switch over to this regimen as soon as possible to save the kidneys and other target organs. Minimize hypoglycemia, improved adherence is there, and this offers flexibility too. And but there are some issues with this newer insulins. Their data is again we need more data on this, and requires proper patient understanding and also physician understanding. A limited availability in some countries and higher cost. Of course, India is a poor country, so everybody cannot afford these insulins. But those who can afford, they must be given. So to conclude my talk, co-formulation insulins are a smart simplification of the insulin therapy, providing both basal plus bolus in single injection, thus demonstrates better efficacy, safety, adherence benefit, and reduced complications. So particularly suited for the Indian diabetics due to variable meal timing and adherence challenges, should be considered as a rational and practical choice in modern insulin therapy. But limited awareness, cost, and availability restrict their wider use. Thanks for patient hearing.
Thank you so much, sir, for that insightful session, and we are very sorry for the technical glitch. The floor is open for discussion.
Thank you, Dr. Jyoti. One query is from my side. What are the adverse effects of this combination? Dr. Jyoti, are you audible?
Sir, are you audible?
Dr. Jyoti, are you hearing me?
Sir, I think he has been disconnected, so we'll move forward. I would like to request Dr. Akhilesh sir to felicitate our chairperson, Dr. Prashant Kumar sir, and Dr. Pragya Gupta ma'am.
Hello?
Sir, are you audible?
Yes. Yes. Any question or should the session
We'll again
closed?
open the stage for discussion, sir.
Dr. Jyoti?
Sir.
I am audible to you?
Yes. You are audible and visible too.
What are the adverse effects of this combination?
And no adverse effect. Only the cost is matters. Cost is matter and there is no adverse effect. Pregnancy में नहीं देना है. Pregnancy में अभी approved नहीं है. Type 1 में अभी नहीं दे सकते हैं. Type 2 के लिए mainly है. Rather outcome, safety outcome is CBD risk, CBD and CKD reduction is there. This is beneficial. No side effect.
Yeah, I have one, comment to
Yes,
the
Professor
presentation. So thank you very much for joining us from airport even. This shows your, high dedication towards the academic milieu. The only submission is now glargine and lixisenatide is very much available in India. It is recently launched and now it is for we clinicians to use it fairly and firmly. It is quite available now. I think we have the talk today for this combination as well in the line. This is what comment
Professor
that I
Ravikant,
wanted. Yeah, am I audible?
Professor Ravikant, I want to add that physicians are also reluctant.
Yeah, there is some inertia from clinicians' mind also to use these new molecules. But they are now available in India, and especially the glargine and lixisenatide is now available at least in metros and where the diabetes practice is going on. I think this is the value addition that I wanted to do for the lecture. Thank you very much.
Thank you so much, sir, for joining with us. Now, I would like to felicitate our chairperson for this.
Yes.
I would like to request Dr. Akhilesh sir to felicitate Dr. Prashant Kumar sir and Dr. Pragya Gupta ma'am.
Okay.
Thank you so much, Jyoti Prakash sir. We will be closing this session. Our next session focuses on a topic that lies at the very heart of nephrology and diabetes management: initiating dialysis in a diabetic kidney disease, identifying subtle clues for optimum management. Diabetic kidney disease continues to be the leading cause of end-stage renal disease in India, and one of the most challenging decisions for a clinician is when to initiate dialysis. To initiate us on this critical aspect, we have with us Dr. Sharan Kandari ma'am, Associate Professor, Department of Nephrology, Aiims Rishikesh. Please join me in welcoming the chairpersons for this session, Dr. Dipesh sir, Assistant Professor, Department of Nephrology, Aiims Rishikesh, and Dr. Sahil sir, Consultant Physician, Critical Care.
Good afternoon, everyone. It's a pleasure to be here in the 6th Annual Cardiodiabetic Society Conference. And I thank Professor Ravikant and other organizers for giving me this opportunity to speak on a topic which is so often faced by all the clinicians in the routine practice. So respected chairpersons, without any further delay, I will begin my talk. So we all know that CKD definition by KDIGO is defined as presence of markers of not visible.
Light is on.
So we all know that the definition of CKD as per KDIGO guidelines is presence of markers of kidney damage or GFR less than 60 for more than equal to 3 months, and other further classification, the staging is done as per GFR and albuminuria. DKD then is defined as persistent kidney injury in the form of GFR impairment, albuminuria, or any histological alterations on biopsy in diabetic patients in the absence of other signs of kidney disease. So DKD is the most leading cause of end-stage renal disease in world as well as in India. In pathophysiology, short chronic hyperglycemia results in glomerular hyperfiltration, which further results in sclerosis, and this leads to progressive nephron loss leading to decreased GFR. So all the complications of CKD like metabolic acidosis, volume overload, and toxin retention develop gradually. So what is the incidence of end-stage renal disease in type 2 diabetic patients? Before that, around 40 to 53% of diabetic patients develop diabetic kidney disease in various stages, not always CKD stage 5 or end stage. but the rate of eGFR decline in diabetics is more than the routine population, normal population, which is 1 ml per minute per year. In diabetics, it is more than 3 ml per minute per year. And also it is accelerated if the patients have longer duration of diabetes, more than 10 years, or if they have severely increased albuminuria or low baseline eGFR. So the incidence of ESRD as per the Finn et al. In type 2 diabetics is 0.29% in 10 years and rises to 0.74% in 20 years from the diagnosis of type 2 diabetes. Before going to the start of dialysis, what we can do to prevent the progression of various stages of CKD in diabetic patients depends on the risk factors. Some are modifiable, some are non-modifiable. The non-modifiable being duration of diabetes, familial and genetic factors, and autonomic neuropathy, and various modifiable factors on which we can work upon, like the socioeconomic status, the sugar control, blood pressure control, lipid control, what the patient eats, obesity, acidemia, acidemic milieu in the body, other drugs which can be not given in these patients, recurrent UTIs, and anemia. So there is a lot of inter-individual variability which depends on the interaction between various socioeconomic clinical risk factors and also on the what levels of glycemic and blood pressure control are achieved in different patients. So in this slide, a brief summary before the patient reaches CKD stage 5 or end stage renal disease. Throughout the stages, CKD stage 1, 2, 3, 4, metformin and SGLT2 inhibitors remain the first line of drugs that can be used. Metformin up to stage 3, SGLT2 inhibitors can be continued up to stage 4. Once the patient enters stage 5, they have to be modified. Insulin, thiazolidine diones, and DPP4 inhibitors become the first choice of drugs. The second line drugs in any stage can be DPP4, insulin, thiazolidine diones, sulfonylureas, and alpha glucosidase inhibitors. So once the patient reaches CKD stage 5, that becomes an important life-altering stage where we will discuss now my topic will begin about the renal replacement therapy. But before that, there is one thing that has to be done with the patient before giving them the 3 core treatment options, that is the comprehensive conservative care or dialysis or kidney transplantation. Rationale of each treatment is different. CCC focuses on non-dialytic management for symptom control and palliative care. Dialysis is the mechanical removal of waste and fluids. It is a life-sustaining treatment, but it is not a destination, rather a bridge to transplant, which is a definitive treatment. And kidney transplant, it is the replacement plus minus pancreas, and it has best survival and quality of life. So the most important step here, which we have to follow as clinicians, is a shared decision-making framework, mandatory step before whenever a patient approaches to you. We have to discuss with the patient all these points. We have to discuss what is the patient's life expectancy, functional status, what can the patient handle the burden of treatment in the form of time commitment, various restrictions that will be imposed upon him, and the physical toll. We have to explain them the prognosis of each core treatment in their context. We have to see the financial burden can the patient bear that much financial burden. Also, we have to align the patient's remaining lifespan, quality of life, and personal values. So after we have a clinician has a detailed counseling session with the patient and family members should be able to answer these following questions. Should I go for RRT or not? If yes, then which type of renal replacement therapy, dialysis or transplantation? If dialysis, what do I want? Do I want it in the center or at home? If dialysis at home, should it be home hemodialysis or peritoneal dialysis? And if transplantation, it opens a new chapter and other discussion is required. So two slides on comprehensive conservative care. It is an active non-dialytic approach, and it is focused on maximizing comfort and quality of life through palliative and supportive care. We go for achieving meticulous symptom control of all the uremic symptoms, pain, nausea, pruritus. We optimize all the comorbidities, blood pressure, anemia, and the bone mineral disorder. We provide nutritional and psychological support. We minimize complications, and we plan for end of life. Planning is done. So who is the candidate for this CCC? Patients with very high comorbidity burden and limited life expectancy, like advanced age, more than 80 to 85 years old, severe non-correctable cardiovascular disease, high burden of other non-renal comorbidities in the form of malignancy, frailty. If patient prefers for less burdensome life near its end, And although the median survival as compared to giving dialysis is less in comprehensive care, but the quality of life is maintained till end. So now if the patient and family have decided to initiate dialysis, the question comes when to initiate dialysis. So traditional indicators in non-diabetics are GFR less than 10 and in diabetics less than 15. So only study which was done was ideal CKD study to decide the initiation of dialysis in CKD end stage patients. So what they did was they classified patient into two, divided into two, early initiation versus late initiation. Early was done as soon as the GFR reached 10 to 14 ml, and late was done when GFR reached 5 to 7. So what they found was there was no difference in the mortality or outcomes whether the patient was initiated early or late. So this is a decision, individualized decision has to be taken upon various factors which we'll be discussing as to when initiate dialysis in diabetic patients. No fixed eGFR is defined for initiation of dialysis. Before initiation of any form, peritoneal or hemodialysis, we have to correct various things. We have to optimize the patient. We have to vaccinate routinely, as in CKD patients. We have to prepare for vascular access early. AV fistula is the preferred choice. And we have to provide nutritional counseling and psychological support. So dialysis modalities are hemodialysis and peritoneal dialysis. Hemodialysis can be in center using a dialysis catheter in the form of internal jugular, femoral or AV fistula, and it is given at home or in center. And peritoneal dialysis is through a catheter in the peritoneal cavity, which is given at home. So first we'll discuss the peritoneal dialysis in DKD patients. Only factors for eligibility of PD are that the patient should not be having any absolute contraindication for PD, patient should have intact peritoneal membrane, and patient should have freely chosen this option. So absolute contraindications as per the KDOQI guidelines are mentioned as surgical, that there is extensive abdominal adhesions which limit your dialysate flow, uncorrectable mechanical defects in the abdominal wall, any irreparable hernia, omphalocele, gastroschisis, diaphragmatic hernia, or bladder exostrophy. Medically, if there is a large abdominal aortic aneurysm and patient has severe lung disease with poor lung function. And social, if the place of residence is unhygienic and does not allow, and if the work or employment does not allow. Any of these absolute contraindications, PD cannot be done. Otherwise, these relative contraindications, PD can be counseled or thought upon. Recent intra-abdominal bodies less than 4, any leak, active inflammatory bowel disease, abdominal wall or skin infection, obesity, malnutrition. These are relative contraindications. If you can cure them, PD can be given in these patients. So as compared to conventional dialysis, PD is associated with slower decrease in residual renal function as per Maron et al. But over time, in all the patients and particularly in diabetics, few barriers may arise that will prevent optimum peritoneal dialysis delivery. Patients can develop loss of autonomy to self-care. They can have visual or auditory cognitive problems, more so in diabetic patients. Or if there is inflammation or malnutrition in diabetic patients, volume overload, cardiovascular disease, diabetics are more prone for that. If they have cerebrovascular disease, then their autonomy will be lost. Metabolic disturbances in PD due to secondary glucose absorption. So next option is in-center hemodialysis. There is no specific contraindication for that. And in diabetics, various complications like atherosclerosis, cardiomyopathy, they increase the morbidity and mortality, as well as the major issue of vascular access in diabetic patients, which we will be discussing. So the main focus is how to prepare for vascular access in these patients before we plan for hemodialysis. Formation of timely and secure vascular access is key component in diabetic patients' overall care. Central venous catheters, higher mortality, more infection, hospitalization rates. AV fistulas are the vascular access of choice, but can fail due to thrombosis and failure to mature. So REIN registry reported, which a study was done in patients who were started on dialysis in 2005 and 13, non-functional vascular access at the start of HD was more common in diabetic patients as compared to non-diabetics. And a meta-analysis was done by Yan et al. They showed, which analyzed 23 papers from 1998 to 2016. In 930 diabetic subjects, diabetics had higher rate of AV failure as compared to their non-diabetics counterparts. So why do diabetics have higher failure rates? They have a tendency for platelet aggregation and higher prevalence for thrombosis due to hyperglycemia and ages injuring the internal wall of the blood vessels. They have higher prevalence of atherosclerosis in the arteries, And also throughout their disease history, they are exposed to numerous blood extractions, intravenous infusions, and punctures which damage their veins throughout over the course of time. So how can we increase our success rates? Study done by Okumura et al. Suggested if we carefully select the patients by doing thorough clinical examination, vascular mapping by ultrasound, we can create higher successful radiocephalic fistulas in diabetic patients, and the survival rates were also high, comparable as compared to the non-diabetics. So for that, we should do early referral, experienced surgical support with a multidisciplinary team. We have to do a careful preoperative assessment, adequate post-op care, also a proactive approach of the fistula in the dialysis unit by the technicians and doctors. For the choosing the site of whether it is radiocephalic or brachiocephalic, if the arteries are calcified, elbows are generally preferred in diabetic patients because calcification at this level is less pronounced as compared to wrist, but it increases the risk of Steele syndrome. And a study by Jennings et al. Found if we do a proximal radiocephalic fistula as compared to a wrist fistula, they have low risk of dialysis access-related Steele syndrome. And also functional patency is good. So while the patient is on dialysis, we have created a successful access, we have started him on dialysis, we have to manage various things of various conditions while the patient is on dialysis. Studies by Klinger et al. And Follis et al. Found that diabetic patients have inferior survival as compared to non-diabetic patients, and they have lesser normal left ventricular size and diastolic function as compared to non-diabetic patients. So the various points which we have to manage while the patient is on diabetes is glycemic control, fluid management, hemodynamic instability, and nutritional. For glycemic control, hypoglycemia is more common in diabetics, whether they are CKD or on hemodialysis. It is as high as 46.6% because glucose decreases during hemodialysis as we use lower glucose dialysates, but it can be changed, it can be increased or decreased. And also a study was done by Katla et al. Found that 16% of patients in whom continuous glucose monitoring was done had asymptomatic hypoglycemia during dialysis. That was not detected by routine finger prick tests. So we all know this pathophysiology, why hypoglycemia is there. Insulin is metabolized by the kidneys. In the later stages, insulin levels rise and the insulin requirement falls in diabetic patients as the CKD progresses, and dialysate has lower glucose. So this is a medication adjustment that has to be done at the start of dialysis. Insulin in HD should be reduced by 25, in PD should be increased up to 30% because of the glucose dialysate which is used in peritoneal dialysis. Metformin is not recommended. Linagliptin, sitagliptin, the doses are similar in HD and PD. SGLT2 and GLPs are not recommended while to be started when the patient is on hemodialysis or PD. So a systematic review was done by Blaine et al. And they found that in HD patients, reduce the basal insulin dose by up to 25% on the dialysis days to prevent hypoglycemia rather than on the non-dialysis days. Now we come to the next part, that the fluid management in these patients. Fluid overload is common in both HD and PD, and it is linked with increased cardiovascular morbidity and mortality. And interdialytic weight gain of more than 4% is an independent factor for all-cause mortality. So why do these patients develop interdialytic weight gain? Because of excessive fluid intake, which is driven by xerostomia because of fibrosis of the salivary glands, or because of the high sodium and uncontrolled glucose levels. So salt restriction and good glycemic control reduces the interdialytic weight gain, reduces intradialytic hypotension, and hence improves the cardiovascular outcomes and ultimately impacts the survival of these patients. So now the next thing, that is the hemodynamic instability, more common in diabetic patients, intradialytic hypotension. It is due to autonomic dysfunction in diabetic patients, higher interdialytic weight gains in these patients, as well as the vascular calcification. So what this intradialytic hypotension does, it causes higher rates of other organ ischemias and damage, myocardial stunning, as well as acute ischemic brain matter changes are found. So one thing that can be done in hemodialysis is that we can cool the dialysate to prevent this hemodynamic instability. Just a few more slides, 2 or 3 are left. So the small talk on home hemodialysis that can be given, because limited slots are there for in-center, so this is a viable option for these patients. And various studies have reported that by increasing the frequency as well as the duration of sessions, all these factors, BP control, cardiac status, anemia, bone mineral metabolism, they all are better with home hemodialysis. So what do the KDOQI guidelines 2015 suggest? That intensive hemodialysis regimens that are provided, that can be provided by home HD, have a good impact on the quality of life. So to summarize, whether to go with hemodialysis or peritoneal dialysis in diabetic patients, what is different between HD and PD? Insulin, we have discussed, it has to be decreased in HD and increased in peritoneal dialysis. HbA1c levels, extremes have to be avoided, less than 6, it has to be between 6 to 9. For fluid control, we have to avoid interdialytic weight gains of more than 4% and hyperhydration, but is more common in PD. So when we have to choose for HD versus PD, how would we make that decision? Vascular access is more difficult in hemodialysis. A simple catheter placement is required in PD. Glycemic control is better with HD and worsens with peritoneal dialysis. Quality restricted, slightly restricted by hemodialysis because it is in-center, but more flexible in PD patients. And complications, we have discussed that vascular access failures, intradialytic hypertension, more in HD, but higher peritonitis rates in PD. So there is no consensus on a universal better option, and it has to be individualized. So in the last, whenever we have to make a choice between the 3 core treatment options, that is transplant, HDPD, or the comprehensive care, if a patient is young with low comorbidities, prefers a good survival as well as good quality of life, and is type 1 diabetic, we should go with transplant along with pancreatic transplant. If the patient is middle-aged with moderate comorbidities, flexible quality of life, but aims for survival, and is type 2 diabetic, go with dialysis. But if a patient is elderly, frail, only wants comfort, go with comprehensive clinical care. So key takeaways for initiating the dialysis: that do not solely rely on the eGFR, assess all the parameters, recognize the signs for uremia in diabetics, and initiate dialysis proactively in these patients, and integrate patient education, nutrition, psychological support in these patients. Thank you.
Thank you, ma'am. That was a very informative session. Indeed, switch from CKD5 ND to CKD on dialysis is a very important step in the management of these patients, not just in diabetes, but any CKD patients. I have just one question. At what level of GFR? Do you believe in an arbitrary level of GFR or creatinine, or do you believe in symptoms, no matter what the level of GFR, for initiation of RRT?
I personally believe in symptoms, irrespective of level of GFR. In diabetic patients, many a times we have found a well-maintained GFR more than 15, still they are coming with recurrent fluid overloads, not being managed by diuretics or anything, and we have to initiate their dialysis for just management of fluid control. So we have to individualize this therapy, see what all metabolic parameters are, fluid control is, hypertension is, and then we have to start dialysis basis on the individual therapy. I do believe that.
Thank you. Any questions from house? Thank you, ma'am.
Thank you so much, ma'am, for sharing the practical insights on this crucial topic of diabetic kidney disease. I now request our chairperson to kindly felicitate our esteemed speaker, Dr. Sharan Khandari, ma'am, Associate Professor in Department of Nephrology. Next, I would like to request Professor Ravikant sir to felicitate our chairperson, Dr. Deepesh sir and Dr. Sahil sir. So our next talk is titled on urine albumin creatinine ratio in diabetic kidney disease, its relevance in 2025. To enlighten us in this very pertinent topic, we have with us Dr. Deepesh Sir, Associate Professor in Department of Nephrology, Aiims Rishikesh, whose expertise will surely offer us both clarity as well as practical perspectives. I would like to invite our esteemed chairpersons for this session, Dr. Arvind Kumar Sir, Additional Professor, Department of Pathology, Dr. Ravi Sir, Associate Professor, Department of Pathology, and Dr. Sharan Ma'am, Associate Professor, Department of Nephrology.
Thank you, sir. My talk today is on urine albumin creatinine ratio. We know it from last many decades. It is as simple as a basic thing in diabetes and kidney care. And yet, is it still relevant in 2025? Let's discuss. First to introduce, as we already know, as ma'am has already discussed, the CKD is one of probably the most common chronic disorders across the world and India. With a rough prevalence of around 10 to 15%, it is as common or maybe even more common than diabetes. It is 20 times more common than cancer and HIV/AIDS. Also, as a leading cause of death, it has been emerging from 1990 when it was 19th leading cause of death to 11th in 2019, and now it is expected to become the 5th leading cause of death in 2040. And causes of CKD, whether we talk about India or across the world, are more or less similar. Diabetes invariably is the leading cause of CKD in India, followed by hypertension, chronic glomerulonephritis, and other causes. Now, unfortunately, CKD is heavily underdiagnosed, and the data that I'm showing here is not from India. We all know that in India, underdiagnosis is very common because of the poor socioeconomic status of patient, because of the poor social security infrastructure, poor insurance, but these data are from USA. And these data show that in CKD stage 1, hardly less than 5% of patients are diagnosed, while more than 95% patients remain underdiagnosed. Even in the advanced stages of CKD like stage 4 and 5, up to 40% of patients do not get diagnosed until they arrive with life-threatening complications and fatalities. So why is that underdiagnosis so common? Why is it so that a disease which is so threatening, which is so life-threatening, which is such a leading cause of death, is still underdiagnosed? The main cause, apart from those socio-economic factors, is the absence of any clinical symptoms in early stages of CKD. And hence, the diagnosis of CKD is solely dependent upon the laboratory parameters. We know that creatinine and EGFR are very late markers. So for early diagnosis, we have to rely upon proteinuria. Let's come now on our main topic, which is proteinuria, basically albumin creatinine ratio. A brief introduction, a brief history of proteinuria detection. Paracelsus and Deckers were the first in 16th to 17th century who noted the coagulable nature of urine in some of their patients. However, it was Richard Bright who deserves the credit for relating that coagulable urine with edema and kidney disease. Fast forward to 2 centuries, and in the later half of 20th century, we got to know that even tiny amounts of albuminuria in diabetic patients can lead to further progression of proteinuria and kidney disease. Later on, these similar findings were also replicated in non-diabetic kidney disease patients also. And as of now, we all know that it is albuminuria rather than proteinuria, which is now considered as the gold standard for urinary protein quantification. So why this albuminuria matters? Albuminuria is not only an early marker of glomerular dysfunction, it is also a strong independent predictor of CKD progression, cardiovascular disease, and all-cause mortality. We are focusing more on CKD progression here, but these three cannot be separated from each other, and albuminuria has to be seen in the context of all three. What drives albuminuria? There are three main pathophysiological pathways. One is endothelial dysfunction, one is podocyte injury, and the third is inflammation. All three go hand in hand, which leads to albuminuria and further CKD progression. So what role does UACR or urine albumin creatinine ratio does in CKD monitoring and management? There are three major roles of urine albumin creatinine ratio. First is in diagnosis and staging of CKD. Second is the risk assessment for development of end-stage kidney disease and the need for dialysis. And the third role is for monitoring during the pharmacotherapy and the therapy for prevention of further progression. We'll talk about first thing, which is diagnosis and staging. This heat map is very, very popular. We have all seen it. This is the CGA classification of CKD. The CGA stands for the cause of kidney disease, grade of GFR decline, and the grade of albuminuria. However, in this heat map, we can only look at two aspects of this CGA classification. One is the GFR grading and the other one is albuminuria grading. The cause, as usual, is ignored in this heat map also, and unfortunately, the cause is probably the most ignored part of the CGA classification. However, in present discussion, we are focusing on albuminuria. So A1, A2, and A3 are the three categories of three grades of albuminuria that were previously called as normoalbuminuria, microalbuminuria, and macroalbuminuria. Those three terms are now obsolete. And A1 category, which was earlier called as normoalbuminuria, now we do know for sure that this is not normal. Less than 30 milligram per day of albuminuria or less than 30 milligram per gram of creatinine in the urine is not normal. It is considered normal to mildly elevated. A2 and A3 is clearly indicative of further progression. So what is the difference between albuminuria and proteinuria and how do they relate to each other? In the early stages, when proteinuria is very much less, in those stages, albuminuria is a very tiny fraction of proteinuria. We can see that in A1 category, which is less than 30 milligram per day of albuminuria, total proteinuria at that time can be up to 150 milligram per day, which is more than 5 times of albuminuria. However, as the degree of proteinuria increases, the major fraction of that proteinuria becomes albumin. So A2 category corresponds to 150 to 500 milligram of proteinuria per day, and A3 corresponds to more than 500 milligram of proteinuria per day. That was about diagnosis and staging. The next is risk assessment. Which patient of diabetes and albuminuria will progress to CKD stage 5 and which patients will need dialysis? We have to assess, because the first question those patients ask us, Dr. Saab, dialysis ki zarurat to nahi padegi. And that is the only question we have to answer when we are assessing the risk. So, this is a brief summary of multiple large landmark trials that have already established that albuminuria is clearly associated with disease progression and albuminuria is the major risk factor for CKD progression. The ESCAPE trial which showed that that 50% reduction in the kidney progression can be seen with low proteinuria. Gluck et al. Clearly showed that proteinuria more than 1+ and hypertension would quadruple the risk of ESRD. CKID trial and ITALKID trial are the two major trials which evaluated the same thing in the pediatric population, and they show 84% higher risk of disease progression in those having A3 category of albuminuria as compared to A1 in CKID. Similarly, ITALKID trials also showed that those patients with more than 900 milligram per gram of proteinuria have much higher GFR decline as compared to those with less than 200 milligram per day of proteinuria. The 4C study shows 50% higher risk of ESRD with proteinuric patients. The Indian cohort also showed the triple risk in those patients with higher proteinuria, and a Japanese cohort was probably the one that showed the highest risk, the 7 times increased risk of ESRD in those patients having higher proteinuria as compared to low albuminuria patients. So with so much variation in different trials, how do we assess exact risk of any individual patient who asks us what is the probability of dialysis requirement in next few years? Here comes the role of kidney failure risk equation. KFRE can be considered as an equivalent of Framingham risk score in the context of CKD. The KFRE equation calculates the probability of end-stage renal disease and requirement of dialysis over 2 to 5 years by considering 4 core inputs. This is the simple 4-variable version which is most commonly used, and the 4 variables that are used in this equation are age, sex, eGFR, and urine ACR. However, if we give 4 more variables, if we put in 4 more values, then the estimate of kidney failure becomes more accurate, and a very precise probability of kidney failure can be assessed. These 4 additional variables are serum calcium, phosphorus, albumin, and bicarbonate level. Together, these 8 variables give us an estimated risk of ESKD over next 2 to 5 years. The formula is complicated and it requires an online calculator. This is a sample, a hypothetical patient who was 45-year male with ACR value of 350 milligram per gram and eGFR of 45 ml per minute per 1.73 meter square. Now this patient seems quite stable. The GFR of 45 corresponds to roughly a creatinine value of roughly 1.8, 1.9 maybe 2.0. If such a patient asks us in OPD, what are my chances of developing ESRD in next 2 to 5 years, we'll probably say no, you'll be fine. The thing is that we have been traditionally taught as the kidney GFR decline rate of 1 to 3 ml per year. Now 1 to 3 ml per year is the data that was obtained from large epidemiological based trials. They used many normal population also. They used strict guidelines for management of those patients, and hence those same data cannot be replicated in the OPD patient. Moreover, apart from eGFR, there are other risk factors also. Like for example, in this patient, serum albumin of 3.2 and bicarbonate level of 20 are another risk factors. So we put in these 8 parameters in this online calculator, and it gives us a 2-year risk of 5.6% of developing ESRD and requiring dialysis. The risk is much more, 23% at 5 years. The same equation also gives some suggestion based upon the KFRE estimate. Like for example, if the 5-year risk is 3 to 5%, these patients should be referred to a nephrology specialties. If the risk is 10% over 2 years, then these patients need team-based care with kidney doctor, nurse, dietitian, pharmacist. And if the risk is more than 20 to 40% over 2 years, then we need to plan about RRT. So now that we know what is the risk or probability of a patient to develop ESRD, what can we do? The next thing is prevention of further progression. And prevention of further progression, we know that prevention without prevention, treatment is simply unsustainable. And this prevention has multiple aspects, lifestyle and drugs. We can say if albuminuria has been established, this patient is already having diabetic nephropathy. What is there to prevent now? No, the primordial prevention and primary prevention in this particular patient is gone now. But secondary prevention for preventing the progression to overt nephropathy and tertiary prevention for preventing the patient to develop end-stage kidney disease is still possible. And in fact, the kidney failure risk equation also gives us how much risk reduction, how much prevention of this ESKD risk can be achieved with different lifestyle modifications and different pharmacological agents. For example, in the hypothetical example we just discussed, the KFRE equation tells us that blood pressure control can decrease this risk from 23% over 5 years to 18% in 5 years. Similarly, ACE inhibitors, SGLT inhibitors, and mineralocorticoid receptor antagonist like finerenone can achieve some amount of reduction in the risk as per this equation. So this is the traditional teaching. What can we do to prevent this further progression? Glycemic control and BP control are 2 of the cornerstones. UKPDS and ADVANCE are the landmark trial which told us decades ago that strict glycemic control and strict BP control will lead in reduction of proteinuria and reduction of CKD progression. However, modern therapeutics are albuminuria modifying, and these modern therapeutics are just 2 minutes more. Modern therapies are SGLT inhibitors, finerenone, GLP agonists, and RAS inhibitors. And we know that these 4 are the pillars of prevention of DKD in current era, 2025. These drugs work through 3 different pathways: the hemodynamic pathway, metabolic pathway, and the inflammation pathway. Here, the inflammation pathway is often ignored. Albuminuria is just one marker which is indicative of all 3 pathways, but more of hemodynamic pathways. So for this inflammatory pathway, we need to have some new biomarkers. This is a long detailed list of novel biomarkers which have been evaluated for progression of DKD. The list is very long, but NGAL, and KIM1 and TNF receptor antagonist. These are the leading biomarkers that are now being evaluated for early diagnosis of CKD progression. We'll not go into much detail. KIM1 and NGAL, as we already know, were once evaluated for AKI biomarkers. Now they are also being used for CKD biomarkers, but none of them are in clinical practice and none of them have been clearly documented as superior to ACR or EGFR. This is the summary, which biomarkers of these are predictive of retinopathy also, which can be used in DKD prediction and which can be used for prediction of cardiovascular risk. There was this large population-based cohort which evaluated 71 inflammatory biomarkers, and they found that 52 biomarkers were predictive of CKD progression and incident CKD. Out of these 52 biomarkers, 42 biomarkers were also replicated in the second cohort, which was Esther cohort. Both of these cohorts were evaluated in Germany. Many of these biomarkers also correlated with the urine ACR ratio also. Now, the new thing is point of care devices for ACR. Not yet available in the Indian market. Maybe one of them is available but not yet popular, and they are mostly useful for rural and primary care setting only, because that is where ACR devices or the sophisticated equipment for ACR are not available in the rural areas. That is where we can use these point of care devices. However, still lab confirmation remains important, especially when the result is leading to major treatment decisions. Limitations of albumin creatinine ratio, we all know that hematuria, exercise, infection, and non-albumin proteins excretion can falsely elevate or falsely decrease the ACR or PCR level. And apart from that, gender of patient, weight of patient, and the changes in creatinine excretion due to acute illnesses can also alter the results. Last slide. This is what KDIGO also tells us in their 10 major takeaways from CKD guidelines. One of those 10 major takeaways is that minor fluctuations of ACR should not be considered. It is minimum 50% reduction or 100% increase. After that, we can consider it significant improvement or significant reduction. Beyond that, below that, it can be random fluctuations. So, the 2025 perspective, treat to target approach, risk-based therapy sequencing algorithms, emerging biomarkers are there but not yet practical or accessible, and key insight is urine ACR still remains the most accessible and actionable biomarker. Thank you.
Thank you, Dr. Dipesh, for your very comprehensive and informative talk. Just a query, is there any Indian study which depicts the patient about the ACR that can stratify the high risk or low risk group according to the ACR?
Sir, we show a slide in which there were 7 or 8 trials, out of which one was Indian group also. That clearly shows that patients with higher ACR levels are at higher risk of.
Is there any cutoff? Higher is or lower is okay.
The cutoffs are clear: A1, A2, and A3. The A1 is less than 30 milligram per day. A2 is 30 to 300 milligram per day, and A3 is more than 300 milligram per day.
So that is equally applicable to the Indian population.
It is gradual risk. It is not. Okay. It is not a static cutoff. We cannot say that below 300 is zero risk and above 300 is higher risk. Right. As the albuminuria increases, the risk increases accordingly.
So is there any applicability of serum ACR if we combine with the urine ACR to stratify the patients high or low risk?
Sir, serum ACR, there is no such thing as serum ACR. Albumin creatinine ratio is not calculated in serum. We calculate albumin and creatinine in urine and we get the ratio done, and that ratio tells us how much is the proteinuria, or more correctly albuminuria.
So by the urine ACR or ACR, can we stratify or classify the patient is more prone to having the kidney disease or cardiac disease?
Yes, of course. That's why urine ACR value has been incorporated into the CKD staging itself, the albuminuria grading A1, A2, A3.
Right. We can ask if any questions from the audience. Yeah, there is one question.
Yes, that's what we were discussing in the last slide, the advantages and disadvantages of ACR. Acute illness is one of the disadvantages where ACR should not be tested, because ACR is not indicative of the chronic kidney disease in that patient. If a patient is admitted with infection and we check the ACR and it is found to be slightly above the normal value, it does not mean that the patient has got CKD. Acute illnesses, exercise, diet changes, there are multiple such factors which can cause minor fluctuations in ACR value. That is why in admitted patients we do not check ACR for long-term prognostication. Long-term prognostication ke liye ACR has to be checked in the OPD when patient is kind of stable.
One question from my side, Dr. Dipesh. Once we have detected abnormal UACR values, how frequently should they be checked for monitoring the progression or stabilization? What do you do?
The KDIGO does not recommend any testing frequency for these patients, but yes, ADA does recommend. And our first slide, which was third slide, which was showing the heat map, that also includes the frequency of ACR testing that is recommended by ADA per year. Like in advanced stages with high risk patients, the frequency should be at least every quarterly, 4 or more times per year.
Thank you. Thank you. We'll end the session.
Thank you so much, sir, for that concise and informative session. I would request our chairperson to felicitate our speaker, Dr. Dipesh, sir. I request Dr. Sahil sir to felicitate our chairperson, Dr. Arvind Kumar sir. Dr. Sharon Kandari ma'am. And Dr. Ravi sir. Moving ahead, we now turn our focus from the kidneys to another crucial aspect of metabolic health, lipid disorders in diabetic patient. Our next talk titled on Treat to Target Lipid Disorders in Indian Diabetic Patients. To take us through this important topic, we are privileged to have with us Dr. Kapil Sharma sir, Associate Professor, Department of Medicine, Aims Bilaspur. Before we begin, I would invite our esteemed chairpersons for this occasion, Dr. Raja Leri sir, Associate Professor, Department of CTVS, Aims Rishikesh, Dr. Rohit Raina sir, Assistant Professor at Department of Medicine, Aims Bhatinda, and Dr. Prakash sir, Assistant Professor, Department of Medicine, Aims Rishikesh. We welcome you, sir.
At the outset, I would like to thank the organizing team of CDS for having me here. So the topic today given to me to discuss is treat to target lipid disorder in Indian diabetic patients. And it appears to be a very simple topic. We have only few drugs to treat. We have statins, ezetimibe, and for the last few years we have bempedoic acid and some more emerging therapies. And most of us are aware what we have to do. We just have to start every patient or diabetic with either atorvastatin, rosuvastatin, and if need arises, some newer drugs. But like in the previous sections, it has been discussed that ACR has some target, and you know HbA1c target. So do we have some target, particularly in the Indian settings, for diabetic dyslipidemia? So in the next 20 minutes, I'm going to discuss this. So India is nowadays it's considered to having the largest population of the people with diabetes. and this number is going to grow in near future. Diabetes patients, they face 2 to 4 times more risk of ASCVD events. The dyslipidemia in diabetes is qualitatively atherogenic even when the LDL appears to be normal. There are, despite global guidelines are there, we will discuss, there is a lack of uniform Indian practice on the lipid targets. So purpose of this review will be, we have to discuss these targets in the Indian population. So as we know, typical lipid triad in diabetes is increased TGs, decreased HDL. LDL can be normal or near normal, but the LDL is the SD, that is small and dense LDL, which is more atherogenic. This kind of dyslipidemia leads to more diffuse atherosclerosis. The CTT meta-analysis shown that each 39 milligram of LDL reduction will lead to reduction of 22% of ASCVD. This benefit is continuous and safe down to less than 30 milligram per deciliter. And lower for longer is the new mantra. In Indian patients, coexisting metabolic syndrome, insulin resistance, and early onset amplify this risk. Hence, early aggressive and sustained lipid lowering is crucial for secondary and even primary prevention. So there are many guidelines to address these issues. There are guidelines from the ACC, AHA, European Cardiological Societies, National Lipid Societies, and very recently our own Indian guideline directed by LAI and which is endorsed by the Cardiac Society of India, it has been published. So what we do, first we have to risk stratify the risk in diabetic patients by measuring estimating the lipid profile. So we categorize all diabetic who are more than 40 years and without any target organ damage at the high risk. So most of the patients will fall into this category. Then there is a very high risk category. These are the patients who have more than one additional risk, which will include hypertension, obesity, smoking, and family history. Then there are extreme risk. These are the patients who have ASCVD, CKD, or evidence of target organ damage in the form of albuminuria, left ventricular hypertrophy, or peripheral arterial disease. In fact, the Lipid Association of India, in its latest 2023-24 guidelines, emphasize that early classification, since most Indian diabetics fall into very high or extreme high risk category. Risk stratification guidelines, they guides LDL goal and therapy intensity. So as I have already told, there are many guidelines, but if we have to remember one chart, this is the one chart which has been endorsed by the Lipid Association of India. So we categorize patient into diabetes without ASCVD and patient with ASCVD. Without ASCVD, if there is no target organ damage and 0 to 1 ASCVD risk factor is there, so we categorize them into high risk group, and target for LDL in this group is less than 70. Non-HDL, which is a primary target, should be less than 100, and ApoB level should be less than 80. But with one of the organ has shown some target, then patient will categorize into very high risk group. Here the target will be reduced to less than 50, non-HDL will be less than 80, and ApoB should be less than 65. Patient with any evidence of ASCVD will be extremely high risk category. So if there is no target organ damage, they will be categorized into extreme high risk category, category 1. Here the LDL target will be less than 50, non-HDL will be less than 80, and ApoB will be less than 65. While with target organ, the target is further defined. Here we can go up to LDL level less than 30, non-HDL level less than 60, and ApoB level less than B. So at the time of diabetes diagnosis, we have to send lipid profile including ApoB and lipoprotein A. at week 0, we start with the LDL lowering drugs, and as per the percentage reduction, we will see what kind of drugs, what doses count, which kind of the reduction. At week 4, we repeat the lipid profile with ApoB and continue with the same treatment if the goals are achieved. Depending on the level of LDL reduction required, and we may add additional LDL lowering drugs, and if triglyceride remains above 150, we will add the drug which has shown its potency in the reduced triad, that is the icosapent ethyl. At week 8, we repeat lipid profile with ApoB, and if all the targets are achieved, we will continue with the same treatment and follow up regularly to maintain them. Otherwise, proceed as below. Add the remaining available LDL lowering drugs. We have to screen for the FH. Aim to achieve LDL cholesterol, non-HDL cholesterol and ApoB target at the earliest. Make sure all modified risk factors are controlled, including diabetes control, aggressive lifestyle achievement, SGLT, GLP-1 may be considered if not contraindicated. So, if we take just the gist of these guidelines, the LDL level should be 70 in all diabetes, less than 55 in very high risk group, and less than 30 for extreme risk reduction. So, how often lipid screening and monitoring should be done? First, all diabetic at the diagnosis, they should have their lipid screen and should be complete lipid screening, which should include LDL, HDL, TG, non-HDL, as well as ApoB1, and once in a lifetime LPA, small a. Following follow-up frequency, every 6 to 12 months, if at target, may be done earlier if there is a dose change or target is not achieved. Additional test, ApoB when triglyceride are more than 200, lipoprotein small a, once in lifetime. It should be repeated if there is a history of premature ASCVD. So the objective should be dynamic monitoring and LDL goal is achieved and sustained. How to manage? Dietary modification, lifestyle modification, exercise, you all know, it as in done in diabetes, which can be replicated here also. Now the drugs. Drugs are the, statin are the oldest and the yet most effective drugs available to us. So, atorvastatin high dose is considered 40 to 80, while rosuvastatin two commonly used drugs in India in the range of 20 to 40 milligram. Moderate intensity will in the dose atorvastatin 10 to 20, while rosuvastatin 5 to 10 milligram. High intensity drugs causes reduction of at least 50 to 60%, while moderate intensity decreases LDL by 30 to 49%. All diabetes more than 40 years should receive statin therapy. Goal has already been defined. We have to monitor the side effects, adjust or switch in case of the intolerance. Now, what about non-statin add-on therapy? We have to add when LDL remain above target. Ezetimibe is the first drug to be added. It decreases LDL by 18 to 25%. The newer drugs like PCK9 inhibitors, they are available. They are of two kinds. They can be monoclonal antibodies or siRNA type. The cost is an issue. The inclisiran, although it has to be given biannually, but the injection of inclisiran costs around 1,20,000. So we have to see whether our patient can afford it or not. Then bempedoic acid is there. It is effective, decreases LDL by 20%, and it is quite effective in patients who has shown these statin-induced myalgias or myopathies. Now, just writing treatment on the patient file and asking him to take the statin is not enough. We all know that our patient take diabetes medication, hypertensive medication, but after 3 to 4 months, they will skip their atorvastatin dose. So how to increase the compliance? So we can make use of AI. You can ask if the patient is literal enough, educated enough, that you may use AI-based reminders on your phone. These are some of the apps which we can use. There are some pill reminders or all that thing. Remember, to just writing a prescription, our job is not finished. it is important that the pill goes into the patient's mouth. So the combination therapy, can we start with the combination therapy? Yes. Although there is we go by step, we can start with the high intensity statin in all the diabetic. If LDL is not, goal is not achieved, we can add ezetimibe. But in the high risk or very high risk or extreme high risk group, the combination of atorvastatin with ezetimibe or rosuvastatin with ezetimibe are easily available, so we can prescribe it at the outset also. We have to emphasize that treat to targets is step by step, and we have to sustain it over time. Now, what about the South Asian paradox? We do get ASCVD 10 years earlier than our Western counterparts, and the disease is more diffuse. So, the common phenotype is there is low HDL, there is high triglyceride, and there is a increased small dense LDL. Other contributor to this paradox is central obesity, insulin resistance, and the genetic predisposition. So, use non-HDL cholesterol and ApoB for better risk prediction. Aggressive early lipid management, even in borderline LDL, should be followed. What baseline test should be done to monitor the adverse effect of these drugs? So, baseline tests are the LFT and CK only if patient complains of myalgias. LFT should be done after 6 to 12 weeks after initiation and then annually. Lipid panel already been told. We can switch molecules, just 1 or 2 minutes more. We can switch molecules. If one suppose patient is not tolerating atorvastatin, we can switch to rosuvastatin and vice versa. Key message is benefit of statin outweighed its risk. This is one example. A 52-year male with type 2 diabetes for 8 years, no prior ASCVD, TG is 240, LDL cholesterol is 118. So he was started on atorvastatin high dose 40 milligram with LSM advice. When lipid profile was rechecked after 8 weeks, LDL cholesterol was found to be 75. Remember, the goal in this case was less than 70. The goal was not achieved even on 40 milligram. So the next time the physician did, he added ezetimibe. After adding ezetimibe, LDL came to be 52. Now the patient LDL is within the goal. But there are new emerging therapies. Inclisiran, I have already told you, this injection is available in India. Then there is ANGPTL3 inhibitors, not still available. The newer therapies like gene editing, messenger RNA based therapy, they are in the pipeline. Now, even after LDL target are met, residual ASCVD risk is achieved. To achieve this, ACC, ECSA and LI, they have all endorsed that non-HDL should be added as a co-primary target. So, in all diabetic, the triglyceride level should be less than 100 according to the risk category, which I have told in the previous the guidelines slide. So, for that, we don't have separate medicine for that. We just have to enhance the drugs which we are already giving. What about special population like CKD? CKD patient, they do have the similar risk as even more risk to have ASCVD, though they should be offered this therapy. What about elderly? They should also be offered, but lower dose can be started. What are the common barriers? Common barriers regarding statin, there are no barrier nowadays. Atorvastatin is even present in the PSCs, so it's very cheap nowadays. So every diabetic patient should be at least on atorvastatin. Integrating lipid management into every diabetes visit, stepwise approach is you have to calculate the ASCVD risk and classify into ASCVD, not by the ASCVD risk score or by the Q risk score. The score which was calculated in those studies, Indian population were not included. So you just have to categorize into high, extremely high, A and B, as in told in the LI endorsement. Always interpreted LDL along with the non-HDL and ApoB in diabetic with high triglyceride. If statin intolerance is there, you may switch over the drugs or you may give the alternative therapy. So, take home message is diabetic dyslipidemia is a high risk by default. LDL remain the central target, lower for longer improves the outcome. Indian patients often need earlier and deeper LDL lowering. Combination therapy is safe and effective when statin alone is inadequate. Lifestyle and adherence remains fundamental. treat to target is not just numerical, it's a continuous, personalized and proactive final mantra. Screen early, treat aggressively and sustain lifelong protection. These are the references which I have taken the concepts. So treat to target is like landing a plane. Roughly there isn't a runaway. CTT rule of thumb is decrease in LDL of 39 milligram per deciliter will reduce the 22% reduction in the ASCVD event. So from one day we should all think that right risk, goal, next lipid date on every diabetic file. Thank you very much.
Thank you, Dr. Kapil, for an excellent talk. I have a question. What is the best strategy to initiate statins in a patient newly diagnosed with diabetes? Is it based on the lab values of the lipid profile which he gets to you, or is it just to start with the lowest dose and then titrate up?
First thing, what I usually do and what is endorsed in these guidelines is we have to risk stratify the patient. Risk stratification is done on the basis of the live guidelines in India. Otherwise, we can use this ASCVD risk calculator, mobile app, or the Q-risk score. So we will categorize whether it is a high risk, extremely high risk, or what are the comorbidity in fact. So then we will define what target we have to achieve in this. Suppose in the first reading, and if I trust the lab, that lab is okay, patient has done the lipid profile which have been achieved, he is not, he is statin naive. So if his LDL is suppose 150, and I know high dose will reduce maximum up to 50 to 60%. So I will start with atorvastatin 40 milligram and see what kind of response I get in next 6 weeks. The patient comes to me in the 6 weeks, I again check for the compliance that he is taking his medication and see what is the LDL. If LDL is still 75, which is above the goal, that is I want 70 here, so I may add ezetimibe the second line therapy. This is what we usually do in these cases.
Just to follow up, sometimes in certain patients we found that the apolipoprotein B is normal value but the LDL is raised, so or vice versa sometimes. So what is the best approach? Like, should we keep on increasing statins or adding other drugs till all the parameters are met within the accepted range?
The first target is LDL. It is the primary target. TZs, ApoB, they remain the co-primary as well as the secondary target. We have to achieve our first target, and if we achieve, we will reduce the mortality to a larger extent. Now, there are no separate drug which will decrease the ApoB. Although TZs will be reduced by the IPE, which is still available in the dose of 4 milligram per day, and it is affordable also. So if primary target is achieved, then we will focus on the second co-primary and secondary target. But LDL goal should be achieved.
Sir, such an enlightening talk. Sir, any specific guidelines for type 1 diabetic patients or secondary diabetic patients, patients who are diabetes with secondary parameters?
Specifically, these guidelines, the live one, they mostly address the type 2 diabetes because the specifically, I'm not very much sure if these targets do apply to the type 1 diabetic also, because we usually deal with some of the endocrinologist and person is there. You may be able to answer it in a better way.
My one question, suppose we tightly control the lipid profile, what will be the complication? Because our brain is made up of the lipid. So is there increased chance of Alzheimer's disease if we tightly control
the... Very interesting question, because I also thought of this question. There is one population which I have come across, they have lipid in the range of LDL range of 10 to 15, just 10 to 15. But they do not have like such any complication if LDL is reduced to such an extent. Some of the studies do mention that some of the patients, they have some retinal changes when LDL was reduced to so much level. But as lies endorsing, they are going up to 15 milligram per deciliter in extremely high risk patients. So we will see.
Yeah, I think justice is done to the topic. If you look at the trajectory of how lipid lowering agents, they had a place in the management of diabetic dyslipidemia, initially there was a lot of hue and cry regarding the lipid lowering agent. They said that there is no added benefit once you start them, so discontinue them. But then the main reason was the targets were not achieved. So initially targets were not achieved because the targets that were set earlier, they were really high. So at that level we were not anywhere, reducing the overall cardiovascular morbidity as well as mortality. So that is why the new and newer targets are being defined for LDL at least. The idea is, please be aware that it is not the HbA1c which is going to benefit the patient more. It is the lipid lowering which is going to benefit the patient more. So try next time not to see the HbA1c, which is almost an impossible task to achieve in no more than 10% of Indian diabetic patients. Whereas achieving lipid targets is quite easier, simpler. You need to reorient the minds of the patients because they will often discontinue it because there is no direct benefit of lipid lowering agents. So please focus, stratify, and then you have to teach your patient that you have to take it forever. That is the key message. I think this is something which I wanted to add to your discussion. Thank you.
Thank you.
Thank you so much, sir, for enlightening us with such an informative and concise talk. I would now request our chairpersons to kindly felicitate our speaker, Dr. Kapil Sharma, sir, as a token of our gratitude. To felicitate our chairpersons, I request Dr. Namrata ma'am to felicitate Dr. Raja Lahiri sir. I also request Dr. Namrata ma'am to felicitate Dr. Prakash sir. Now, as we move ahead, it's time to bring a bit of energy and perspective into the hall with a debate session on a very interesting and a relevant topic in diabetes therapeutics. The topic for the debate is Trelagliptin, the future of convenient diabetes therapy. To explore both the sides of this argument, we have with us two eminent speakers, Dr. Rohit Raina sir, Assistant Professor at Department of Medicine, Aiims Bathinda, who will be speaking on the opportunities, and on the opposing side, Dr. Aniketa, Assistant Professor at Department of Medicine, YS PGMC Nahan, who will be speaking challenges. For this, I would like to invite our esteemed chairpersons for this session, Dr. Mukesh Bhairava sir, Additional Professor, Department of Medicine, Aiims Rishikesh, and Dr. Gaurav sir, Additional Professor, Department of Pharmacology, Aiims Rishikesh, to kindly chair the session. Please welcome Dr. Rohit sir to present the opening statement.
So, first of all, I want to thank Professor Ravikant sir and his organizing team for giving me the opportunity to speak on this platform. So, my topic of discussion is Trelagliptin, a future of convenient diabetes therapy. So, I will start with my presentation with this beautiful meme or quote. Doctor said daily pills, but the patient grinned, no doc, I am chilling, it's Trelagliptin. So, my topic of discussion is Trelagliptin. So, Trelagliptin, it's a novel orally acting DPP-4 inhibitor, and it has highly selectivity for T-cell activation antigen CD26. It is recommended as an add-on therapy with metformin, can also be used as a first-line therapy if metformin is not suitable, and can be used if other drugs like sulfonylureas, SGLT2 inhibitors are not controlling the sugars. And also, it is differentiating from other gliptins like sitagliptin, linagliptin. So the difference is that it is used once weekly dosing, and it improves the patient adherence as compared to the once daily dosing, because the dosing is once weekly. And it has potential for a better glycemic control. So the phase 3 trial showed positive results, and the development was discontinued in USA due to the cost concerns. And first of all, approved in Japan in 2015, but yes, it was approved in India on December 26, 2024 for India also. So the mechanism of action is same as that of other gliptins, like it increases the DPP4 levels in the body and also increases the release of insulin and glucagon from the cells, and thereby decreasing the blood glucose levels and reducing the HbA1c levels. So mechanism of action is same as of other gliptins, but yes, it has a strong DPP4 inhibition. The maximum inhibitory concentration, IC50, is 1.3 nanomole per liter as compared to allogliptin, which is quite high, 5.3 nanomole per liter. And the inhibition is 77.4%, even sustained inhibition 7 days after the last dose. The levels are quite high. The GLP levels are quite high after a meal, and the efficacy is good as compared to other gliptins. The GLP levels are high, and there is significant HbA1c reduction as compared to placebo. And the glycemic control in terms of fasting insulin, C-peptide levels, HOMA IR and HOMA beta levels were significantly improved. A bit about the pharmacokinetics. And the Cmax concentration, maximum concentration achieved was quite high in 1.3 hours. It was 619.4 nanogram per ml, and the area under curve is also 6601.7 nanogram per ml. And the elimination half-life, it has a biphasic elimination half-life. The T half-life is 18.5 hours, follows a biphasic elimination kinetics, and it's metabolized by the CDP2D6 enzyme, and the main excretion is by the kidneys, which is 76%. The plasma protein binding is 22 to 28%, and in patients with renal dysfunction, the Cmax and AUC, area under curve, is increased, and so these drugs is contraindicated in patients with severe renal impairment and the patients who are having creatinine clearance less than 30, although reduced dose can be given up to 25 mg per day, per week. So the dose reduction in patients with moderate renal impairment is 50 mg weekly. So same, like once weekly dosing, better adherence as because of less frequent dosing, comparable efficacy, a better HbA1c reduction as compared to DPP4 inhibitors. The pill burden is very low, weekly dose, and reduces the medication load, and the quality of life is improved and has a similar safety profile as compared to other gliptins. So highly selective, potent, long-acting DPP4 inhibitor forms a non-covalent bond with DPP4 and has a slow binding with DPP4. The half-life is of 30 minutes. It has having slow dissociation from the DPP4 and is having more potency, like 4-fold potent than allogliptin and 12-fold more potent than sitagliptin. And the efficacy is quite sustained, and the better thing is that it has a good potency, a high potent drug when leading to sustained efficacy. So coming to the adverse effects, because of potent DPP4 inhibition, the adverse effects were more in terms of nasopharyngitis, which was 23% trilacgliptin, and allogliptin was having 21%, while other side effects were quite comparable, and trilacgliptin was having only 5% of treatment emergent adverse effects. And the hypoglycemia was only seen in patients who were already on patients with sulfonylureas or the patients who were taking insulin along with the trilacgliptin. And the cardiovascular safety, there is no clinically significant data regarding differences seen in the ECG parameters, vital signs, and the lab tests. So the contraindication is the severe renal impairment. The patients on ESRD or organ dialysis, eGFR less than 30, are the contraindicated, and the hypersensitivity to trilacgliptin or the excipients is a strong contraindication. The patients who are having EGFR less than 30, the dose can be reduced to 25 mg per day week. Yes. So there was a trial, the renal impairment trial, which showed that what was the dose of telegliptin in less than 30 ml per minute creatinine clearance, and which will be studied in the later slides. So in terms of hepatic impairment, this was excluded from phase 2, phase 3 and long-term studies, and there was no minimal impact on the hepatic dysfunction. The AUC increased very smallly by 5.1% and Cmax was decreased by 4.3%, and there is no dose adjustment required in patients with hepatic impairment, although it is primarily excreted by the kidneys, and there is strong, not as strong, but it is a metabolism binding based inhibitor of cytochrome 3A45. So the cardiovascular safety. So unlike other gliptins who are having a strong trials, and they have completed a dedicated trials on telegliptin like TCOS trial, SAVER-TIMI trial, EXAMINE trial, this telegliptin, it lacks a cardiovascular safety data. So saxagliptin. So, but yes, there was one study done on the serum adiponectin levels, which showed that this telegliptin increases the level of serum adiponectin levels and also decreases the level of asymmetric dimethyl arginine levels, which increases the levels of nitric oxide and leading to the flow-mediated dilatation. Elderly patients up to 1 can be included in this patient, but yes, it is to be used in caution with dementia and cognitive dysfunction, and because of there is it requires a third-party assistant in these patients. So yes, as compared to other gliptins, we can see that the dosing is once weekly only, and the half-life is 5 days, and it's a weight-neutral drug, and there is no hepatotoxicity, although it is the elimination by kidneys. The dose is to be reduced in patient with renal failure, and the dosing is once weekly. So it has a comparable HbA1c lowering efficacy as compared to other gliptins, and the HbA1c reduction is 0.7 to 0.9%. So there were few trials done on the telegliptin. The study one showed that even given as a monotherapy or in combination therapy, the effect was quite good, and the HbA1c levels were reduced to -7.4 to -2.25% across all groups, and the treatment-induced adverse effects were very low, and the hypoglycemia was not seen in these patients. Another study showed that even in use as a monotherapy, it was a study done in Japanese population, which showed that the patients who received telegliptin 100 mg had a better compliance, and the treatment compliance was 99.45% up to week 12. There were another study like Cambodia Trella real study, which showed that the patient satisfaction rate was quite good, 97.4% in patients, and the HbA1c reduction was 1.26% at 6 months as compared to the other studies. And this renal impairment trial, we showed that the patients who were having renal impairment, the dose was reduced to 25 mg once weekly. So comparing to the cost, the cost is as compared to other gliptins, the daily cost is 17 to 20 rupees per day. So the other gliptins are costing the same because of once weekly dosing, because the cost is same once 17 to 20 rupees per day. But as compared to other drugs like bigonides, sulfonylureas, the cost is quite high. They are more cheaper drugs, bigonides, sulfonylureas, and combination therapy. But as compared to SGLT2 inhibitors, the SGLT2 inhibitors are the more expensive drugs as compared to the telegliptin. Safety profile. Pregnancy safety is not studied, pancreatitis is not mentioned, and the studies were quite limited, and the more complex schedules were seen. And so these are the clinical trials. So take-home message is that it is it's a long-acting DPP-4 gliptin. Once weekly dosing is required, and better patient adherence, and more DPP-4 inhibition. Requires treatment in the contraindicated in severe renal impairment, and the long half-life allows for once weekly dosing. So I will conclude my presentation by a short poem. Trelagliptin, oh what a name, once a week pill plays the game, keeps sugar low, keeps doctor in chair, take it just once, not every day dear. Metformin size, I am still the king, but Trelagliptin got that zing. No daily dose, no constant fuss, just one small tab, less work for us. Pancreas says, you make me grin, GLP-1 up and I am insulin. Diabetic smile, you are quite a win, oh clever, sweet Trelagliptin. Thank you very much.
I think it's very nice presentation. I think we should also listen the second speaker.
Now, to present the counter view, I invite Dr. Anikita ma'am to share her perspective on the challenges one must be mindful of.
Good evening, all of you. First of all, I would like to thank Dr. Ravikant for giving me this opportunity and invite me here. Respected chairpersons and my respected opponent. So here we start. So again, I'm today talking against the motion, is really Trelagliptin the future of convenient diabetes therapy? So I rise to speak against the motion that Trelagliptin represent the future of convenient diabetes therapy. Convenience alone cannot be defined the future of diabetes care. What we truly need is efficacy, safety, affordability, and long-term outcome data. So unfortunately, Trelagliptin falls short on many of these parameters. So let's discuss one by one. First of all, limited global acceptance and evidence. So it is approved regionally. So regional approval only, unlike sitagliptin or linagliptin, Trelagliptin is approved only in Japan and India. No major regulatory approval is there with Trelagliptin. Like there is no approval from major regulatory bodies like US FDA and EMA. Reason? Because there is insufficient large-scale, long-term clinical data which is providing the cardiovascular safety and durability of the glycemic control. So without such robust global evidence, calling it as this future, it is really premature and scientifically unjustified. So we can't say that Trelagliptin really has a zing. Short-term data, no long-term outcome trials. So what we have about Trelagliptin is the existing studies on Trelagliptin are mostly small industry-sponsored trials of short-term duration. And we have no cardiovascular outcome trials, no renal outcome trials, and no studies showing mortality benefit, and moreover it is weight neutral. There is no added benefit of reduction of weight. And what we need actually, in contrast, like other classes of anti-diabetic drugs, like SGLT2 inhibitors and GLP-1 receptor agonists, which have proven reduction in cardiovascular and renal events, although along with weight reduction, clearly setting the benchmark for the future of diabetes therapy. So really, convenience, is it equivalent to the superiority? Really, we will go for convenience only, that we will take one tablet 1 week, that's it, whether it is superior or not. So let's see that one by one. So weekly dosing, yes, I agree, Trelagliptin offers once weekly dosing, but convenience does not automatically translate to better glycemic control or adherence. So because there is no added HbA1c reduction advantage, and studies have shown no significant difference in HbA1c reduction as compared to the daily DPP-4 inhibitors like sitagliptin or linagliptin. And if we see the real world risk, moreover, if somebody missed a dose within a week with a weekly drug, can lead to poor glycemic control for several days, which is really real world risk in elderly and in patients with decreased memory like Alzheimer's disease. Now coming to the safety concerns, post-marketing data is still limited for trilagliptin. We still don't know enough about the long-term hepatic, renal, or immunological safety of this molecule. Other gliptins have undergone more rigorous testing across the diverse population. In contrast, trilagliptin evidence is based, which is based on a narrow and largely confined to the Asian cohort only, making it making its global application questionable. And economical and practical limitation. Now we are really announcing it very cost effective. I don't think so. Cost reality, trilagliptin may be marketed as cost effective, but its per week cost often equals or sometimes exceed that of daily gliptins when calculated monthly. And there is another concept of physician inertia or physician hesitation. Moreover, being a physician, if I would have to switch a stable patient from a well-studied molecule just for the dosing convenience, I won't go for it, which is called as physician hesitation. And another is limited uptake. Thus, in this real world, uptake remains limited even years after its introduction. So the real future lies beyond DPP-4 inhibition. With the rise of SGLT2 inhibitors, GLP-1 analogues offering organ protection, weight loss, and mortality benefit, the DPP-4 class, including trilagliptin, is being increasingly used as therapeutically stagnant class. Hence, calling a weekly DPP-4 inhibitor as a future really ignores the ongoing paradigm shift in diabetes management. One side we are saying that there is paradigm shift in the diabetes management. We are really going to save the organs, but this is not going to happen with trilagliptin. So if we go with the scientific data, so I have made few slides on the summary of the clinical evidences. So most of the trials on trilagliptin was done in Japan. So it is on Japanese population based. So there was a phase 3 multi-centric open label study in Japanese patient which ran for about 52 weeks. And the result was HbA1c reduction in the range of 0.7%. And the limitation was, it was open label trial, there was no control arm, it was done in Japanese population only. So generalization of this molecule may be less for other ethnicities, we can't say that. Another concern, there is a review article which has shown that the safety profile of the trilagliptin is similar to the once daily DPP-4 inhibitor, that is linagliptin. But in clinical relevance, if we see, then reinforces that trilagliptin appears safe in studied population, but again mostly in Japanese data. So we cannot generalize this statement for whole of the world that we have studied this molecule in this particular population and it is safer for all the ethnicity across the world because it is not studied in that larger population. So this is another trial which was again done in Japan. It was open label exploratory phase 3 study in Japan, including only 14 patients in which they have did glucose monitoring, and they have found that the sample size of the study was very small because there were only 14 patients included in it. So keeping the view that this evidence is weak, we cannot say that switching to weekly dosing may maintain a control in a stable patients. Efficacy and safety of trilagliptin in type 2 diabetes patient with CKD and stage renal disease. There was a trial which was double-blind phase 3 trial, and this study was again done in Japanese only. So the limitation of this study was, it was done for 12 weeks, means 3 months trial only, done only in Japanese population, in a very small number of population. So the safety data is also not very much sure about trilagliptin. Now come to the glycemic variability. Yes, they have shown in studies that there is decrease in glycemic variability with use of trilagliptin, but see the data and the sample size. The trial was done only for 29 days. So with such small sample size, such small duration study, we cannot compare. The weekly trilagliptin may reduce glycemic variability similar to the daily DPP-4 inhibitor. No, we cannot say that. But comparative magnitude and long-term impact are less established. So in preclinical studies, it has been shown that trilagliptin has impact on insulin resistance as well as it act on adipocytes, but there is no human data yet. Also, please 2 slides more. Also in preclinical study, it has been shown that it is helpful in NAFLD, but this study was done in mice and there is no human trials which are based for this study. So, take home message and the clinical implication about trilagliptin is that real world settings are still limited. We need more evidence-based desirable data. NAFLD, anti-NAFLD properties has to be proven in human data, and all the studies which were done in a particular population, it was done in Japanese, so we cannot generalize the statement. So conclusion is that trilagliptin is a convenient option but not a revolution. It may have a place in therapy for selected patients, but it cannot be the future when it lacks global validation, long-term data, outcome superiority. So convenience without confidence is not the future, it's just a temporary comfort. Thank you so much.
So I also invite Dr. Rohit on the podium. So madam says that trilagliptin having the similar effect or other gliptins, but the issue is that this is the new drug, there is no post-marketing surveillance. The HV reduction is not significant, weight reduction is also not significant. But some positive points that ma'am also mentioned, that you have to mention, but ma'am mentioned that key trilagliptin having less glycemic variability. So we all know that the effect of diabetes, it depends on the glycemic variability. So time in range is very important. So you think that trilagliptin ma'am is more in favor in the time in range than the other gliptins?
No sir, I don't think so. We should not take anti-diabetic drug. We have to take it only once weekly. That's it. That's not our target. Our target is to target organ protection, decrease the glycemic variability, and we should be sure that this molecule has been studied thoroughly and has cleared all the phase trials.
So in this scenario, sir, in this scenario of polypharmacy, we're using multiple drugs in the patient, sir. I think, sir, this is a better drug, giving once weekly, having a better safety profile and a comparable safety profile as compared to other gliptins, having a good cardiovascular, not, sir, data is limited, but yes, it increases the level of serum adiponectin levels, also has an equivalent or even better HbA1c lowering and once weekly dosing, and the better thing is that a strong non-covalent bonding with this DP4 inhibition, a potent DP4 inhibitor. So I think it's a better drug in future. That's why it will be used in future.
Okay.
So one point I want to raise. Still the first line is metformin, which has the best mortality benefit. Second one is SGLT2 inhibitor or / GLP-1 agonist. So when we are giving metformin twice daily, and most of the other gliptins are coming in combination with metformin, and we are giving SGLT2 inhibitors daily to the patient. So patient is already taking gliptin with metformin and also taking SGLT2 inhibitors. So I don't think there will be much pill burden. They have to take metformin and SGLT2 inhibitors. Already they have to take, because first two lines are they. So we cannot say that just because it's only once weekly drugs, there should be boom and it should be taken very warmly. I don't think so. I don't think so, because they have to take metformin, SGLT2 inhibitor daily तो लेनी ही पड़ेगी. तो combination के साथ और gliptins भी चल रही हैं. मुझे नहीं लगता उसमें कोई खास problem.
One more question is, by fear of any drugs that this drug may develop any adverse effect in the future.
Yes.
So if you fear develop in a scientist or a physician, there is no chance of newer drug come in the market. So you are afraid that patient may have a adverse effect, so this drug is not
No, I don't have fear, but I want when we physician, as a physician, we prescribe any medicine, we should have that confidence कि इसकी detailed study हो चुकी है. I am very confident कि एक हफ्ते में एक गोली खाने वाला patient मेरे पास किसी भी problem के साथ वापस नहीं आएगा. जब तक इसके सारे data नहीं आ जाता है, clinical trial clear नहीं हो जाते, I don't think so it should be marketed.
Sir, that's why it's the future, not present.
I don't think it's future even. Future is GLP-1 analog and SGLT2 inhibitors only.
So considering that diabetes has multiple microvascular and macrovascular complications, would you still prefer trelagliptin with metformin in comparison to the other available drugs?
Sir, so although it lacks a robust cardiovascular data, but it can be given with metformin because it increases level of serum adiponectin levels, which is a good thing in this.
But that is in the preclinical studies,
yes, sir,
not in the human
yes,
clinical trials.
Not in clinical trials.
And you skipped the comparison between GLP-1 agonist and trelagliptin in your presentation. Was that by choice or
No, sir,
that was a glitch?
I think that was by choice by Dr.
But it was very rough for you in comparison to Dr. Aniketa, definitely, because all the evidence, I think, favor not to use trelagliptin right now. It's too premature.
Yes, sir. It's too premature, but I am still saying it's a future.
But still, I'm still winning the debate. Thank you.
So I
Thank
think,
you.
yeah, may I say a few words? Yeah. So I think it's a wonderful debate. Congratulations to both the proposers and the opposers. My only humble submission is, I think there are challenges and in fact opportunities. There is an opportunity in adversity. So for example, Dr. Aniketa has told there are so many adversities, but there is an opportunity, a window of opportunity for labile diabetic patients. They are a special population of patients, say for example, geriatric patients, who are developing diabetes for the first time after 5th or 6th decade, where the sugars are not very high, where you do not expect life expectancy to be much, and you fear hypoglycemia. So this drug is really a good promise to this population, especially this population. So this is my take for this trelagliptin. Rest depends on the judges who are sitting. Thank you.
Thank you.
Thank you to both our speakers for such an enlightening and spirited discussion. Now, may I request our chairpersons to felicitate both our speakers, Dr. Rohit Raina sir and Dr. Aniketa ma'am. May I kindly request Professor Dr. Ravikant sir to felicitate our chairpersons, Dr. Gaurav sir and Dr. Mukesh Pairwa sir. As we approach the final scientific session of the day, we turn our attention to a topic that beautifully integrates innovation with practicality in diabetes care. Aiglar Lixi, a solid approach for comprehensive type 2 diabetes management. To share more on this, we have with us Dr. Shunil Mishra sir, Director and Consultant Physician, Diabetes and Endocrinology at GEIMS. Before I begin, I would like to invite our respected chairpersons for this session, Dr. Seema Mahant ma'am, Professor, Department of Medicine, Aims Bhopal, and Dr. U.S. Silpi sir, Senior Physician at BHEL, Haridwar.
This is for advance. Fine. Shall I start, sir, with permission? Thank you. So, good evening, everyone. So, thank you, Dr. Ravikant, Professor Ravikant, for inviting me in All India Institute of Medical Science. AIIMS is always, my heart and being my alma mater, but to the Aiims Rishikesh, I am visiting for first time. Thank you. So, I will be speaking on I-GLAR-LIXI, that is insulin, glargine, and lixisenatide combination, and how it holds a solid approach for the comprehensive diabetes management. We heard about the terlagliptin, that is increasing the endogenous gliptin, but now we are giving a GLP receptor agonist from outside along with the basal insulin and how it works well, because this principle is holds on the notion that when you give basal insulin, you control the fasting hyperglycemia, and by giving the GLP receptor agonist, you also take care of the postprandial hyperglycemia. So this trial, landmark trial, was a prospective trial done in the country, and which showed that the control is dismal, which Professor Ravikant was also talking that hardly 10% will have HbA1c less than 10%. And the situation is similar, right? And many people with the diabetes will also have by the time they reach to us. If you look at the window of opportunities, probably on the number one part of the slide, that diabetes, there are multiple pathophysiological defects. So it is called as ominous octet, but probably to look into the positive aspect, there are 8 different opportunities to control diabetes. So A, you be on the negative side, but you be on the positive side, means you can control. And now, if today we have multiple different approaches to control diabetes, and we can combine different drugs, probably the sustenance of the control in long run is going to be better. As we know, the diabetes is a progressive disease. So by the time a type 2 diabetes is detected, 30 to 50% of the insulin reserve is gone, and with the over the time the reserve will go further down. So the unmet need is that you tell your patient to start on the drug, diabetes is uncontrolled, people will start taking drug, but the follow-up is going to be very poor, and by the time they come next time, the HbA1c is again high, and with that the time passes and the glycemic control remains poor, and they develop the complications, right? So most of the people are uncontrolled. So how we can start about the insulin? So insulin in type 2 diabetes is not like a type 1 diabetes. So if I ask you type 1 diabetes means it's a basal bolus therapy, that's the gold standard of the treatment. In type 2 diabetes, there are opportunities before you start full basal bolus therapy, a basal insulin, basal plus bolus, that is basal plus approach, or addition of the GLP receptor agonist in between does help in maintaining sugar control, glycemic control for longer duration of the time. So there are multiple, and every approach will have a benefit and its challenges, because diabetes being the progressive disease, so obviously insulin is required at some point of the time. Mechanism of action, one is different, and both are the potent agent to control hyperglycemia, insulin as well as the GLP, receptor agonist. Convenience, because anyway you are giving your patient everyday injection, so on the top of that, if it is been combined with the GLP receptor agonist, it will definitely help and patient further. Greater persistence, reduction in the adverse effect, and probably the delay the progression of the disease related complication, because of you are maintaining the hyperglycemia better. So how it works? When you give the basal insulin, the basal insulin will decrease the hepatic glucose output, the fasting hyperglycemia improves. When you give the GLP receptor with it, GLP receptor will cause glucose dependent insulin release and suppression of the glucagon, so that will help in the maintenance of the postprandial hyperglycemia. So single shot will taking care of the fasting as well as the postprandial hyperglycemia, so therefore this approach works better, right? So looking at this thing, there are multiple pathophysiological defects as I told about, and this combination works at the multiple pathophysiological defect except for the renal glycosuria. So like at the liver and the fat and the intestine and the brain. So therefore the sustenance is going to be better compared to other. And therefore multiple organization has approved the role of the GLP receptor agonist. And if you go to the algorithm of the type 2 diabetes, GLP receptor agonist has gone much up in the hierarchy of the treatment. And especially I am talking about the GLP receptor agonist with the benefit, cardiovascular outcome benefit, a drug that was earlier put in the multiple 6 boxes before 2017, now has found a place much up in the hierarchy, right? So now the drug competes with metformin at some places, especially, and even before metformin at some places. So now I'll come to the focus just on this combination where it is the insulin glargine, which is a daily insulin injection, a well-tested long-acting basal insulin since 2000 in a combination with the lixisenatide, which is considered to be a short-acting GLP receptor agonist given every day. Now you combine both together, what is going to happen? So obviously in today's era we need to look into the clinical trial rather than speaking on my own experience. So there have been multiple different trials, patients who are suboptimally controlled on oral anti-diabetic drug, patients who are controlled, suboptimally controlled on basal insulin, suboptimally controlled on the GLP receptor agonist, and then such switch studies. I will not go into the detail because I will go to the 2-3 trials which I am going to show you right now. SOLID D study. SOLID D study is the glargine and lixisenatide was looked into people with the type 2 diabetes who are suboptimally controlled on oral anti-diabetic drug, and one arm was given the glargine and lixisenatide, iglar-lixi, and other arm the co-formulation. The co-formulation, as you know, is insulin degludec and aspart. So how insulin and degludec aspart works? It's the basal plus kind of the therapy, right? So you are giving one step ahead of the basal, so basal plus therapy. People in the trial were more than 45 years, type 2 7 to 8 years, so they were already on multiple anti-diabetic drug, HbA1c near 8.5% and BMI 20. So randomized to the 2 arm, one arm was the insulin glargine and lixisenatide daily, and other is the degludec aspart, and in end point was the primary end point is to look at the non-inferiority in the HbA1c from the baseline to 24 weeks. Now this is the baseline data. So age, gender, the BMI, the duration of the diabetes, HbA1c, and the metformin proportion, and SGLT2 at baseline matches in the both arms, so I will not go into that detail. Look at the clinical result. So what happens after giving the 2 different agents? Iglar-lixi showed a superiority over the insulin degludec aspart in terms of the HbA1c reduction. So here we are dealing with the baseline HbA1c of 8.58 in the iglar-lixi and insulin degludec aspart 8.53, comparable. So drop in HbA1c with the iglar-lixi was 1.88 from the baseline versus insulin degludec aspart, which we commonly use, it's around 1.68. So you are actually comparing 2 different agents in basal plus bolus insulin. Here you are giving basal insulin plus lixisenatide, a GLP receptor agonist. So that means a statistically significant difference is there. Now how this is happening? Is it increasing the body weight? No. The probably body weight change from the baseline to 24 week was less in the iglar-lixi compared to degludec aspart, because here you are giving GLP receptor agonist, and the mean insulin dose. So that is from the iglar-lixi combination was actually less. So people who the insulin degludec aspart was 34 unit and 28 unit in this arm. Also the composite endpoint means proportion of the people who are achieving HbA1c less than 7%, 12.7% more in the iglar-lixi, and HbA1c less than 7% without body weight gain at 24 weeks were more. And the third composite outcome is that when we take everything, less than 7% body weight gain and no hypoglycemia were again more in the people with the Aiims-Rishikesh compared to insulin degludec aspart, and that is expected also. So that fulfills the trial. And lower evidence of the hypoglycemia. Next thing is that does it increase? Because we know that degludec is the insulin which has a lesser propensity of hypoglycemia compared to any other basal previous generation, the first generation basal insulin. So in this arm, when we combined Aiims-Rishikesh with compared with the insulin degludec aspart, any hypoglycemia was less, 35.2% to 40.5%. In any hypoglycemia, ADA level 1 and level 2 hypoglycemia, the pink one is less in Aiims-Rishikesh, and similarly, the event rate of hypoglycemia were lower in people with Aiims-Rishikesh compared to the degludec aspart. So in nutshell, what this SOLID study tells us that statistically superior HbA1c reduction, body weight maintenance, superior body weight benefit, more patient achieve a composite endpoint, lower risk of the hypoglycemia, and nothing unexpected kind of the adverse effect profile was seen in the. Now I will show you another study which is again interesting also, where Aiims-Rishikesh in type 2 diabetes was suboptimally controlled on the insulin. So SOLI-mix, right? So people are already on the mix insulin twice daily, because this agent probably the place is where either we are considering for the co-formulation or the mixed insulin, right? So there it fights with the injectable ring. So Aiims-Rishikesh versus biphasic aspart 30. So people are on the biphasic aspart twice daily, or you are giving one single injection of the Aiims-Rishikesh. So you are comparing now. Earlier one you are comparing with the co-formulation. Now look at the patient population, 57 year, mean age, diabetes 12 year, already on oral anti-diabetic drug, HbA1c was 8.7% and the BMI is 28%. So one arm goes to the Aiims-Rishikesh, other you are giving the biphasic aspart twice daily, and India also contributed 182 patient for this, not a long-term trial, but 26-week trial for dose formulation. So in this trial, giving a single dose of the Aiims-Rishikesh shown a better HbA1c control, superior than the biphasic aspart at 26 weeks. So from the baseline, 1.3% reduction versus 1.1% HbA1c reduction versus the biphasic aspart. And the body weight change, as you see, we know that the biphasic insulin have a more chance of having the body weight gain. So obviously this is the GLP added to the basal insulin, and basal insulin doesn't cause that much of the weight gain, was superior compared to the biphasic aspart. The composite target achievement, the first one is the number of patient achieving HbA1c less than 7% more in the patient when the Aiims-Rishikesh, and then the HbA1c less than 7% without weight gain, and finally without hypoglycemia were more with the Aiims-Rishikesh compared with the biphasic aspart, that is the analog mixed insulin twice daily. And required a smaller mean daily insulin dose was lower compared to the biphasic aspart. So 10 versus the around 30 unit in the biphasic aspart. So lower hypoglycemia at any time with Aiims-Rishikesh versus the premixed insulin. Here we definitely expect that the people will have more hypoglycemia because this is biphasic aspart, and even compared with the, we have seen insulin degludec aspart. So anytime level 1, level 2 hypoglycemia and incidence of hypoglycemia were lower in people when they were taking this Aiims-Rishikesh compared to the biphasic aspart twice daily. So summary from this trial, the SOLI-mix study says that it's a better glycemic control with weight benefit, lesser hypoglycemia, fewer daily injection. You are giving one single injection but giving more benefit, right? Not inferior at all. And similar proportion of the adverse side effect, and so it is considered that efficacious, simple and well tolerated in people with type 2 diabetes who had the uncontrolled diabetes. So about the little bit about the titration, because many of us has not used a drug quite frequently, and it is not been say promoted by the company as well. We've been hearing this drug for last, I would say 7-8 years, but it's very the problem is that availability and the routine use is less. So we have probably one single type of the pen in the country which has the combination of the 10 and 40. So Iglar Lixi, few slides more. So which is the 2 unit of insulin glargine and 1 microgram of the lixisenatide. So per 3 ml pen will have 300 units of the insulin glargine and 150 microgram of the lixisenatide. And the dose, how do we start? If you look at the, if on the, depend upon the previous therapy, you are starting in a person who is the patient is the insulin naive, not taken insulin, or on OAD or GLP receptor agonist, or having glargine less than 20 units per day. So just start with the 10 dose step. So by giving the 10 dose step, what you do, that you give 10 units of the glargine and 5 microgram of the lixisenatide. And then you up titrate based on that I will come. People who are having glargine dose more than that, and those who are already having poor control, other anti-diabetic drug, you can start with the 20 dose step and then up titrate further. How to do the up titration? Depending upon the glucose, more than 100, but less than 140, you add by 2 units. Between 80 to 100, no change. Although in the clinical trial, the titration is more strict. In the practicality, we go little less titer control. Less than 80, we deduct by 2. Timing of it is important. Now we just understand. Iglar Lixi can be injected subcutaneously once in a day, every day single dose, within 1 hour prior to the meal, 1 hour before the meal, right? When, where, which meal? It is preferable that the prendial injection is performed before the same meal every day. It should not be that like today in the breakfast, tomorrow after lunch, and tomorrow. So it is better to go for one type of the meal. And convenient meal time. So it has to be convenient to the patient, so they can choose which meal is they are convenient at home. And in case of the missed dose, it should be injected within the hour prior to the next meal, so they can take the next meal. So weekly dose adjustment based on the median fasting SMPG of the last. You are doing adjustment every week, but depending upon the last 3 days average, you are taking the adjustment. So population elderly more than 65 can be used. And lixisenatide, no adjustment is required. Renal impairment, it is not recommended in the severe renal impairment, less than 30, but up to 30 GFR you can use. Hepatic impairment can be used in a patient with a stable liver disease, but of course you will decompensated liver disease, you won't go for this injection. Pregnancy and lactation is no, so we won't go for that. Just to summarize, it has shown effective HbA1c reduction, once a day dose, combining 2 established agent, the basal insulin as well as the GLP receptor agonist, control both fasting and PP, because basal plus GLP. And weight benefit, lower rate of the additional hypoglycemia, and addresses pathophysiological defect, and better tolerated, and it can be advancement. So I think, thank you very much, and these are the trial which has shown the benefit. Thank you. Yeah.
So thank you very much, Dr. Mishra, for this insightfulness presentation. And it's a very new combination, especially in an Indian perspective, because the drug is too costly. This is the more important concern of an Indian patient. Otherwise, it's very good to control diabetes. There is no hypoglycemia. My question is there any evidence or is there any study to use this drug in type 1?
No, sir. Because GLP receptor agonists are off-label use in type 1 diabetes, and there are some people who have used the long-acting GLP receptor agonists, especially people who are overweight and obese type 1 diabetes. But this injection is mainly for type 2 diabetes, not for type 1 diabetes.
Okay, so maybe in future the study will come and we will also get benefit of this drug. So thank you very much. And ma'am.
I've been very limited, ma'am. As I told you that because we've been discussing, we have been, Dr. Rosentuck and who is the person who is doing the research on this thing, but multiple occasion. But the only problem is that the consistency from the Sanofi has to be there to make it available. Because I write a medicine which is not available across the pharmacy, so it will be difficult. So if they are, they want to this drug to be, which is a beautiful drug anyway. We have had multiple the ad board meeting, discussion on different platform, but the availability has to be there. The patient should not go back. As I will just answer to the sir's question. Cost is definitely is there. Approximately costs around 1700 for a single pen. But when it was compared with the other insulin like the Degludec Aspart and the premix insulin, probably it find a place for them. It is not for everyone, but probably find a place for those injections. So if I'm thinking about initiating IDAC Aspart, so then it might be better because many a time IDAC Aspart might be required twice. Or if a patient is already on the premixed insulin, biphasic Aspart, which is costly also now, and want to shift to the single shot of the injection. So probably this may be an opportunity there. So with the
definitely it's a good choice.
Yeah.
So now any question from the house? So I think, thank you very much.
Yeah. Thank you, sir.
Good presentation. Thank you.
Thank you so much, sir. And I request our chairpersons to kindly felicitate our speaker, Dr. Sunil Sharma, sir. Thank you, sir. I would also like to request Dr. Prakash, sir, to felicitate Dr. U.S. Shilpi, sir. Thank you so much, sir. With that, we conclude today's scientific sessions. We thank you all